Monica. I'm Dr. Monica. So today we'll be starting with the first session of MRB revision, and that is pathology. So the first topic we'll be seeing will be the cell injury. So whenever there is an injurious stimuli to the cell will initially try to adapt itself to its new environment. So that is what is called as cellular adaptation. Usually the cellular adaptations are of four types, which is hypertrophy, hyperplasia, atrophy, and metaplasia. So later on, when this injurious stimuli is still not being relieved, so in that case, this adaptation will further proceed on to cell injury. So initially the injury will be reversible. Later on, it proceeds on to irreversible cell injury and then to cell death. So cell death is going to be irreversible. So there are various types of cell death apart from the conventional cell death, which we had been studying over the years. So apart from necrosis and apoptosis, they had added new types of cell death, which is necroptosis, pyroptosis, and ferroptosis. So when it comes to cell injury, we'll have to know about the most common causes. So usually in MRB exams, usually it is the one-liners and the most common kind of questions which are being asked. So let us concentrate on them as well. So the most common cause of cell injury is going to be hypoxia. So the most common cause of hypoxia as such is going to be ischemia. So whenever there is loss of blood supply, there is going to be less of oxygen supply to the tissue. So that is going to result in the cell injury. And if we see the tissue which is the most sensitive to hypoxia, it is the neurons. So neurons can withstand hypoxia for a maximum of 5 minutes only. And the most resistant tissue to hypoxia is going to be the fibroblastic tissue. Okay, so all of this is going to be MCQs. So let's move on to the cellular adaptations. So like I told, the cellular adaptations are reversible changes. So both physiological and pathological injurious stimuli can result in this adaptation. So starting with hypertrophy. So trophy means there is going to be something related to the size. So hypertrophy means increase in the cell size. So physiological causes of hypertrophy is usually the gym bodybuilders. If you see, their skeletal muscles are quite thick. So the increase in the skeletal muscle thickness is usually a result of hypertrophy. Same goes in for lactational breast, and also in the pathological causes, we can see LV hypertrophy, left ventricular hypertrophy. So in cellular adaptations, the examples are the important ones. Okay, so all of these are examples of hypertrophy. Next, we'll see about hyperplasia. So hyperplasia means there is going to be increase in the number. So hyperplasia is increase in the cell number. So when will the cell increase in number? Only when the cell is capable of division, right? So physiological examples of hyperplasia is going to be liver and bone marrow. Suppose we are cutting the liver. So for a transplant or something, we are removing a part of the liver. The liver can still regrow to its fullest size. So liver is liver hyperplasia is example of this hyperplasia. Then bone marrow as well. If there is a trauma, so blood loss is there. So still the bone marrow will try to replenish its stores, which has been lost now. So bone marrow can undergo hyperplasia. The pathological causes of hyperplasia, the most important ones are endometrial hyperplasia and benign prostatic hyperplasia. So endometrial hyperplasia, why is it important? Because it is going to be a pre-neoplastic condition. So a pre-neoplastic condition which can progress on to endometrial carcinoma. BPH, which is benign prostatic hyperplasia, here both the gland and the stroma of the prostate gland is going to increase in the number. So there is going to be hyperplasia, but it is not a pre-neoplastic condition. Okay, endometrial hyperplasia is pre-neoplastic, while BPH is not pre-neoplastic. So these are some controversial questions. So ideally they should not be asking this, but just in case, if there is a gravid uterus and they ask what type of cellular adaptation happens in a gravid uterus, in that case, both hypertrophy and hyperplasia takes place in a gravid uterus, but it is more of hypertrophy than hyperplasia. While in a pregnant or a pubertal breast, if you see, again, it is both hyperplasia and hypertrophy, but more of hyperplasia. So we can remember it this way. So both the P's are, it is the hyperplasia, P is more, okay? And uterus, you have a P here. So hypertrophy is going to be more. Next, moving on to atrophy. So atrophy is going to be the exact opposite of both this hypertrophy and hyperplasia. So there is going to be decrease in the cell number and also the cell size. So again, examples, we have multiple examples. So whenever, sorry. Um, Sorry. Hello, sir. Sir. Hello. Yeah, come in, sir.
ஸ்டூல தவிர அங்க உட்கார்ந்தா தான் நல்லா இருக்குது. ஸ்டாண்ட் உட்கார்ந்தாலே நல்லா.
Hello.
ஆட்ராய் போறா. சரியாவா? அதுக்கு என்ன பண்ணலாம்? அப்படிங்க. கடிக்கு போதாதா? கடிக்கு போதாதா? போட்டிக்கு யாருங்க போட்டிக்கு அது அதான் வர இதுக்கெல்லாம் வராது.
Let's continue. So we were speaking about atrophy. So in atrophy, the most important example here will be endometrial atrophy. So with hormone withdrawal, the endometrial tissue is going to undergo atrophy. And why is it important? Because this endometrial atrophy is also a preneoplastic condition. So not just hyperplasia, both atrophy and hyperplasia in endometrium is going to result in endometrial cancer eventually. Okay. Then let's see the metaplasia. So metaplasia is another cellular adaptation. Here, there is going to be replacement of one differentiated tissue by another differentiated tissue. And the mechanism by which this happens is a reprogramming of the stem cells. So the best example of this is going to be the Barrett's esophagus. So we all know Barrett's esophagus happens in the lower 1/3 of the esophagus. So with gastric esophageal reflux disease, continuous chronic gastric esophageal reflux disease, the lower end of the esophagus gets irritated. The sphincter will become loose, and the gastric acid will get refluxed into the esophagus. So that will eventually cause an adaptation in the lower 1/3 of the esophagus. So normally the lining of the lower 1/3 of the esophagus is going to be the squamous lining only. But with this metaplasia, it is going to become a intestinal metaplasia, that is columnar epithelium. Along with that, there is going to be presence of goblet cells. So goblet cells is the hallmark of Barrett's esophagus. Okay, goblet cells you see only in the large intestine. So this intestinal metaplasia will have this goblet cells. So normal squamous epithelium becoming this intestinal metaplasia with the presence of this goblet cells is the hallmark of Barrett's esophagus. So what is this importance of this Barrett's esophagus? Again, this is a preneoplastic condition which can progress on to become adenocarcinoma of the esophagus. Usually the squamous cell carcinoma is the most common type of cancer which can occur in esophagus. But in Barrett's esophagus, that is especially the lower 1/3, it is the adenocarcinoma, which is the most common cancer in esophagus, right? Next, we'll see about the reversible cell injury. So once this injury stimulus is not removed, it is progressing, then in that case, the cell will undergo a reversible state of an injury first. So the reversible cell injury, the first organ which was affected by was the mitochondria. So mitochondria, we all know it is the powerhouse of the cell. So when this powerhouse of the cell is being affected, it undergoes dysfunction, it cannot produce ATP. So when ATP is not being produced, the first thing which is going to be affected will be the mitochondria, the membranes. The cell membrane, which is having this NAK ATPase pump. So the sodium potassium ATPase pump will undergo failure without the ATP. So what will happen? The sodium will start coming into the cell. So along with the sodium influx, water will also come into the cell, causing the cell to swollen up. Okay. So this is what we call as cellular swelling or hydropic degeneration, or the hydropic change or vascular degeneration. So this is going to be the first morphological change which we see in a reversible cell injury. So other than this membrane, the endoplasmic reticulum and the nucleus can also be affected. So there will be decrease in the protein synthesis and there will be nuclear chromatin clumping happening. And one other thing is the presence of this myelin figures. So myelin figures are nothing but these are lamellated structures like whorls will be appearing. So these are going to be composed of the phospholipids which are present in the membrane, along with that calcium which came into the cell, calcium influx. So the calcium and the phospholipids present in the membrane are going to form some whorl structures called as myelin figures. So the myelin figures start to be formed in the reversible cell injury. Later on, they'll increase in the irreversible cell injury. Okay, so two things important here will be the first thing, mitochondria is the first organelle which is being affected, which is going to result in the membrane, which NAK ATPase pump failure, causing cellular swelling. Okay. Next is irreversible cell injury. In irreversible cell injury, both the ends will be affected severely. So the mitochondria and the membrane are going to be damaged very severely. So when the membrane is being damaged, there is going to be influx of the calcium. So when calcium comes, we all know it is going to activate many enzymes. So one such enzyme which is going to be activated is the endonuclease enzyme. So as the name suggests, it is going to cleave the nuclear material. So that cleaving of the nuclear material is going to result in a series of changes, which is a sequential change basically. So the first change which happens in the nucleus is going to be the pycnosis. So pycnosis is nothing but nuclear chromatin condensation. Suppose this is the normal cell, normal cell, and this is the size of the nucleus. The size of the nucleus is going to get decreased and condensed. So pycnosis is nothing but nuclear chromatin condensation. The next thing which will happen will be the karyorrhexis. So karyorrhexis means it is just fragmentation. So the nuclear material will just fragment. Then comes karyolysis. So lysis is breaking. So the cell will nucleus will undergo lysis and it will get dissolved. Eventually the nucleus itself will be lost. Okay. So these three changes are characteristic of a particular type of cell death, which is the necrosis. Okay. When irreversible cell death, irreversible cell injury is going to result in cell death. With this kind of nuclear changes, it will result in the necrosis. Okay. Apart from that, mitochondria, whenever the mitochondria is being damaged, both the cell type of cell death, which is the necrosis and apoptosis, can result. So we'll be reading about that sooner. So we all know that the intrinsic pathway of apoptosis is going to be also called as the mitochondrial pathway. So when mitochondria is being affected, apoptosis is being triggered by the intrinsic pathway. And then with this decrease in the ATP formation with the damage to the mitochondria, necrosis is going to be triggered. Okay. Now let's move on to the cell death, which is starting with necrosis. So necrosis, three important points. Always remember, necrosis is always pathological. Necrosis is always pathological and it is always associated with membrane damage. So whenever there is membrane damage, obviously the inflammatory cells will come to clear up the debris which is being made. So it is always associated with inflammation. So pathological causes. So this is the main important points about necrosis. Coming to the patterns of necrosis, we have first pattern, which is the coagulative necrosis. So this coagulative necrosis is the most common type of necrosis. So whenever there is ischemia, loss of blood supply, the tissue which is being supplied by the blood vessel is going to undergo this type of necrosis, which is coagulative necrosis. So everywhere ischemia is going to result in coagulative necrosis, except in will result in this coagulative necrosis, which is called as the infarct. So infarct is nothing but the coagulative necrosis, which we see in the solid organs. So infarct is formed in every organ except in the brain, which is going to undergo liquefactive necrosis whenever there is ischemia present. Okay. So ischemia will result in coagulative necrosis, except in brain, where it is going to result in the liquefactive necrosis. So infarcts are of two types. Again, important MCQs here. So white infarct and red infarct. So white infarcts are the ones which are going to be wedge shaped. So this wedge shaped infarcts are going to be seen in those solid organs where there is going to be end arterial blood supply. That is, it is the final blood supply. There is no other blood supply compensating for that organ. Okay, so solid organs having this end organ arterial supply are going to be having a white infarct. So examples will be heart and kidney. While red infarct is the one that where the infarct is going to be present in loose tissues. So lung, if you see, this is spongy tissue, right? So lung and liver. Again, here it is the exact opposite of white infarct criteria. So organs with dual blood supply, like liver and lung. So liver, we have hepatic circulation and then portal circulation. While in lung, we have pulmonary arteries and bronchial arteries supplying it. So whenever there is this dual supply, and especially in loose connective tissue, it will result in a red infarct. So the examples of white infarct and red infarct are important. So coming to one other thing, Zenker's degeneration. So Zenker's degeneration, it is a type of coagulative necrosis only, which is going to be seen in certain skeletal muscles, especially the abdominal skeletal muscles, and it is seen in typhoid condition. Okay. The next type of necrosis will be the liquefactive necrosis. So as the name suggests, the organ itself is going to become liquefied. Okay, so it is going to become like a liquid. So one thing I forgot to mention, in coagulative necrosis, even though there is going to be this necrosis, the cell architecture is still going to be maintained, the tissue architecture. So the outlines of the cell is going to be seen. So that will give a tombstone kind of an appearance. So tombstone appearance is going to be seen in coagulative necrosis. While in liquefactive necrosis, as the name suggests, it is liquid-like. So liquid is not going to hold its shape, right? So the tissue architecture is not going to be preserved in liquefactive necrosis. So examples of liquefactive necrosis is going to be when there is any infection. So infection will rapidly cause enzymatic stimulation, which will eat up the tissue. Okay, so hydrolytic enzymes will be stimulated. So that is the reason why ischemia in brain is going to result in liquefactive necrosis rather than coagulative necrosis, because brain is going to be rich in these hydrolytic enzymes. And the most common cause of this liquefactive necrosis is the bacterial infections. Next is the caseous necrosis. Caseous necrosis, caseous means cheesy in appearance. So it is a gross appearance. So whenever there is a caseous necrosis, there is going to be some white cheesy kind of material. So it is a combination of both coagulative and liquefactive necrosis. And the most important cause of caseous necrosis in our country is going to be tuberculosis. So tuberculosis, when we are discussing tuberculosis, let me go on to the histomorphology of tuberculosis as well. So in tuberculosis, we are going to have something called as a granulomatous inflammation. So granulomatous inflammation is a type of chronic inflammation only. So we all must have drawn this diagram in our second years in that circle, if you remember. So the central part of this granulomatous inflammation is going to be this caseous necrosis. Okay, this pink material which is having no shape at all is the caseous necrosis, surrounding which we are going to have some kind of epithelioid macrophages. So epithelioid macrophages are modified macrophages. So they are going to have this slipper-shaped nucleus. So epithelioid macrophages are surrounding it. Then comes a collar of lymphocytes. So along with this, there is going to be presence of giant cells. So these giant cells are called as Langhans giant cells. So Langhans giant cells with the collar of lymphocytes, with the epithelioid macrophages and central caseous necrosis is as the name suggests, this type of necrosis is going to happen in places where there is going to be lots of fatty tissue. So the breast and the omentum are examples. So suppose there is a trauma or a pancreatitis case, because of the enzymes, this fat will undergo necrosis. So once fat undergoes necrosis, calcium will come to a deposit on this saponified fat and cause the formation of this chalky white deposits. It can be seen grossly as well. Next is the fibrinoid necrosis. So remember, fibrinoid necrosis is a type 3 type of hypersensitivity reaction. So type 3 hypersensitivity, usually it is associated with vasculitis kind of pattern. So in vasculitis, you are going to have around the vessel, there is this fibrinoid necrosis. Some pinkish material will be seen surrounding this vessel, which is called as the fibrinoid necrosis. And examples of this will be the same examples of the type 3 hypersensitivity, which is SLE, RHD, which is rheumatic heart disease, and then polyarteritis nodosa, then malignant hypertension. So all of this we are going to have fibrinoid necrosis. Next is gangrene. It's a surgical clinical term. Basically, we would have seen in surgery postings. So we have two types of gangrene: dry gangrene and wet gangrene. Dry gangrene is going to result from ischemia. So it is going to be a type of coagulative necrosis. While wet gangrene is when there is superadded infection on it. So what will be the type of necrosis we see in that? It will be liquefactive necrosis. Now we had seen about necrosis. Next, we'll move on to the second type of cell death, which is apoptosis. So apoptosis literally means falling off. Okay, so it literally means falling off, and apoptosis can both be both physiological and pathological. Necrosis was only pathological, while apoptosis can be both physiological and pathological. So during organogenesis, and also when there is involution of the hormone dependent tissue, like post pregnancy, the uterus has to go back to its normal size. So all of this is going to happen via apoptosis. And pathological examples, we have many examples of apoptosis, but the most important one here will be the viral hepatitis. Why? Because there is going to be the formation of this Councilman body or apoptotic body. So Councilman body is nothing but an apoptotic body only, which is seen in viral hepatitis. Okay. So necrosis, apoptosis is going to be the exact opposite of necrosis. So here, what will happen if the cellular swelling was there in necrosis? Here it is going to be cellular shrinkage. Then there was membrane damage associated with necrosis, while there is no membrane damage here in apoptosis. So when membrane is not damaged, obviously there is not going to be any inflammation here. And then if you see, the most important thing about apoptosis is this caspase activation. So the hallmark of apoptosis is going to be caspase activation. Okay. So these kind of characteristic words like hallmark, markers, like characteristic features, pathognomonic features, these are quite important for MRB. So remember, the hallmark of apoptosis is going to be caspase activation. So we have two types of caspases in apoptosis, which is the initiator caspases and execution caspases. So in the initiation phase itself, there is two processes which is happening. The first one will be the intrinsic pathway, which is the mitochondrial pathway, and then the extrinsic pathway or the death receptor pathway. So the caspases involved in each of these phases is going to be different, and these are very, very important MCQs. Okay. So in the initiator caspases, in the intrinsic pathway especially, it is going to be caspase 9, while it is going to be caspase 8 and 10 for extrinsic pathway. So just remember it this way. Extrinsic is E and X, right? So E for 8 and X looks like Roman letter 10. So this is 10. So 8 and 10 are for extrinsic pathway, while the number in between 9 is the intrinsic pathway. These three are the initiation caspases, while the executor caspases are caspases 3, 6, and 10, out of which caspase 3 is the most important one. Okay. So we all know apoptosis was initially called as a programmed cell death. Why is it called as programmed cell death? Because it is being regulated by certain set of genes. That is a regulated process. So that is why it was called as programmed cell death. So what are the genes which are controlling this apoptosis? We have pro-apoptotic factors, anti-apoptotic factors, and then cell injury sensors, which is stress sensors. So pro-apoptotic factors, again, very important MCQs here. So pro-apoptotic factors are BAX, and BCL excess, while anti-apoptotic factors are all the CLs, basically BCL2, BCL-XL, and then MCL1. So CL is there. So the only CL which is seen in the pro-apoptotic factors is the BCL excess. Okay, so remember it that way. Then the stress sensors are the BIM, BIT, BAD, PUMA, and NOXA. So these are important high yield points here. The first person to describe the principle of apoptosis was Carl Vogt. Then coming to the mechanism of apoptosis, I'm not going into the details here. So initiation pathway, I already told it is going to be intrinsic mitochondrial pathway or the extrinsic death receptor pathway. So the death receptors are nothing but CD95 and FAS. So when these get activated, it is going to result in the extrinsic pathway of apoptosis. When the mitochondria is going to be activated, that is going to result in the intrinsic pathway. So in the intrinsic pathway, I want to stress one thing. there is going to be this cytochrome C, which is getting extruded from the mitochondria. So when cytochrome C exits from the mitochondria and enters the cytoplasm, it is going to combine with something called as apoptosis activating factor. So APAF1 is going to be combining with the cytochrome C, and together these two are called as is forming the apoptosome. Okay, so apoptosome is the combination of cytochrome C plus APAF1. So this will result in the conversion of pro-caspase 9 to active caspase 9. So caspase 9 was the intrinsic pathway caspase. So when the initiation phase caspases, that is 8, 9, and 10 get activated, they will finally activate the execution caspase, which is 3, 6, and 7. And when this execution caspase get activated, it is going to activate and again many enzymes, the most important one of which is the endonuclease. So when endonuclease is getting activated, it is going to cleave the nucleus. So it is going to form internucleosomal cleavage, which results in the nuclear chromatin condensation. Remember, in necrosis also, the first stage in the nuclear changes was nuclear chromatin condensation, which is otherwise called as pycnosis. But in apoptosis, it stops with the pycnosis only. Okay. So the most characteristic feature of apoptosis is this nuclear chromatin condensation, which is resulting as a result of this internucleosomal cleavage. Okay, hallmark was caspase activation, while the characteristic is this nuclear chromatin condensation. Apart from that, this execution caspases is also going to form the apoptotic body. So the apoptotic bodies are nothing but whatever material is going to be digested, the entire cell is going to be still membrane bound. So membrane bound bodies are going to be found. So this membrane is not going to be damaged. That is why inflammation is not present in the apoptosis. So these membrane bound organelles, with or without the nucleus, is going to form this apoptotic body. So what happens in this apoptotic body is that normally if you see a cell membrane, the phosphatidylserine, it is going to be present in the inner layer of the cell membrane. But in this apoptotic body, there is going to be flipping. So this phosphatidylserine, which is present in the inner leaflet, is going to come out to the surface. So when it comes out to the surface, it is going to attract the macrophages, which will come and eat up this apoptotic body. So this mechanism by which these macrophages eat up this apoptotic body is termed as efferocytosis. So this again is a new concept which has been included in the Robbins. So do note this down. Efferocytosis is macrophages phagocytosing this apoptotic body. Okay. So how do you detect this apoptosis? So already we had seen there will be cellular shrinkage along with the nuclear chromatin condensation. Apart from that, another important MCQs are coming here. So the marker of apoptosis is going to be a stain called as annexin 5. So annexin 5 stain can highlight apoptosis. So that is the marker of apoptosis. But if they ask molecular marker of apoptosis, it is CD95 or FAST. So CD95 or FAST was the part of the death receptor, remember? So it is the extrinsic pathway of the initiation phase. So CD95 or FAST is the molecular marker of apoptosis. Then if you see the cell under gel electrophoresis, you do a gel electrophoresis. If you see a step ladder kind of a pattern like this, it is going to indicate apoptosis. While if it is a tongue-like smear pattern, like a peripheral smear, you see, so tongue-like smearing pattern is going to be characteristic of a necrosis. Okay, so the step ladder pattern is actually because of the internucleosomal cleavage which is happening. So step ladder pattern is in apoptosis, while smearing pattern is in necrosis. So free radicals are one of the most important causes of cell injury. So free radicals are nothing but these are extra unpaired electrons, single unpaired electrons that are circulating in the outer orbit. So these are quite unstable and they are autocatalytic, meaning they can produce more and more of free radicals, and also they'll be lysed easily as well. So whenever there is this oxygen, the oxygen is going to get converted into the free radical superoxide. So superoxide is represented by the dot above the oxygen. Okay, so superoxide is going to be formed with the whenever there is some injurious stimuli to this oxygen molecule. So superoxide is formed. Superoxide will dissociate itself. It will get dismutated itself by with the help of the enzyme superoxide dismutase. So SOD is superoxide dismutase. So this superoxide dismutase is going to convert the superoxide into hydrogen peroxide. When this hydrogen peroxide is being formed, it can undergo two things. Firstly, it can get converted into hydroxyl free radical, which is OH. So hydroxyl is the most potent free radical. Okay, the most potent free radical is going to be hydroxyl free radical. And this conversion utilizes iron. So this reaction utilizes iron and it is called as the Fenton's reaction. So Fenton's reaction is nothing but with the usage of iron, hydrogen peroxide gets converted into hydroxyl free radical. So what actually happens when free radicals are being produced? So firstly, it will attack the membrane. So cell membrane is being attacked. It will cause the peroxidation of the phospholipids present in the membrane. So that will result in the damage to the membrane. Then apart from that, there is going to be lots of mutations which are happening, then protein misfolding, endoplasmic reticulum stress. So eventually it is going to result in cell injury and cell death. So when these free radicals are so harmful, how do you remove these free radicals? Usually we have antioxidant mechanisms for that in our body itself. So when you consume vitamins like vitamins A, C, and E, these are antioxidant vitamins which are helpful in removing the free radicals. Apart from that, there are enzymes like the superoxide dismutase. So superoxide dismutase, it resulted in the formation of hydrogen peroxide, right, from the superoxide free radical. So that is the first enzyme which is helpful in the removal of free radical. Then this hydrogen peroxide with the Fenton's reaction is going to get converted into hydroxyl 1. And apart from that, this hydrogen peroxide, it can be broken down by two other enzymes. Firstly, it is catalase enzyme. So catalase enzyme is going to break hydrogen peroxide into water and oxygen, while GPX4 is glutathione peroxidase. So glutathione peroxidase is going to break both the hydrogen peroxide and the hydroxyl free radical which were formed into water. Okay. So these three enzymes, superoxide dismutase, catalase, and glutathione peroxidase, are enzymes which are acting as antioxidants. Then we also have transport proteins like transferrin, ferritin, and lactoferrin and ceruloplasmin, which are again antioxidants. So if you remember, for Fenton's reaction, I had written both ferrous and copper. So when this excess ferrous and copper is being utilized or it is being transported with the help of these transport proteins like transferrin, ferritin, lactoferrin. So these three are for iron, while the ceruloplasmin is for copper. So whenever they are taken up, they are not available for the formation of this hydroxyl free radical because of the Fenton's reaction. Okay. So other forms of cell death, I'm just going to give the important points regarding this. So till now we will be thinking that there were only two types of cell death, necrosis and apoptosis, but that is not the case. Newer forms of cell death have come up now. So we were thinking apoptosis was the only programmed cell death. No, other than necrosis, whatever cell deaths have we have found now, all of them are programmed cell death only. Each of them have a specific name. So remember that at least. So iron-induced programmed cell death is going to be called as ferroptosis. So ferro for iron. So ferroptosis is iron-induced cell death. Then we have caspase-dependent programmed cell death itself. Two types of caspase-dependent programmed cell death are going to be there. One thing we have already seen, which is apoptosis. And the other caspase-dependent programmed cell death is going to be pyroptosis. So pyro means heat. So heat is related with fever. Okay. So fever is going to be there. That is why it is called as pyroptosis. So as the name suggests, pyro plus ptosis, apoptosis. Okay. So this the difference in between pyroptosis and apoptosis is that the caspases which are involved are different. So in apoptosis it was caspase 3, 6, 7, 8, 9, and 10, while in pyroptosis it is caspase 1, 4, 5, and 11. Okay. So this caspase 1 is the one which is responsible for activating interleukin 1. And this interleukin 1 is the most important interleukin which is responsible for causing fever. Okay. Then other forms of cell death, if you see, we have necroptosis and pyroptosis. So both of this, if you see in this necroptosis, it is a hybrid of both necrosis and apoptosis. So what part of necrosis does it imitate? It is the morphology. So morphologically, it is going to mimic the necrosis, but pathway wise, it is going to mimic the apoptosis. So it is hybrid of both necrosis and apoptosis. So pyroptosis, we have already seen, it is, even though it is having caspase dependent mechanism, that is how it is going to mimic the apoptosis. But morphologically, here again, pyroptosis is also going to have necrosis kind of a morphology. Okay. So morphology of necrosis is going to be seen in necrosis, then pyroptosis and necroptosis, while caspase activation is going to be seen in apoptosis and pyroptosis. Iron-induced programmed cell death is going to be ferroptosis. Okay. Then moving on to autophagy. So as the name suggests, auto means self, phagy means eating. So self-eating, that is cell cannibalization. So whenever the cell is in a very stressful kind of a situation that is not going to escape from this hurtful stresses, in that case, it will try to eat up its own content to survive. Okay. So it is going into the dormant phase, but just eating and surviving by its own contents. So that is called as autophagy. And the mechanism of this autophagy was discovered by this Oshinori Osumi, the scientist Oshinori Osumi, and he won the Nobel Prize for the same. Okay. And the important organelle involved in this autophagy is lysosome. So lysosome has this hydrolytic enzymes which helps in digesting the contents of the cell. Okay. Lysosome is the organelle involved in autophagy, while mitochondria is the main important thing which was involved in the cell injury. Okay. Reversible cell injury. Moving on to intracellular accumulations. Under intracellular accumulations, we have many pigments, lipids, glucose, and proteins which can get accumulated and result in the cell injury. Okay. So starting with pigments, we'll see carbon. This is the most common exogenous pigment. So carbon is black in color. So during dust inhalation, so coal, it can result in coal workers pneumoconiosis. The most common exogenous pigment is the carbon. Then moving on to melanin, it is being produced by melanocytes and which is responsible for our skin color, right? So this melanin is the endogenous black pigment. Exogenous black pigment is the carbon. Endogenous black pigment is the melanin. Okay. So whenever in intracellular accumulation, it is usually the special stains which are very, very important again. So the special stain for melanin is going to be Fontana-Mason stain, which is going to stain melanin black in color. Then we have small stain, which can stain melanin in emerald green. Then we'll move on to homogenesic acid. So there is going to be accumulation of this homogenesic acid in a autosomal recessive condition called as alkaptonuria. So in alkaptonuria, there is going to be deficiency of the enzyme homogenesate oxygenase. So when this enzyme is deficient, homogenesic acid tends to accumulate, and it also gives a blackish kind of pigmentation, especially in tissues like tendons and also in ear cartilages and also in conjunctiva. So that is what we call as ochronosis. So more in detail of this about this alkaptonuria, I'll be studying in biochemistry. Next, the most important pigment, lipofuscin. So lipo means lipid. Fusion is coming from it is a fuscus is a brown pigment basically. Okay, so fusion stands for brown. So it is going to be an yellow brown kind of a pigment. The most important thing about it is the telltale sign of free radical injury. Why is it called as the telltale sign of free radical injury? Is that the origin of this lipid in this lipofusion is going to be derived from the cell membrane. How? Cell membrane had phospholipid, right? So whenever there was cell injury, I told the membranes are going to be damaged. So there is going to be lipid peroxidation because of the free radical injury. So when this lipid peroxides are formed, it is going to eventually form this lipofusion pigment. Okay. So this because of this lipid peroxidation, this, lipofusion is being formed. So it is a telltale sign of this free radical injury. The other names for this pigment is going to be lipochrome and wear and tear pigment. And they can also ask the question as brown atrophy or senile atrophy as such, because with age, there is going to be lots of accumulation of cell injury. So there is going to be lots of accumulation of this lipofusion as well. Coming to hemosiderin. So hemosiderin, as the name suggests, siderin is for iron. So there is going to be excess iron storage. So whenever iron is getting accumulated, it is going to result in cell injury again. So it can either because the accumulation of iron can either happen because of some trauma like a contusion, or it could be because some inherited condition like hemochromatosis. So hemochromatosis is an inherited condition wherein there is going to be this accumulation of iron pigment. So it is going to be a triad of symptoms. So where iron can either accumulate in the pancreas, liver, or in the skin. So each of these places, it is going to cause dysfunction. So liver, it is going to cause micronodular cirrhosis. In pancreas, it is going to affect the islets of Langerhans. That is going to result in diabetes mellitus. And then skin also can get a slate gray kind of a pigmentation because of this hemosiderosis. Okay, hemochromatosis. So remember this most important thing. Whenever you are seeing iron, it can be highlighted with the special stain Pearl's Prussian blue. Pearl's Prussian blue for iron. Okay, always remember this. So this Pearl's Prussian blue, as the name suggests, it is going to stain iron blue in color. Next is copper. So whenever we think of copper, the first disease which comes to our mind is Wilson's disease, right? So copper is a brown pigment again, which is stored in excess during the Wilson's disease. So Wilson's disease, we all know it is ATP7B gene defect. Here again, it is a triad. So the triad is going to be deposition of copper in certain organs. So in liver, it is going to result in all kind of patterns, basically acute hepatitis, chronic hepatitis, fulminant hepatitis, cirrhosis. So all patterns, it is called as whole spectrum. So whole spectrum liver disease is going to be present. Apart from that, there is going to be deposition of copper in the eyes, especially in the Descemet's membrane. So Descemet's membrane is present in the cornea. So Descemet's membrane in the cornea is going to deposit, and it is going to produce something called as KF ring or Kayser-Fleischer ring. So KF ring is seen in Wilson's disease, which is excess accumulation of copper. And apart from that, this copper can also accumulate in the basal ganglia of the brain, especially in the putamen region. And in putamen, it is going to cause atrophy. Okay, so this is the classical triad of Wilson's disease. So what is the special stain used for copper? We have two stains which start with the letter R. Copper for R, okay? The last letter of copper is R, so remember it that way. So it is rhodonine stain and rubianic acid. So rhodonine stain is going to stain copper brown. So copper is also a brown color pigment. With the special stain also, it is going to be stained brown in color, okay? So rhodonine and rubianic acid is for copper. First Prussian blue is for iron. So do not confuse it with the orthene stain. People tend to answer it this way. Orthene stain is not for copper. It is actually for copper associated protein, which is the ceruloplasmin. Ceruloplasmin is nothing but the copper carrying transport protein, right? So that can be highlighted with the orthene stain and not copper. So moving on to the accumulation of lipids. So here again, I just want to tell the special stains only. So the special stain for lipid is going to be oil red O. So red comes in the name. So it is going to stain fat red in color. Sudan black B is going to stain black in color. Okay. And lipids can be stained only in a frozen tissue, fresh frozen tissue. Okay. Once it is fixed, it cannot be stained with these stains. Next, glycogen. So glycogen can be deposited when there is kind of glycogen storage diseases or even in excess diabetes mellitus. So it can result in something called as Armani-Epstein lesion. So in diabetes mellitus, in the kidney, if you see, the proximal convoluted tubules can have some subnuclear vacuoles. So those vacuoles are as such composed of this glycogen only. So after reabsorption, it is going to stay in that PCT, proximal convoluted tubule. So that is what we call as Armani-Epstein lesion. So Armani-Epstein lesion, where do you see it? You will see in the proximal convoluted tubule in diabetes mellitus. The special stain for glycogen is going to be periodic acid shift stain, which we call it in short form as PAS stain. So PAS stain is for glycogen, but PAS stain stains n number of things. Okay, it is not specific for glycogen. It can stain many other things. One such thing is fungus also. Okay, fungus can also be stained with PAS. But if you put diastase, diastase is an enzyme which can be seen in our saliva. So if you put diastase enzyme, it is glycogen is going to be sensitive for diastase. Okay, while the rest of the things which is stained by PAS is going to be resistant to diastase. Okay, so glycogen, what you have to tell is it is PAS positive, diastase sensitive, right? So with PAS, it is going to stain magenta pink in color. Coming to the accumulation of protons, so two protons are very important. First one will be the Mallory-Denk bodies. I hope you have heard of this. It's a very important question, even asked many times in NEET PG as well. So Mallory-Denk bodies are also called as Mallory alcoholic hyaline. Okay, so these are nothing but intermediate filaments. So the composition of this Mallory-Denk bodies is intermediate filaments, which is cytokeratin 8 and 18. Cytokeratin 8 and 18, which are basically intermediate filaments, is the composition of this Mallory-Denk bodies, usually seen in alcoholic liver disease. Not specific for alcoholic liver disease, but most commonly seen in alcoholic liver disease. That is why it is given the other name as alcoholic hyaline. Then the other protons which can be accumulated is the Russell's or the Dutcher's body. So Russell body, Dutcher body, favorite question during our UG time as well. So these are protein accumulations basically composed of immunoglobulins. So immunoglobulins which are going to be produced in excess in multiple myeloma. So multiple myeloma is a plasma cell dyscrasia. So there is going to be some neoplasm of the plasma cells. So their plasma cells will in turn produce lots of immunoglobulin, which are going to be accumulated in the plasma cells. So if in the plasma cells, it is going to be accumulated in the intracytoplasmic location, it is called as Russell body. While if it is in the intranuclear location, it is called as Dutcher body. Okay, intranuclear Dutcher, intracytoplasmic is Russell. And when there is lots of this Russell body collection, it is going to be filling the cytoplasm of the cell and making the cell look like a bunch of grapes. So that grape-like appearance of the cell is called as Mott cell. So Russell body, Mott cell, Dutcher bodies, all of these are going to be seen in multiple myeloma. Next, coming to pathological calcification, again, very important. So pathological, as the name itself suggests, there is going to be some abnormal deposition of the calcium salts in tissues. So we have two types of calcification, which is dystrophic calcification and metastatic calcification. So remember D for D. So whenever there is calcium deposition in dead and degenerating tissues, it is dystrophic calcification. Okay. And here it is the serum calcium levels are going to be normal. While metastatic calcification is, it will deposit in normal tissues, but the serum calcium levels are going to be elevated. Okay. The examples of each of this is going to be important again. In dystrophic calcification, just remember D for D, right? So dead and degenerating tissue. Apart from that, remember Samoma bodies. So Samoma bodies is nothing but these kind of lamellated deposits of calcium. So this kind of whirling onion skin kind of pattern will be seen. So that these are called as Samoma bodies. It is an example of dystrophic calcification. So Samoma bodies are seen in specific conditions, which are again MCQs. So Samoma bodies are seen in any kind of papillary tumors. So papillary carcinoma of the thyroid, then papillary carcinoma of the kidney, and also serous adenocarcinomas, which has this papillary excrescence kind of a pattern. So serous adenocarcinomas of the ovary. Then apart from that, meningiomas and mesotheliomas. These are all examples of having this Samoma bodies. And another important thing, special stain for calcium. So two stains we have. First one is the von Posa stain, which will stain the calcium black in color. Then we have alizarin red, which will stain calcium red in color. No other go, you have to remember these special stains, which are very important questions. Coming to metastatic calcification. So metastatic calcification, we have seen it is because of the elevated levels of serum calcium levels, right? And where does this calcium go and deposit? It is going to deposit in normal tissue. So which is the most common organ in which this calcium gets deposited? It is lung alveoli. Okay, lung alveoli is the most common tissue in which this calcium gets deposited. The first organelle in which in the cell also, which organelle is the one where this calcium gets deposited first is the mitochondria. Okay, so mitochondria, this is the second time we are seeing this, right? Because the first change in cell injury is going to happen in the mitochondria. Similarly, metastatic calcification, the first organelle in which the calcium deposits is the mitochondria. This is the rule, but except in the kidney. In the kidney alone, the calcification will start with the basement membrane. Okay. And when you see, when I told it is because of hypercalcemia, this metastatic calcification is happening, right? So what is the most common cause of this hypercalcemia? So it is hyperparathyroidism. So hyperparathyroidism is the most common cause. And if they ask the most common cause of this hyperparathyroidism, it is parathyroid adenoma. So parathyroid adenoma is a benign tumor of the parathyroid. So it is not parathyroid hyperplasia, it is parathyroid adenoma, which is the most common cause of this hyperparathyroidism. Right? Then this one may be asked, tetracycline labeling, double labeling index is used for. So it is used for, tetracycline is used for calculating the bone mineralization. Moving on to cellular aging, this is the most common cause of this cellular aging is cell injury. So when a cell ages, the person will age. Okay, so cellular aging, most common and accepted theory for cellular aging is free radical injury. Okay, so with accumulated cell injury, the damage is going to be accumulated. Eventually, the cell will die and it loses its function as well. So here, okay, I'll tell this. So we have something called as telomeres. So telomeres are nothing but if this is the chromosome, the ends of the chromosome are going to be called as the telomeres. So with each cell division, these telomeres are going to be lost. Okay. So after about 60 to 70 cell divisions, the cell is not going to have any more of this material. So cell will eventually have to undergo death. Okay. So this limit of 60 to 70 cell divisions is called as the Hayflick effect. Hayflick effect is for cellular senescence, which is 60 to 70 cell divisions, after which the telomeres are being lost. So after that, there is the cell will die itself. But there is an enzyme called as telomerase. So this telomerase enzyme is actually going to prevent this shortening of the telomeres. So basically, it is going to prevent the cell from dying, right? So normally, this telomere is not active in normal cells. If you see, only in the germ cells and in the stem cells, it is active. Germ cells, it is highly active. And then the stem cell, it still has some kind of telomerase activity. In somatic cells, it doesn't have this telomerase activity. But what happens is that in cancer cells, they acquire this telomerase activity and they attain the state of immortality. So this telomerase enzyme is also called as immortality gene. Okay, telomerase is the immortality gene. So finally, I had given the recap of all the special stains at the last page of it. So next, let's move on to the next topic, which is inflammation. So inflammation, here again, the signs of inflammation is repeated as MRB question. So signs of inflammation, we have 5 signs basically: rubor, calor, dolor, tumor, and functio lesa. So this rubor rubor means redness, calor means heat production, dolor is for pain, and tumor is for swelling. So these first 4 signs were described by the scientist Celsus. While the next sign, which is the functio lesa, that is loss of function, is was discovered by the scientist Rudolf Virchow. So Rudolf Virchow, he is the father of modern pathology. This again is a question. The father of modern pathology is Rudolf Virchow. So based on his name only, we have many other things like Virchow's node, which you have read in surgery, Virchow's triad, and all these things. Okay. So what is Virchow's triad? Just write it here. So Virchow's triad is for thrombosis. So what are the features of this Virchow's triad is, firstly, there is going to be disturbance in the blood flow. So it could be either stasis or turbulence, which is then going to result in endothelial injury. Sorry. Okay, where were we? So this Virchow's triad for thrombosis is going to have endothelial injury, and then first was this alteration in the blood flow, which is this stasis or turbulence, which is going to cause this endothelial injury. Okay, the stasis will come here. Okay, so this forms this Virchow's triad, which is resulting in the formation of the thrombosis. Next, we'll move on to acute inflammation. So we are all familiar with the steps with the acute inflammation. So starting is whenever there is some injurious stimulus, so there is going to be recognition of whatever the inciting agent. Okay, so recognition is going to take place with the help of receptors like toll-like receptors. So after recognition, next comes the vascular events. So vascular events, the first vascular event which happens in acute inflammation is vasodilatation. So vasodilatation, the vessel will initially dilate with the help of preformed mediators like histamine. Okay, then after vasodilatation, next comes vascular permeability. So the vessels will start becoming leaky, so that the WBCs which were present inside the vessel will come out into the extravascular space. Okay, so there is going to be increase in the vascular permeability, and once the vessels become leaky, there is going to be what do you call that as? It is going to be very thick. The blood is going to become very viscous. So that is going to cause stasis. Okay. So vasodilation, vascular permeability, stasis. These are the three steps of vascular events happening in acute inflammation. Then for vascular permeability, we have three mechanisms. First one will be the endothelial contraction. So the endothelium, which is going to be continuous like this, it is going to create space between the endothelium. It will contract and let the cell pass. So that is the most common mechanism, and that is endothelial contraction. Next, the endothelium can be directly damaged, and through the endothelium itself, the cell can pass. Another thing is transcytosis. The endothelium is not damaged. It is via an organelle called as vesicovascular organelle. This WBCs can pass through the endothelium. Three mechanisms are there. You just remember endothelial contraction, which is the most common mechanism of vascular permeability. Next, coming to the cellular events. So initially, what happens inside the vessel? So both of it will be happening simultaneously. So in cellular events, first thing will be the margination. So RBCs will be usually present in the central plane, and WBCs will be in a more peripheral location. So margination is when this WBCs go to a much more peripheral location and go very much near to the vessel wall, that is the endothelium. So this is the endothelium I had marked. So these are the RBCs. These green ones are the WBCs. So WBCs had gone to the margins of the vessel, which is called as margination, which is the first step. The next step will be rolling. So rolling means it is just tumbling over, right? So it is not attaching, it is just attaching and detaching to the endothelium. So just like that, it is going attaching and removing. So this is caused by selectants. So remember, selectants are responsible for rolling in acute inflammation. So we have three types of selectant: L-selectin, E-selectin, and P-selectin. L stands for leukocyte, which is the WBCs. E stands for endothelium. P stands for platelet. Okay. So based on them, based on the name, these selectants are present on the corresponding cells. Okay. Then after that, we have addition. Addition means there is going to be strong addition. So there is going to, rather than attaching and detaching, the WBCs are going to be strictly attached to the endothelium. So that is addition, and that is going to happen via integrins. So integrins are responsible for addition, while selectants were responsible for rolling. Once the WBCs get attached to the endothelium, the WBCs then migrate to the migrate through the endothelium. It crosses the basal membrane and comes out. So this transmigration is also called as diapedesis, and diapedesis is caused by this CD31 or PCAM1 expressed by the endothelium. So endothelium is going to express CD31 or PCAM, which is going to be responsible for this diapedesis of WBCs. So once WBCs pass through the endothelium and come out, they have to reach the location where this injurious stimulus is actually present. So this kind of unidirectional movement, which is along the gradient, is going to be called as this chemotaxis. So once this chemotaxis happens, WBCs reaches the site of the injurious stimulus. Okay. So here the chemotactic agents are important. So what is actually calling this WBCs? So there are certain agents which are released, which cause this attraction of this WBCs. So firstly, the bacterial product or whatever the inside itself is going to cause. Later on, there is some mediators which are being released in response to this injurious stimuli. So those again are responsible for chemotaxis. So the three important things are LIC. So LIC is responsible for chemotaxis. So L stands for leukotriene B4, I stands for interleukin 8, and C stands for complement factor 5A. Okay, so LIC, remember it this way. So these three are responsible for chemotaxis. Then once the WBCs have reached the site of the injurious stimuli, what happens is the WBCs have now, it has to now go and eat up this injurious stimuli. So this eating up is called as the phagocytosis. So here again, there is one scientist name you need to remember, Elie Mechnikov. So Elie Mechnikov is the scientist who coined the term phagocytosis. Okay. So this the WBCs will then throw pseudopodia around the inciting agent, and then it will engulf it. And after engulfing it, the lysosome present in the WBC is going to fuse with this engulfed material and form a phagolysosome. Okay, this formation of phagolysosome is important. Why I will tell later. So once inside the phagolysosome, the inciting agent or the injurious stimulus is going to be killed. So intracellular killing is going to happen by three mechanisms. Firstly, the reactive oxygen species, which was the free radicals, remember that one. Then we have nitric oxide, and then we have lysosomal enzymes itself, the hydrolytic enzymes. So the first reactive oxygen species is the free radical. We'll see oxygen, which was forming the free radical superoxide. This superoxide, during this formation, there is also going to be activation of an enzyme called as NADPH oxidase. So this NADPH oxidase gets converted into NADP during this process. After that, we know with the superoxide dismutase, the superoxide ion is going to form hydrogen peroxide. Then this hydrogen peroxide can either form hydroxyl ion, which is again a very potent free radical, right? Apart from that, it can also undergo something called as the MPO halide system, H2O2 MPO halide system. So MPO is the enzyme which is myeloperoxidase present in the primary granules of the neutrophils itself. So this MPO enzyme, along with that a halogen like chloride, is going to involve, and with the help of this, the hydrogen peroxide is going to form this HOCl, which is a very, very potent free radical. Okay, HOCl is going to be formed. This HOCl will take care of the injurious stimuli, it will kill it. Okay, so this entire process is called as the respiratory burst. Then nitric oxide is it is being produced with the help of an enzyme called as nitric oxide synthase. Three forms of nitric oxide synthase are there, which is eNOS, nNOS, and iNOS. E for endothelium, N for neuron, and I for inducible. So this inducible is the one which is responsible for producing the free radical nitric oxide in this inflammation process. Okay, so this nitric oxide is going to combine with the superoxide free radical and form another free radical called as peroxynitrate. And this peroxynitrate will again kill the injurious agent. So this form of cell death, which is this involving this nitric oxide, is common in the macrophages. Then moving on to the lysosomal enzymes, we have primary azurophilic granules and the secondary specific granules. So this primary granules, the most important one of which is the MPO, which is the myeloperoxidase. And apart from that, we have acid hydrolases and neutral proteases like elastase. Then the secondary granules, we have lactoferrin, alkaline phosphatase, and then collagenases. So this again is important MRB in MRB questions. Okay. So with the help of all of these enzymes and free radicals, the injurious stimulus is being killed. So once the injurious stimulus is being removed, the acute inflammation will stop. Okay. So what are the clinical aspects related to this inflammation? We have Shediac-Higashi syndrome. Remember, I told phagolysosome fusion is important. So whenever there's a defect in the fusion of this phagosome and the lysosome, because of a defect in a gene called as the List gene, so it is going to result in the disease called as Shediac-Higashi syndrome. So in this syndrome, there is going to be specific features, which is very, very important. So the patient will present with recurrent infections. Apart from that, if you see the peripheral smear of this patient, the neutrophils will have very giant granules. So giant granules neutrophils are seen in Shediac-Higashi syndrome. Other than that, anything related to granules will be seen in this Shediac-Higashi syndrome. So albinism. So melanin is usually stored in granules, right? So albinism is loss of melanin, deficiency of melanin. So albinism is going to be presented. Then nerve defects. There again, the neurotransmitter granules will be stored, right? So there is going to be nerve defects, bleeding, platelet granules, right? So all of it, which is related to the granules, can be seen in Shediac-Higashi syndrome. What are the features of Shediac-Higashi syndrome? Recurrent infection. Then we have this albinism, nerve defects, bleeding, and apart from that, peripheral smear, you see giant granules in the neutrophils. Then comes chronic granulomatous disease. So whenever there is this NADPH oxidase defect, this was the enzyme which we saw in the respiratory burst, remember? So when that phagocytic intracellular killing itself is not proper, what will happen? Acute inflammation cannot remove the organism. So obviously, to remove the inciting stimulus, the inflammation will proceed on to a chronic kind of an inflammation. So that is why it is called as chronic granulomatous disease. So chronic granulomatous disease is due to the NADPH oxidase defect. Here again, we have two types of NADPH oxidase defect, which is X-linked and an autosomal recessive form. X-linked form is the one in which the glycoprotein 91 phagocyte oxidase, FOX is phagocyte oxidase, okay? GP91 FOX is defective, while in autosomal recessive, it is the P47 and P67 FOX, which is defective, okay? And how do you confirm the CGD is that we use the NBT test, which is nitro blue tetrazolium test. So NBT test, but the best test will be the dihydrorhodamine test for CGD, okay? Mediators of acute inflammation, I'm not going to touch here. I have given a summary at last. You can read that. One important thing alone I'll stress, which is the chemokines and the complement factors. Okay, so chemokines, we have 4 families. First one will be the CX3C family. Here it is going to attract, these chemokines are this family of chemokines are responsible for attracting the mononuclear cells like lymphocytes and monocytes. So the example of this is going to be fractalkine. Then we have CAXC family. So the example of that is going to be interleukin 8. And remember, interleukin 8 is always chemotactic for neutrophils. This interleukin 8 was the one which I mentioned in the LIC also, remember? Then the CC family of chemokines, it can attract every every other WBC except the neutrophils. And the examples of this will be eotaxin, then MIP1, MCP1, and rantis, which is responsible for attracting the monocyte macrophages, basically. Eotaxin for eosinophils. Then in the C family of chemokines, it is a lymphotactin. So as the name suggests, it is going to attract the lymphocytes. Okay, so these examples are important. Then coming to the complement system, we have 20 complement proteins. Okay, so these complement proteins can be activated in various pathways. So we have 3 major pathways: which is the classical pathway, alternate pathway, and the mannose binding lectin pathway. So in this, if you see, the classical pathway and the mannose binding lectin pathway are going to activate the first complement itself, which is C1. While the alternate pathway will directly activate C3. It will bypass the C1 and C2 and it will directly activate the C3 complement. Okay, and the activation triggers are different for each of this pathway. For complement pathway, classical pathway, it is usually the immune complex, antigen antibody complex, which is going to trigger this C1 classical pathway. While mannose binding lectin, as the name suggests, the mannose which is present on the bacterial cell wall is going to activate this pathway. Then alternate pathway, this is going to be activated by certain endotoxins or lipopolysaccharides produced by the bacterium, even venom also. So those are going to directly trigger the C3 complement. So along with C3, there is going to be involvement of factor B and properdin activation. And finally, that will come to the normal pathway. Okay. So once C1 is activated, it is going to undergo a sequence of events. So C3 is going to come in between. So their alternate pathway is going to come and join. So the final product is that there is going to be formation of something called as C5b9. So this C5b9 is called as the membrane attack complex, or MAC. So MAC is membrane attack complex. This is the final product of whatever be the pathway. The final activation of complement system is going to form this C5b9. But the other important things are, during this sequence of events, there is going to be multiple byproducts formed during this activation. Okay, so those byproducts also have important functions. So let's see them. So C3A and C5A. So these are A for anaphylotoxins. So C3A and C5A are important anaphylotoxins. While C5A, again, if you remember in the LIC, the C was for C5A. Okay, these were chemotactic factors. So other than anaphylotoxins, C5A is also a chemoattractant. Then we have seen about the A part of it. B part of the complement byproducts usually gets involved in the cycle. Apart from that, these B products also have certain functions, especially C3B, which is an opsonin. Opsonin means it is going to coat the cell. So once it gets coated, it is being easily edible for the phagocytes. The phagocytes can easily identify these cells and eat them up. Okay, so this C3B is a very important opsonin. Then MAC was this C5B to C5-9. So this MAC complex, a membrane attack complex, as the name suggests, this is going to insert in the membrane and form holes in that and cause the lysis of the cell. So this MAC complex is responsible for the cell lysis. So these are again important high yield points. So whenever there is some pathway, there is going to be some regulatory mechanism also to control it, right? So for the classical pathway, the C1, right, the first complement. So that is going to be inhibited by a inhibitor called as C1 inhibitor. But whenever there is going to be inhibitor of the C1 deficiency, C1 inhibitor deficiency, it is going to result in excess activation of this C1 related pathway. So what will happen? There is going to be damage caused by this excess complement activation. So this deficiency of a C1 inhibitor is going to result in angioneurotic edema. Okay, while the factor H is an inhibitor of the alternate pathway. Okay, so alternate pathway, factor B was involved in activation, factor H is involved in inactivation. So factor H, whenever there is deficiency, there is going to be excess alternate complement pathway, and it is going to result in a disease called as atypical hemolytic uremia syndrome. HUS is hemolytic uremic syndrome. Okay, atypical HUS is a type of HUS, so that is going to result because of the factor H deficiency. Apart from that, we have certain GPI, that is the glycoprotein anchored proteins. Okay, GPA anchored proteins. So GPA anchored proteins, these are a DAF and MERL. So this DAF is, it's also called as CD55, while MERL is also called as CD59. CD55 is responsible for inhibiting the complement factor 3, while MERL is responsible for inhibiting the final product, which is the MAC. So when there is deficiency of this DAF and MERL, it is going to result in hemolytic anemia called as paroxysmal nocturnal hemoglobinuria, PNH. Okay, so PNH is we'll read it again in the RBC chapter. So in PNH, there is going to be a defect in the PIGA gene. So PIGA gene is responsible for anchoring this GPA anchored proteins. So only when GPA anchored proteins are present, they can do their function. So when I told DAF and MERL are GPA anchored proteins, so whenever there is this PIGA gene defect, they are not anchored properly. So what will happen? These C3 and MAC will get activated uncontrollably, and that will actually cause the lysis of the RBCs. Okay, don't go into the details. Just remember, PNH is PIGA gene defect, which is resulting in the deficient attachment of this GPA anchored proteins, and the GPA anchored proteins which are defective in PNH is going to be DAF and MERL, which is CD55 and CD59. So this is the summary of mediators which I have given at last. We'll go through that later. Then we'll move on to chronic inflammation. As the name suggests, once acute inflammation is not able to send away this inciting stimulus, it is going to progress on to chronic inflammation. So whenever there is chronic inflammation, remember the hallmark of chronic inflammation is going to be tissue injury. So there is always tissue injury present in chronic inflammation, and with the injury, there is going to be repair as well happening simultaneously. So repair will happen by fibrosis. Remember, hallmark of chronic inflammation is going to be tissue injury, and the most important cell for chronic injury is chronic inflammation is going to be macrophages. Okay. So there are special names for these macrophages at certain places. So in the brain, these macrophages are called as microglia, while in liver it is called as Kupffer cells. In spleen it is called as literal cells. In lungs it is called as dust cells. Then in kidney it is called as mesangial cell. In placenta it is called as Hofbauer cells. Synovium it is called as type A synovial cells, and connective tissue is called as histiocytes. Out of this Kupffer cell, literal cell, dust cell, Hofbauer cells are quite important. Okay. In macrophages also, we have two types of macrophages, M1 or the classical macrophages, M2 or the alternate macrophages. So M1 macrophages are the ones which are usually pro-inflammatory, the ones which we see during activation of the inflammation. So that is the M1 macrophages, which are going to be activated by the interferon gammas produced by T helper subset 1, which I'll be telling sooner. While M2 macrophages are actually anti-inflammatory, they help in fibrogenesis and repair. Okay, so this M2 macrophages are the ones needed for repair mechanism. So these are activated by the interleukins 4 and 13 produced by T helper cell subset 2. Okay, now lymphocytes, we all know we have B lymphocytes and T lymphocytes. T lymphocytes, again we have CD4 positive helper T lymphocytes, CD8 positive cytotoxic T lymphocytes, right? Cytotoxic, as the name suggests, it is going to directly cause the lysis of the cell. So CD4 helper, in the sense, it is going to help in some sort. It is going to provide help to some other cells. So in that, we have three subsets of T helper cells, which is TH1, TH2, and TH17. So the interleukins produced by each of these subsets is important. So this you need to remember. The TH1 subset is going to produce the interferon gamma. So always remember, interferon gamma is associated with granuloma formation. So chronic inflammation, it is going to activate the M1 kind of macrophages. So interferon gamma, granuloma, M1 macrophages. Okay. Then TH2 subset is going to produce interleukin 4, 5, and interleukin 13. This is going to activate the M2 kind of subset, which is responsible for fibrogenesis and repair. Okay. Apart from that, this interleukin 4 and 5 are interleukin 4 is for producing immunoglobulins as well. The plasma cells being B cells can be triggered to produce plasma cells and immunoglobulins. So interleukin 4 will help for that. Interleukin 5, it's responsible for recruiting eosinophils. Okay. Interleukin 13, it is both a pro-inflammatory and an anti-inflammatory. Interleukin 13 is an anti-inflammatory mediator. Then interleukin 17 is going to be produced by the Th17 subset, and this interleukin 17 is responsible for recruiting neutrophils and monocytes. Okay. Remember interferon gamma for sure. Okay. This granulomatous information I had already discussed when we were discussing tuberculosis and caseous necrosis. Remember? So here again, there are very specific named MCQs. Okay. So there are various types of granulomas. There are certain specialized names given to certain causes. So in malaria, the granuloma is called as Turk's granuloma. In cat scratch disease, the granuloma is called as stellate granuloma because it is star shaped. And then fibrin ring or a donut granuloma is seen in Q fever. So, and the granuloma formed in a syphilis is called as a gamma. So these four are important MCQs again. Then if you, when I was speaking about tuberculosis itself, I told the tuberculosis has a caseous type of a necrosis in the center, while there is something called as sarcoidosis, which is a disease of unknown etiology. So the sarcoidosis is going to have a non-caseating kind of a granuloma, meaning there is not going to be any caseous necrosis here. And apart from that, it is given a special name called as naked granulomas. Naked granulomas are seen in sarcoidosis. Why is it called naked? Because the lymphocyte collar, which we were talking about in the tuberculosis granuloma, remember the outermost layer. So the lymphocyte collar is not going to be seen in this sarcoidosis. That is why it is given the name of naked granuloma. Then giant cells were also a component of this granulomas, remember. So I am going to discuss this certain type of giant cells. So we have both physiological and pathological giant cells. In physiological giant cells, we have osteoclasts, syncytiotrophoblasts, and megakaryocytes. In pathological giant cells, these are the important ones. So Langhans giant cells, we all know it is seen in tuberculosis. Then that is the nucleus is actually arranged in the form of a horseshoe at the periphery of the cell. So that is Langhans giant cell. Next comes Teuton's giant cells. Teuton's giant cells are seen in xanthomas. So here as such, the nucleus will form a circle like this. So if this is the cell, this nucleus is form a circle like this, and the cytoplasm will be present both inside and outside of the cell, like outside of the nuclear ring. Okay, so this is the appearance of the Teuton's giant cell. Then foreign body giant cells, as the name suggests, you will see it in any, if there is any foreign body. So here the nucleus is going to be haphazard. So randomly distributed nucleus is going to be present. Then we have Reed-Sternberg cell. So Reed-Sternberg cell, we all know it is seen in Hodgkin's lymphoma, and we also have given it a name called as owl-eye appearance, because it is going to have a prominent nucleolus surrounding which there is going to be a clear halo. So that is going to give the appearance of a owl eye. And there is going to be a mirror image kind of a binucleate nucleus, which we see in Hodgkin's lymphoma. So the characteristic cell we see in Hodgkin's lymphoma is the Reed-Sternberg cell, which has this owl eye appearance. Other than that, we have this owl eye appearance also in CMV. CMV is cytomegalovirus. So in cytomegalovirus also, we have the very big intracytoplasmic and intranuclear inclusions. So this inclusions give the appearance, or the intranuclear inclusions of the CMV virus also gives the appearance of the owl eye. So owl eye appearance is seen both in Reed-Sternberg cells and in CMV infection. Then Warden-Fingaldi giant cell. This is again an important MCQ. Warden-Fingaldi giant cell is seen in measles. So measles can cause pneumonia, which is given a special name again called as hex pneumonia. HECHT, okay, hex pneumonia. And in hex pneumonia, you can see this Warden-Fingaldi giant cells. Here again, you can have certain inclusions. Next, moving on to tissue repair. I'm not going to touch in the details here. So for tissue repair, two important processes will happen. One is regeneration, which is based on the potential of the cell to proliferate. Another thing is scar formation, which is happening by fibrosis. So based on the potential of the cell to proliferate, we have three types of cells: labile cells, stable cells, and permanent cells. Labile cells, as the name suggests, they can divide continuously, like the cells which are shed usually, like the skin, GIT, bone marrow. So the whatever mucosa is present, they are going to be labile cells. While stable cells are cells which can divide only in response to certain injury. So like liver, like I told you, so liver and kidney are examples of stable cells. While permanent cells, whatever be the stimulus, they cannot regenerate. So neurons and cardiac muscles are examples. Okay, so neurons and cardiac muscles are examples of permanent cells. So the hallmark of this repair is going to be formation of granulation tissue. Very, very important. We have seen many hallmarks till now. So hallmark of apoptosis, we have seen hallmark of chronic inflammation. Abhi, we are seeing hallmark of repair. So hallmark of repair is formation of granulation tissue. So granulation tissue is nothing but the pinkish structure which forms once you have any wound. So after a few days, you get to see some pinkish structure, right? That is the granulation tissue. And this granulation tissue is composed of three things basically, which is proliferating blood vessels, proliferating fibroblasts, and inflammatory cells. So proliferating blood vessels are needed for healing. So only when blood supply is there, there will be healing, right? Then proliferating fibroblasts, because fibroblasts are the cells which are producing the collagen. So it will lay down the collagen which is needed for the scar formation. Thirdly, the inflammatory cells which are helping in eating up the debris and cleaning up the area. Okay. So the inflammatory cells usually in repair, the most important cell I told was M2 kind of macrophages, right? And another important thing is the collagen which is deposited by the fibroblast seen in granulation tissue is going to be type 1 and type 3 collagen. Type 1 collagen is the most common collagen which we see in skin and all. And this granulation tissue will have both type 1 and type 3 collagen. But when it is being replaced by the scar tissue, eventually scar tissue will take over. Only the fibrosis and collagen will be there. That collagen will be only type 1 collagen. Okay. Type 1 and 3 will become just type 1 collagen. So in this events in wound healing, just remember the maximum amount of granulation tissue is going to happen on day 5. Okay. Granulation tissue, maximum granulation tissue on day 5. And once the scarring is complete, it takes around a month. So day 28, it will be over. The scar will be complete. But if you see the wound strength, it will never ever regain 100% strength. It will gain a maximum of 70 to 80% of the strength by the end of 3 months. That too. Okay. So by the end of 1 month, scarring is complete, but the strength of 70% is regained at the end of 3 months. But it will never ever become 100%. So types of wound healing, we have two types: primary intention and secondary intention. Primary intention is the clean surgical wound which we have. So with the scalpel, if you cut, the edges are still can be approximated. So with those clean kind of opposed edges, primary union will happen. But any wound which has some kind of gaping or trauma kind of thing, so it will result in secondary union only. And in that case, the steps are going to be the same. The formation of granulation tissue, scar formation, everything is going to be the same, except that everything will be in a higher amount just to bridge the gap between the wound. The granulation tissue and the scar tissue which is formed in the secondary union is more than that of the primary union. And one other important thing in this secondary union is the wound contracture. Wound contracture is a feature of secondary union and not a feature of primary union. So when does wound contracture happen? So this was the gaped wound. I am laying down collagen in between this. So you don't end up having this bigger scar, right? You have this bigger scar only, right? That is because of wound contracture. It happens because of the myofibroblasts. The fibroblasts which lay down the collagen, they acquire the property of myofibroblasts. They in turn change into myofibroblasts. So myo means muscle. Muscles are capable of contracting, right? So this fibroblast can contract and bring down the size of the wound into a small scar. Okay. Hypertrophic scar and keloid, I guess it will be covered in surgery, but still I'll just tell. Hypertrophic scar is when the scar is limited to the margins, while keloid is when the scar exceeds beyond the margin. Hypertrophic scar is spontaneously resolving, while keloid will not resolve on its own. In fact, if you cut it, it will grow more and more. Okay. So we are done with inflammation. Next, we'll move on to genetics. So in genetics, so first things, the basics. So the coding regions in the gene are called as exons. And as such, coding regions, the exons, compose the very minimal part in the entire genome. It is just 1.5%. While the non-coding regions, which are called as the introns, are the maximum part which occupy 98.5%. This is a very basic question, but I've seen students make multiple mistakes in this all the time. Okay, remember, E looks like C, right? So exons for coding region, okay, and it is very less. Then codominance. So codominance, example for codominance will be ABO blood group system. Okay, ABO blood group system. Then coming to Lyon's hypothesis. So whenever there is 2X, there is going to be inactivation of one of the X. So if it's a female, we are going to have 2X, right? So one of the X chromosomes is always going to be inactive. And it is the same X which is going to be inactivated in all the cells. Okay. And this inactivation of the X is controlled by a gene called as ZIST. Okay. ZIST gene is actually an example of a long non-coding RNA, which we call as link RNA. Our LNC is long non-coding RNA, which we call as link RNA. Example of a link RNA is ZIST gene, which is responsible for the inactivation of the X chromosome. So the inactivated X chromosome is eventually going to form a bar body. So this bar body is going to be seen in the neutrophil as a drumstick. So near the nuclear membrane, it is going to appear like a dumbbell and it is going to appear like a drumstick appearance. Okay. So the number of bar bodies is always equal to the number of X minus 1. So based on this, questions have been asked. So if you have a normal female, it is a 46XX is the genotype. So what will be the number of bar bodies? Yes, it is going to be 1. But if it is a male, it is 46XY. They already have only one X. So when that X is also minus, there is not going to be any bar body. So 0 bar bodies are seen in male. So that is how we can identify the sex of the patient also in a peripheral smear. Okay. If it's a Turner syndrome, the Turner syndrome, the genotype is going to be 45XO, X0 basically. So X0, there again, there is only one X. So the number of bar bodies is 0. Okay. 0 bar bodies in Turner syndrome. Then coming to karyotyping. So karyotyping is the study of chromosomes. The study of chromosomes, the sample in which we study the chromosomes are usually the chorionic villus biopsy, amniocentesis. Then if you take the peripheral blood, you have to study it only in the lymphocytes and not the monocytes. Lymphocyte can be used. And in the skin, fibroblasts can also be taken. Okay. So these 4 are the samples that can be used for karyotyping. And usually the chromosomes are visualized in the metaphase of the division. And this arrest is happening with the help of an agent which we use called as colchicine. Okay, so colchicine, with that we cause metaphase arrest and study the chromosome. And the fixative used for karyotyping is Carnoy's fixative, which contains glacial acetic acid and methanol in the ratio of 1:3. So the pattern in which we see the karyotyping, the most common pattern is the G banding. G stands for GMSA. So we use the stain GMSA and it will give a dark and light appearance which looks like bands. That is what is called as banding. The stain which we use is GMSA, so it is called as G banding, which is the most common one which we use for karyotyping. So mutations. So what are mutations? We speak about mutations all the time. So what are those? They are actually which are permanent aberrant changes which are happening in the DNA. So they are abnormal. So this mutation can either be a point mutation or a frame shift mutation. Point mutation, as the name suggests, it is going to be at a particular point involving only a single nucleotide. So it could either result in a silent mutation or a missense mutation or a nonsense mutation. Silent mutation meaning there is not, I had changed one of the nucleotides with some other thing, but still there is not going to be any effect because the nucleotide which I replace with some other nucleotide, no, it is going to encode with the same amino acid, then it is not going to cause any other change. So that is called as a silent mutation. While if I am changing one nucleotide with some other nucleotide and it is going to read as a separate different amino acid, it is going to code for a different amino acid, it has changed the sense of it, right? So the amino acid itself has changed. That is called as missense mutation. And the best example of missense mutation is sickle cell anemia. Again, it has been asked in MRB question as well. So in sickle cell anemia, we all know glutamate is replaced by valine at the 6th position of the beta chain of the hemoglobin. So this one, we all know it by heart, remember? So here, because of that, one single nucleotide change, what has happened? The hemoglobin A, which is the normal C, has been replaced by hemoglobin S, which is abnormal. Okay. So missense mutation, it is sickle cell anemia. So remember, valine is Win. Okay. So V for Win. So valine is the final final amino acid which is getting which is actually present, okay, in sickle cell anemia. Then nonsense mutation is one which I had changed the nucleotide and an entirely different thing has happened. It is causing no sense at all. That is, a stop codon has been introduced. So the protein itself has been synthesized as a small protein rather than the complete protein. It has stopped prior itself. So that is a nonsense mutation, and the example of nonsense mutation will be thalassemia. Missense is sickle cell anemia. Thalassemia is nonsense mutation, right? Then coming to the classification of genetic diseases, we have Mendelian disorders, non-Mendelian disorders, chromosomal disorders, and multifactorial disorders. So under multifactorial disorders, as the name suggests, is going to have many factors. So both the genetic factors and environmental factors will contribute to the disease, not a single gene, not a single pinpointed reason you can give for that. And the best examples for that will be the heart diseases like congenital heart disease, cleft lip, cleft palate, and also diabetes, hypertension. These kind of examples are important for multifactorial diseases. Let's see about Mendelian disorders. So Mendelian disorders are always single gene disorders, and they follow the principles of Mendelian law. So first we'll see about the autosomal dominant and autosomal recessive in a comparative manner. I'm not going to go into the details, just remember the important things. In autosomal dominant, it is incomplete penetrance and variable expressivity, while in autosomal recessive, it is complete penetrance and 100% expressivity. Here again, students tend to make mistake. They think dominant, so everything should be perfect. So complete and 100% expressivity, they write. No, it is the opposite. Autosomal dominant is incomplete penetrance and variable expressivity, while autosomal recessive is the one in which there is 100% expressivity when complete penetrance. Okay. So every time it is autosomal recessive is usually of a enzymatic deficiency. So some inborn error of metabolism, usually those kind of inborn errors of metabolism disorders are autosomal recessive, while any structural protein defect will be an autosomal dominant defect. Okay, disease. And autosomal dominant diseases usually tend to present at a later adulthood age group, while autosomal recessive they cannot survive, so they cannot survive. I shouldn't have told. These patients will present at a very younger age group. In the childhood itself, the onset will start. And the examples of these Mendelian disorders are the most important ones. No other go, you have to mark it up. For autosomal dominant, I have created a mnemonic. So it is, he has a very dominant father for dominant disorders. So out of this, at least you must know hereditary spherocytosis, Huntington's disease, VHL syndrome, osteogenesis imperfecta, Marfan's, neurofibromatosis, achondroplasia, then familial adenomatous polyposis, and familial hypercholesterolemia. Okay. So familial hypercholesterolemia is the only disorder in which there is this metabolic error is going to be there, but still it is an autosomal dominant disorder and not an autosomal recessive. Okay. Coming to autosomal recessive, it is enzymatic deficiency. So whatever enzymatic deficiencies you read in biochemistry, those are all examples of autosomal recessive disorders. Apart from that, you have blood related hemolytic anemias like sickle cell anemia, thalassemia, then liver diseases like Wilson's disease, hemochromatosis, cystic fibrosis, albinism. Here albinism is because of an enzyme deficiency. Alpha-1 antitrypsin deficiency, again alpha-1 antitrypsin is an enzyme. So all of these are examples of autosomal recessive diseases. Apart from that, storage disorders. We have read big tables in biochemistry, remember, like glycogen storage disorders, lysosomal storage disorders. So all of them are autosomal recessive, except exceptions are always important, except Fabry's disease and Hunter's disease, which are X-linked recessive diseases. Fabry's and Hunter's disease are X-linked recessive diseases. Rest all enzymatic disorders are examples of autosomal recessive. Okay. Then we'll see Marfan syndrome. So Marfan syndrome, I mentioned it as an example under autosomal dominant. So here the gene which is defective is the fibrillin gene present on chromosome 15. Fibrillin gene present on chromosome 15. So here the features I have to discuss. So here the Marfanoid habitus, they present with Marfanoid habitus, that is the person will be quite tall with long legs, okay? So very tall with long legs, and they'll have usually a supratemporal dislocation of the lens. So supratemporal in the sense it is like this, supratemporal dislocation of the lens will be there. So fibrillin is as such, it usually provides a scaffold for the elastin. So elastin is present in the connective tissue. So without fibrillin, elastin is also not properly formed. So when elastin is also not properly formed, the elastin is present usually in this lens, then joints, ligaments, and also in vessel walls, they all become quite lax. So the patients, they have very flexible kind of joints, and because the ciliary ligaments in the eyes are lax only, the lens tends to get dislocated. Same thing for vessels also. The vessels tend to rupture without the support, and they can even result in aortic dissections. Then we'll see Ehlers-Danlos syndrome. Ehlers-Danlos syndrome, here the defect is in the collagen. Fibrin defect in Marfan's, while collagen defect is there in Ehlers-Danlos syndrome. But Ehlers-Danlos syndrome, it is going to be a cluster of many types. Okay, so we have at least 7 types. More than that, we have. We need to remember at least some of it. Okay, so the defect is going to be in the collagen, and the most common type of collagen which is affected is the type 3 collagen. One important thing is the most common Ehlers-Danlos syndrome is also type 3 EDS. Type 3 EDS, and it is also given the name of hypermobility type. Type 3 collagen is usually defective, and type 3 EDS is the most common EDS. Type 3 EDS is also called as hypermobility type, meaning the joints are quite flexible. But the least common EDS will be the type 7 EDS, which is the arthrochalasia type. Then the life-threatening EDS is the type 4, which is the vascular type. So obviously the vessels are being very fragile, so it will rupture. So that is going to result in massive hematomas. So the patient can die. So that is the life-threatening EDS, which is type 4. So clinically here again, the patient will have very flexible joints, and the skin will also be quite thin. So collagen 1 is going to be the most common collagen seen in skin. So without collagen, the skin is going to be very thin and like a cigarette paper, very thin. Okay. The autosomal recessive diseases I'm not discussing. One thing alone I'll mention, this Gaucher's disease, which is a lysosomal storage disorder again. It is an autosomal recessive condition because the enzyme defective here is the glucocerebrosidase deficiency. So when there is a deficiency of this enzyme, there is going to be accumulation of the substrate glucocerebroside. So this accumulated glucocerebroside is going to give a characteristic appearance to the tissue, which is called as the crumpled tissue paper appearance. So as if the tissue paper has been crumpled, it looks like. So crumpled tissue paper appearance is seen in Gaucher's disease. One other thing is pseudo-Gaucher cell. So pseudo-Gaucher cell, where do you see? It is seen in CML, chronic myeloid leukemia. So Gaucher's cell is the crumpled tissue paper appearance cell, which is seen in Gaucher's disease. But pseudo-Gaucher cell is the cell which are sea blue histiocytes basically, which are seen in chronic myeloid leukemia. Okay. Then coming to X-linked recessive diseases. The X-linked recessive diseases, the mantra to remember these diseases is the females are always carriers and males are always affected. Okay, females are carriers, males are diseased. So this is the mantra. And the examples of these are again important. So starting with hemophilia, then Bruton's A gamma globulinemia, then Duchenne's muscular dystrophy, wherein dystrophin is the gene which is being affected, Fabry's disease, Fragile X syndrome, X already is there in the disease, G6PD disease, Hunter's disease, and Wiskott-Aldrich. Remember, when I was discussing autosomal recessive, I mentioned Fabry's disease and Hunter's disease are the exceptions to autosomal recessive diseases because they are X-linked recessive. So these examples at least you must remember for X-linked recessive. Moving on to X-linked dominant diseases, here we can use the mnemonic Ravi. So Rett's disease, Alport syndrome, then vitamin D resistant rickets, and incontinentia pigmenting. So all these 4 are examples of X-linked dominant disorders. Alport syndrome, it is actually multiple, all kind of inheritance is possible, but the most common one is going to be X-linked dominant. Okay. Y-linked disorders. So Y-linked, Y is going to be present only in males. So all males are going to be affected. So from father, he is going to give the Y only to the son, right? So all the males are going to be affected. And here the only example we have for Y-linked is hairy ears, right? Next, moving on to non-Mendelian disorders. First thing will be the mitochondrial inheritance. So mitochondrial inheritance is usually have a maternal pattern of inheritance. Why? Because mitochondrial genes are inherited only from the mother and not from the father. Okay, so they always have a maternal inheritance, and these follow population genetics. So the mantra for remembering mitochondrial inheritance is going to be the mother is going to pass the she is the only one who is going to pass the mitochondrial genes, right? So she is going to give it to all her children. The disease is going to affect all the children, but the father he doesn't transmit the mitochondria, so he's not going to give the disease to his children. So father to none and mother to all children is the mantra for mitochondrial inheritance. So in the diseases for mitochondrial diseases, we have many diseases. You don't have to remember everything. Remember MELAS. MELAS is the most common mitochondrial disease, and CPO, which is chronic progressive external ophthalmoplegia. This is the most common mitochondrial myopathy. Okay. So mostly mitochondrial diseases will be associated with muscle disorders or CNS disorders. Okay. And we have Leber's hereditary optic neuropathy. So these are all examples of mitochondrial disorders. Two important things about mitochondrial inheritance is in electron microscopy, you can have parking lot inclusions in the skeletal muscle. So parking lot inclusions and red ragged fibers are seen in mitochondrial diseases. Mitochondrial inheritance, you can see red ragged fibers in Gomery's trichome stain and parking lot inclusions in electron microscopy. Then the next and non-Mendelian disorder type of pattern is the trinucleotide repeat mutation. So we all know the nucleotides will be read in a reading frame of 3 nucleotides. So that will code for an amino acid. That is how we read the frame, right? So this 3 nucleotides, if they get repeated, so to a certain extent, this repetition is allowed. Suppose I'm writing C, G, G, C, G, G. Like this, if I'm giving a repeat of continuous C, G, G, it is acceptable till a particular limit. After that, it is abnormal. So that is when this trinucleotide repeat mutation presents as the disease. So this trinucleotide repeat mutation can either happen in the coding region or the non-coding region. So for coding region, we have Huntington's disease as the example, and the repeat here will be the CAG repeats. So CAG nucleotides will be repeated back to back. So remember it, hunter will take a cage to capture the animals. So cage resembles like CAG, right? So CAG repeats for Huntington's disease. Then non-coding regions, we have 3 examples: Fragile X syndrome, which is CGG repeats, and then Friedreich's ataxia, which is GAA repeats, and myotonic dystrophy, which is CPG repeats. So Fragile X syndrome, I remember it this way. So CGG, it looks like egg, right? So this is C, egg. So egg is fragile. So Fragile Egg syndrome, it is CGG repeats. So certain things first, this trinucleotide repeat mutations have a common feature which is called as anticipation. So anticipation is a feature of trinucleotide repeats. So what is this anticipation? It just means that if a particular generation of a parent is affected, he is passing the disease to his son. In that case, the son will be affected at an earlier age than that of the father. Suppose the father acquired the disease at the age of 35. The son is going to acquire the disease, manifest the disease at the age of 20 itself. And it will come up with much more severity in the son. Okay, so this kind of anticipation in the disease progression is what we see in trinucleotide repeat. And this is because the number of repeats tend to increase with the generation. So in Fragile X syndrome, the gene which is mutated is actually FMR1 gene. So FMR stands for F for this fragile, and then MR for mental retardation. It is actually the second most common cause for mental retardation. The most common cause of mental retardation is it's Down syndrome. Okay, the second most common cause is Fragile X syndrome. So FMR1 gene, you are going to have the repeats of the CGG. So up to 55, it is acceptable. So 55 to 200 repeats, if they are present, it is called as pre-mutation, and it is going to result in some other disease called as Fragile X associated tremor ataxia, and then Fragile X associated primary ovarian failure. Only when the repeats are more than 200, it is going to cause the full mutation, and which is resulting in this Fragile X syndrome, right? 200 repeats needed for Fragile X syndrome. So anticipation, I've already told. Then this most important features, this again is a repeated asked question. So in Fragile X syndrome, mostly the features are all big. Okay, the person will have mental retardation, long face, large ears, long mandible, everything will be big. And the most consistent feature, if you they ask in a Fragile X syndrome, it is the macroorchidism. So more than 90% of the kids are going to present with this macroorchidism. So this is the most important thing. Macroorchidism is bigger testes. Okay. Then the third type of non-Mendelian inheritance is the genomic imprinting. So imprinting itself means silencing. So silencing happens by epigenetic mechanisms like methylation. So methylation is an epigenetic mechanism. The most common silencing mechanism is this imprinting. So here you need to remember one thing alone. Chromosome 15, it is going to be affected. So chromosome 15, you get a maternal copy and a paternal copy, right? If the paternal copy is deleted and the maternal copy is imprinted, it will result in Prader-Willi syndrome. While if the maternal copy is deleted and the paternal copy is imprinted, it will result in Angelman syndrome. So don't confuse. Just remember one of the things. Just imagine, I'm telling one of the copies is imprinted, other one is deleted, meaning imprinting is already useless because it is a silenced gene, and the other one is deleted, meaning there is no normal copy of this chromosome 15 at all. So that is going to result in the problem. So this chromosome 15, if the P for P is for paternal, angel is for mother is an angel, okay? So maternal. So you will remember only the deletion, okay? Don't remember the imprinting. If one is deleted, obviously the other one will be imprinted. So if I'm telling paternal deletion, it is Prader-Willi, and maternal deletion, it is Angelman. So with paternal deletion, obviously there is going to be maternal imprinting, okay? Do not confuse. Paternal deletion is Prader-Willi, maternal deletion is going to be Angelman syndrome. This is going to happen in chromosome 15. So where else did we see chromosome 15? Yes, it was in Marfan syndrome, fibrillin 1 gene. And the features, this again has been housed in MRB. So obese, both of the Prader-Willi and Angelman syndrome, they both present with mental retardation and short statures. But obesity is a feature of Prader-Willi syndrome, while inappropriate laughter is a feature of Angelman syndrome. Okay, so because they are laughing inappropriately, they are also called as happy puppets, right? Then the last mechanism for non-Mendelian disorders is a gonadal mosaicism. So these are usually autosomal dominant disorders, but the difference between this and autosomal dominant is that in an autosomal dominant disorder, every generation is going to be affected. Okay, not even a single generation will be skipped. So grandfather will be affected, the father will be affected, the son will be affected, every generation will be affected. But in a gonadal mosaicism, an autosomal dominant disorder like osteogenesis imperfecta, it is presenting just like that in a family without prior history in the family. So in that case, it would be because of gonadal mosaicism. So that is because of post-zygotic mutation. So the father's sperm was normal, mother's egg was normal. They had formed the zygote, and the zygote, after forming, it has undergone mutation, and that has resulted in the disease. Okay. So this gonadal mosaicism examples are usually that of the autosomal dominant disorders only, like osteogenesis imperfecta, tuberous sclerosis, achondroplasia. If you remember, all these three were autosomal dominant disorders. So the difference is going to be the previous generations are not going to be affected. It is just the index generation, the current generation, which is going to be affected, right? Chromosomal disorders, I'm not going to touch it. I'll just discuss Down syndrome. Okay, Down's, Klinefelters, and Turners. So Down syndrome, we all know it is trisomy 21. Never ever forget that. And most common cause of mental retardation is Down syndrome. Second most cause was Fragile X syndrome. So the pathogenesis in Down syndrome is meiotic non-disjunction, and it is associated with increasing maternal age. So with increasing maternal age, the probability of getting a child with Downs is more. So meiotic non-disjunction is the major pathogenesis in Down syndrome. Apart from that, we also have Robertsonian translocation and mosaicism. Okay. So clinical features, we are all familiar with Down's clinical features, not going in there. Next is complications. So the most common hematological abnormality which we see in Down's patient is a transient abnormal myelopoiesis, TAM. Okay, so there is going to be transient abnormal myelopoiesis. And if they ask most common leukemia, if the age group of the child is less than 2 years, it is AML M7, which is the megakaryocytic type. Okay, AML M7. While it is overall, it is acute lymphoblastic leukemia, ALL. Okay. And these kids are prone for developing Alzheimer's disease at an earlier age group itself. So normally Alzheimer's is a disease of the elderly. They tend to forget, right? That is Alzheimer's. dementia. So this dementia sets earlier, around 20 to 40 years itself. This dementia will set in these Down syndrome kids. Why? Because this chromosome 21, there there is going to be a gene called as APP, which is amyloid precursor protein. So amyloid precursor protein is from this amyloid precursor protein only the characteristic A beta plaques which are seen in Alzheimer's are being formed. Okay, so this APP gene itself is present in chromosome 21. So when we have an extra copy of this chromosome 21, obviously the patients are going to have a higher predisposition for developing Alzheimer's at an earlier age, right? So how do you diagnose Down syndrome? So screening, we use the triple test and the quadruple test. So triple test is the estriol, AFP, and beta HCG, out of which only the beta HCG will be elevated, while the other two will be decreased. While in quadruple test, the same three, along with that increase in the inhibin is quadruple test. So if you see this during the pregnancy trimester itself, they suspect Down syndrome. Also, they check in for the nuchal translucency, right? So thickness of it, that also they measure, and based on that also they can diagnose. Confirmation will be with the karyotyping. You see 3 copies of the 21st chromosome. So again, important questions here. The most common trisomy alone they ask, don't jump into Down syndrome. Okay, it is trisomy 21, trisomy 16. Okay, it's just that trisomy 16, those embryos they get, they die in utero itself. They don't survive. They are not compatible with life. So trisomy 16 is the most common trisomy. Only if the question is most common trisomy compatible with life, it will be Down syndrome. Okay. Then trisomy 22 is multiple coloboma. So colobomas are nothing but this kind of eye, like a cat eye, vertical slits will be there. So multiple coloboma will be seen in this trisomy 22. Then trisomy 13 and trisomy 18. So this again, they tend to confuse. So trisomy 13 is for PATHO. So we usually tell 13 number is evil, right? For ghost kind of number. So I remember it this way. So 13 is an evil number. So pay, I remember. So pay for PATHO. So this is how I remember. P for P. Then Edward is E letter and 18 is also E. So Edward is 18, PATHO is 13. Okay. Then Klinefelter syndrome. Klinefelter's, we all know it is either 47. There is going to be an extra X chromosome in the male. So it is either going to be 47 XXY if there is one extra X chromosome, or 48 XXY XXXY if there is 2 extra X chromosome. Okay. They'll change the numbers. Okay, they'll give it as 47 46 XX extra X with the 46 chromosome. You will not pick that. Okay, so 47 or 48 based on the number of X, you'll have to increase the number as well. So clinical features here, they are going to present, but they are also going to be very tall like the Marfans, but here they are going to have hypogonadism with absence of secondary sexual characters. Apart from that, these patients are going to have an increased risk of extragonadal germ cell tumors and also male breast cancers. Then Turner syndrome, the genotype is 45XO. Also, we have a 46 ring X ring chromosome. Okay, so ring chromosome is basically a useless chromosome. It is not going to be of any use. So that is also equivalent to a 0 only. So that is why 2 types of genotypes can be there, 45XO or 46X ring X. Then clinical features, most important one, streak ovaries. So the ovaries are going to be very much atrophied. They just look like a streak, and the patients will present with a primary amenorrhea. So hypogonadism will be there again. And apart from that, the classical features of webbing of neck, low hairline, and widely spaced nipples, coarctation of aorta, all these things will be classical features of Turner syndrome. So we are done with genetics. Now let's move on to immunity. So cells of the immune system, we'll just start the lymphoid system here. So every cell, hematopoietic cell will start from the hematopoietic stem cell. So the marker of a hematopoietic stem cell is going to be CD34. Okay. So from the hematopoietic stem cell, we have various progenitors. From the lymphoid progenitor, we get the B cells and the T cells and the NK cells also, just natural killer cells. So B cells constitute only 20 to 30% of the peripheral blood. So the majority, 80% is going to be composed of the T lymphocytes only. So B cells, both the production and maturation is going to happen in the bone marrow only. And the B cell receptor is composed of IgM and IgD. And in the CD markers are again important questions. So the pan B cell marker is CD19. So CD19 is a pan B cell marker. Apart from that, if they ask CALA antigen, so common ALL antigen, which is CD10. Okay, at least these two you must remember, CD19 and CD10. So we all know B cells, after getting activated, they become plasma cells and they produce immunoglobulins. So immunoglobulins are of 5 types: IgG, IgM, IgA, IgD, IgE. So remember it this way: GAMD. So G is the highest concentration. So as the GAMD it goes up down, the size, the concentration of the immunoglobulins are going to be decreased, the proportion. Okay, so IgG is the maximum and IgE is the least concentration. Okay. And IgG, it can cross the placenta. That is very important. It is the maximum concentration. IgA is the first defense against the mucosal immunity. So in the gut immunity, the respiratory immunity, all of this is produced by the IgA only. Then IgM, it is the first defense mechanism, which is taken over by the IgG next. Okay, so first defense mechanism is the IgM, and then it is the biggest immunoglobulin because it is a pentamer. Okay, the structure of the immunoglobulin, we draw something like this, right? So like this, 5 things will be attached. So that forms the IgM molecule. So it is a pentamer and it is the largest immunoglobulin. And because it has multiple, it is a pentamer, it has multiple antigen binding sites. So the maximum antigen binding cells are also present in the IgM. Then IgE, we know it is involved in the type 1 hypersensitivity reaction, any allergic kind of reactions, right? So coming to the type of antigen, we have 2 types of antigen: proteinaceous antigens and non-proteinaceous antigens. So proteinaceous antigens are the one which can evoke a very robust kind of a response with memory. Okay, why? Because when these proteinaceous antigens are injected, it will be taken up by the antigen presenting cells. So these antigen presenting cells will break down these proteinaceous antigens and present it to the T cells, which is the T helper cells. So the T helper cells will take up this and then it will go and in turn activate the B cells. So this T cell will ask the B cell to get activated, and this B cell will in turn produce the various kinds of immunoglobulins. So initially it will produce IgM, and later on, seeing the type of the antigen, it will change itself, and according to the antigen, it will mature. So that is called as affinity maturation. That is specific for that particular antigen, it will produce antibodies. So that is very precise mechanism, right? So it is very robust. So the affinity maturation will happen. And also, suppose the infecting agent which had come was the parasite. So in that case, it has, rather than IgM, it has to produce an IgE, right? So IgE should be produced. So for IgE, it has to change its class. So from IgM, it has to change. So that is called as class switching. So class switching and affinity maturation, only when they are there, it can produce a robust kind of an immune response. That can happen only when T cell dependent responses happen. Okay, T cell helper response is needed for such a robust response with memory. So more potent and memory, it is T cell dependent, and it will happen only when there is a proteinaceous antigen, because isotype switching and affinity maturation will happen. Suppose if it is a lipopolysaccharide, a non-proteinaceous antigen, so it will directly go and activate the B cells. So the B cells will be able to produce only IgM and there will be no memory. Okay, so it's a very simple thing, but it is not a robust kind of a mechanism. So coming to T cells, I told it's the maximum proportion. So 60 to 70% of the lymphocytes are T cells only. And here the formation of T cells will be in bone marrow, but they get matured in the thymus. That is why it is given the letter T, right? Then structure, I don't see it. Then CD markers expressed by the T cells. Here again, CD3 is the pan T cell marker. Okay, CD3 is the pan T cell marker. CD19 was the pan B cell marker. CALA antigen was CD19, while CD3 is the pan T cell marker. Apart from that, we had already seen CD4 positive is going to be the helper T cell. CD8 positive is going to be the cytotoxic T cells. So the ratio of the cytotoxic, helper T cells to cytotoxic T cells is going to be 2:1. The ratio will be more of T cells, helper T cells. So remember this thing. This again is quite confusing. People tend to forget it. So CD4 helper T cells, they always interact with the MHC class 2 molecule. MHC class 2 molecule. CD8 will interact with the MHC class 1. Okay. So these MHC, I'll be speaking about MHC sooner. So we have 3 types of subtypes of T helper cells, and their interleukins we had already seen. Remember? So this one is an important question. CD4 interacts with MHC2, while CD8 interacts with MHC1. Then there is a specific subset of T helper cells only, CD4 positive T helper cells. So those are called as Treg cells. To see Treg, as the name suggests, these are going to be having a regulatory function. So these are regulatory cells which bring down the inflammation. So once the agent is removed, inciting agent is removed, the environment has to come back to its normalcy. Inflammation has to subside. So that is taken up by the Treg cells. And Treg cells will differentiate only when the transcription factor FOXP3 is present. So FOXP3 is responsible for production of Tregs. And when there is mutation of this FOXP3, it is going to result in the syndrome called as IPEX syndrome. IPEX syndrome. It is a acronym which stands for immune dysregulation, polyendocrinopathy, enteropathy, and it is an X-linked disorder. Okay. So IPEX syndrome, FOXP3, Tregs. Then NK cell. NK cell are natural killer cells. Here I am not going to the details. It is a part of the innate immunity system only. And the CD markers which are expressed by the NK cells are CD16 and CD56. Okay. Certain CD markers at least you need to remember only. So next, moving on to the antigen presenting cells. So these are the first cells which encounter the antigens whichever enter the body. So antigen presenting cells can be of 2 types, which are professional antigen presenting cells and non-professionals. So the professional antigen presenting cells, obviously they are the professionals, so they are good at their work. So they have the examples of these professional and APCs are dendritic cell, B cells, and macrophages. So B cells are also APCs only. So dendritic cells, B cells, and macrophages. While non-professional APCs, we have thymic epithelial cells, thyroid epithelial cells, endothelial cells, skin fibroblasts. So when triggered, they can still act as APCs. Okay. Moving on to MHCs, which is major histocompatibility complex. It is also called as the human leukocyte antigen HLA. So HLA and MHC are the same. So the gene for this MHC is going to be present on chromosome 6p. So we have 3 parts of this MHC1 in the gene, the HLA gene, right? So it is going to have 3 parts: HLA1, HLA2, and HLA3. So this MHC1 is going to be further subdivided into A, B, C, while MHC2 is going to be further subdivided into DP, DQ, and DR, while MHC3 is just as such. Okay. And if they ask, this MHC3 is going to encode for complement factors like C2, C4, properdin, TNF alpha, and heat shock proteins. I don't think they'll ask, but just in case. So most important thing on MHC is that the MHC1, it is going to be present on all nucleated cells and platelets. Okay, on all nucleated cells is there. Platelets do not have nucleus. RBCs also don't have nucleus, but platelets still have MHC1, but RBC doesn't have MHC1. Okay. So MHC1, I told the interaction will be with that of a CD8, right? So they will present to the CD8 positive T cells, and the detection of this MHC1 is done by allo anti-sera. While MHC2, it is going to be present on the on all antigen presenting cells. Okay, all antigen presenting cells will have MHC2. They will present to CD4 positive T cells, and they are detected by the mixed lymphocyte reaction. Okay. So in MHC1 complex, if you see the antigen, the antigen will actually bind to this MHC1 only. Okay. So the antigen binding cleft in MHC1 is formed by the alpha-1, alpha-2 structure, while alpha-1 and beta-1 is the antigen binding cleft for MHC2. So alpha is first. Alpha is always the king. Okay. So that is for MHC1. Remember it that way. Alpha-1, alpha-2 for MHC1, alpha-1, beta-1 for MHC2. Then certain, why is this MHC important? It is usually for testing paternity issues, some medical legal issues can be clarified with the help of this MHCs, and also for identifying disease pathogenesis. We always tell this person is susceptible for certain diseases. How? Because we have found certain HLA associations with those diseases. Certain examples at least we'll see. So the HLA DR3, DR4 is associated with diabetes mellitus. Then HLA-B8 is associated with myasthenia gravis and Graves' disease. Both the Graves are associated with HLA-B8. Then HLA-B51 is for Behçet's disease, which is a vasculitis disease associated with multiple genital and oral ulcers as well as uveitis. Then HLA-B27, this list very, very important. Ankylosing spondylitis, Reiter syndrome, and reactive arthritis. These three examples are very important for HLA-B27 associated diseases. Then HLA-CW6 is for psoriasis. Okay. Then coming to hypersensitivity reactions. Here in hypersensitivity, again, it is the examples which are important. So in type 1 hypersensitivity, it is also called as the immediate type of hypersensitivity. It is usually associated with allergy, atopy kind of reactions. So with the first exposure of the antigen is going to be taken up by the T cell, antigen presenting cell, which will present it to the T cell. The T cell will then get differentiated into the Th2 subset. Okay. So Th2 subset, what were the interleukins I told? Interleukin 4, 5, and 13. So when interleukin 4 is being produced, it is going to cause IgE production, interleukin 5, eosinophil activation. So these IgE is then going to go and coat onto the mast cells. Okay. So it is going to sit on the mast cell like this. Then with subsequent exposure of the antigen, what will happen? Immediately the mast cell will degrade. The antigen will directly come and attach to the IgE, which is present on the mast cell, and it will cause degranulation of the mast cell. So mast cell contains many vasoactive amines like histamine, serotonin, and all these things. So once they are released, they are the ones which are responsible for the itching, redness, vasodilatation, which happens in this allergy reaction. Okay. So the early phase of this type 1 hypersensitive reaction is actually mediated by the histamine. And the most important cell in type 1 hypersensitivity itself is the mast cell only. Okay. The late phase of the type 1 hypersensitivity reaction is the one which is mediated by the other inflammatory mediators like prostaglandins, leukotrienes, cytokines. Okay. They are the ones which are responsible for the tissue damage. Always remember, eosinophils, whenever they are present, they are always associated with tissue damage. They cause fibrosis and tissue damage. So type 1 early phase was just the early preformed mediators release, like degranulation of the mast cell. So it is histamine. While type 2, late phase of the type 1 hypersensitivity reaction, it is going to take some time to form. The mediators should form and then it will cause damage. So that is because of the newly formed mediators like prostaglandins and cytokines, right? And the most important cell, if they ask, it is the mast cell. Don't tick eosinophil. Okay. Most important cell for type 1 hypersensitivity is the mast cell, which is the one which is releasing the histamine, right? If they ask specifically for the late phase, which is responsible for the tissue damage, then it is the eosinophil, right? So examples again, atopy, hay fever, rhinitis, allergic rhinitis, then anaphylaxis, bronchial asthma. These are all examples of type 1 hypersensitivity. Type 2 hypersensitivity, it is also called as antibody mediated hypersensitivity. And here the antibody is actually against the fixed antigen. So the antigen is fixed on the tissue and the antibody will come and attack it. They'll form the antigen antibody complex. They then together activate the complement and cause damage. Okay. So the examples of type 2 hypersensitivity reaction are usually related to blood. Okay. So RH incompatibility, blood transfusion reactions, autoimmune hemolytic anemia, autoimmune thrombocytopenias. These are all examples. Apart from that, we have specific examples: good pasture syndrome, myasthenia gravis, and Graves' disease. In fact, these two, myasthenia gravis and Graves' disease, are considered as type 5 hypersensitivity. Okay. Just in case you remember. Okay. Both the Graves are type 5 hypersensitivity, which is actually a part of the type 2 hypersensitivity only. So good pasture syndrome, acute rheumatic fever, all these are examples of type 2 hypersensitivity. Again and again, I'm telling examples are important in hypersensitivity reactions. Then moving on to type 3 hypersensitivity reactions, it is immune complex mediated hypersensitivity reaction. Here, the antigen is going to be circulating in the blood. So it is not on the fixed tissue, it is going to be circulating in the blood, and there the antibody will go and attach with this antigen, and then they'll form the immune complex, then attract complements and activate the complements as such, causing damage. So remember, when we are discussing fibrinoid necrosis, I told it is related with the type 3 hypersensitivity reaction. There the examples we read were SLE, PAN, malignant hypertension, and RHD, right? So all of these will again be examples of type 3 hypersensitivity as well. So SLE is as such both type 3 and type 2 hypersensitivity reaction, but more of type 3. So how do you remember? SLE is 3 letters, so type 3 is more, okay? So PSGN, which is post-streptococcal glomerulonephritis, arthritis reaction, reactive arthritis, polyarthritis nodosa, malignant hypertension. Wherever you see fibrinoid necrosis, all of it are examples of type 3 hypersensitive reaction. Then type 4 hypersensitivity reaction, it is also called as delayed type or cell-mediated hypersensitivity reaction. Cell-mediated because it is mediated by cells, which is lymphocytes, CD4 and CD8. Okay, so here it is the classical thing which describes the delayed type of hypersensitivity will be a granuloma formation. Not always, but many times. So whenever granuloma formation is there, I told interferon gamma will come, which was produced by the T helper 1 subset. Remember, so T helper 1 subset is the most important one for this cell-mediated hypersensitivity in CD4. CD8 can also result in this cell-mediated hypersensitivity. So the examples of these will be infections, whatever infections which produce this granulomatous inflammation, you can tell that. Apart from that, rheumatoid arthritis, contact dermatitis, then we have psoriasis, type 1 diabetes, then inflammatory bowel disease. All these are examples of type 4 hypersensitivity. If they ask allergic dermatitis, is this type 1 hypersensitivity? Contact dermatitis is this type 4 hypersensitivity. So I've given a recap of all the examples here. Do go through that. This antigen sequestration, I just want to put in a word. So there are certain sites in the body, like the brain, eye, and testis, wherein the antigens are never exposed to the body's own immune system at all. So once they come into the circulation, the body will actually think that it is not of its own, and it will think it as foreign and immune, and it will mount an immune response against those antigens. Okay, so that is why whenever there is post trauma to the eye, there is trauma to one eye and it is causing uveitis, it will still affect the second eye because the eye antigens are normally not exposed. So with trauma, it will get exposed, and the antibodies which are formed is going to attack the normal antigens which are present in the other eye as well. So always post-traumatic uveitis will present as a bilateral thing. So the immune privileged sites wherein hidden or cryptic antigens are present are usually examples are brain, eye, and testis. Better. Okay. Then moving on to autoimmune disorders, first is SLE. SLE, I already told, it is a hybrid of type 2 and type 3 hypersensitivity, but more of type 3 hypersensitivity. And it is usually associated with certain drugs like SHIP drugs, which is the normal mnemonic we use for. SHIP stands for sulfonamides, hydralazine, isoniazid, and procainamide. So these drugs, apart from many other causes are there, these drugs can also trigger a drug-induced lupus nephritis. The drug-induced SLE, okay? So I'm not going into the criteria for diagnosis of SLE. So certain important points around I'll tell. So under the criteria, the patients can develop alopecia. So there the alopecia is going to be non-scarring type of alopecia. And arthritis also, it is a non-erosive type of an arthritis. And ulcers, they tend to get multiple oral ulcers, access ulcers, they are going to be painless. Okay, everything is like a good kind of thing you think, okay? Non-scarring, non-erosive, painless. Then renal thing, it has specific criteria for diagnosing. It is called as lupus nephritis. Under lupus nephritis, we have 6 classes, out of which the type 4 class is the most important and the most common one also, which is called as the diffuse proliferative lupus nephritis. Why is it important is that this there is a classical finding which we see in a lupus nephritis, which is called as the wire loop lesions. So wire loop lesions are usually because of the subendothelial immune complex deposits which we see in the glomerulus. So the wire loop lesions are actually proportional to the severity of the disease. As the number increases, the severity is also going to increase. So these wire loop lesions are usually seen in class 3, 4, and 5, but more common in type 4, which is again the most common type of lupus nephritis. right? Then coming to the immunological criteria for diagnosing SLE, they are going to have multiple antibodies. That is why it is an autoimmune disorder, right? So multiple antibodies are going to be present. Out of that, anti-nuclear antibodies, ANAs, are going to be the most sensitive antibodies. But if they ask the most specific, it is going to be anti-Smith antibody. While if it is both sensitive and specific, they are asking together, it is going to be anti-dsDNA, double-stranded DNA antibody. Anti-dsDNA, it is name itself has double, right? Double-stranded DNA. So double means both sensitive and specific. Remember it that way. ANA is the most sensitive, while anti-Smith, Smith has a name, right? So it is specific for some person. So that is most specific. Apart from that, don't scold me, there are so many antibodies related with SLE. These are specific things which they ask also. Anti-Ro antibodies is associated with shrinking lung syndrome and also neonatal lupus. So in SLE, one of the features in the lung is called as shrinking lung syndrome. So when that feature is there, it is going to usually have this anti-Ro antibodies. So anti-Ro antibodies, you'll also be reading it in Sjogren's syndrome, okay? But anti-Ro antibodies are also seen in SLE, especially in the shrinking lung syndrome and neonatal lupus. Then anti-ribosomal P antibody. So psychosis is one of the features of SLE. So P for P. Anti-ribosomal P antibodies are associated with psychosis. Then anti-beta-2 glycoprotein antibodies are associated with anti-phospholipid antibody syndrome. APLA syndrome is anti-phospholipid antibody syndrome. So APLA syndrome, usually the patients have multiple episodes of thrombosis. Lots of thrombus will be formed, and usually the history will be a female coming with multiple abortions back to back. Okay, so the thrombus will not allow the fetus to grow. The placental insufficiency will be caused, and the fetus will die. Okay, so APLA syndrome, it is usually having many antibodies, 3 antibodies basically. The most important one of which is the anti-beta-2 glycoprotein antibody. This APLA syndrome is also associated with SLE. Then anti-histone antibody is for drug-induced lupus. I told SHIP drugs, right? So whenever the SHIP drugs are going to cause lupus, it is going to be having this anti-histone antibody. So these are again questions here. Then apart from the other criteria for SLE, we have certain features as well. So in lung, I told we are going to have shrinking lung syndrome. But as such, serositis is the most important feature and the most common feature which we see in the lung in a SLE patient. So serositis, it could be pericarditis, pleuritis, peritonitis, anything. So pleuritis is the most common lung feature. So in heart, we have a specific thing called as Liebman-Sachs endocarditis. So Liebman-Sachs endocarditis, if you see, it is LSE, SLE, LSE. Okay. So that is the feature we see in heart. Spleen, there is going to be onion skinning of the splenic vessels. Okay, onion skinning of the splenic vessels is going to be seen in SLE. Then moving on to Sjogren's syndrome. Sjogren's syndrome we have, it is also called as Zika syndrome. Why? Zika means dry. So we have dry eyes and also dry mouth. Dry eyes because lacrimal glands are affected, dry mouth because the salivary glands are going to be affected. So there is going to be xerostomia, and then keratoconjunctivitis, Zika. And as such, there is going to be an increased risk of developing marginal zone lymphoma in these patients. So any autoimmune disorder, obviously, this a chronic inflammation is going to be there. So lymphocytes will come in. So whenever there is a chronic inflammation and lymphocytes are there, they tend to develop into a maltoma, which is marginal zone lymphomas. Okay. One such example is a Sjogren's syndrome. So diagnosis, I already told, 2 antibodies, anti-Ro and anti-La antibodies. Anti-Ro was also seen in shrinking lung syndrome and neonatal lupus. But anti-Ro is the most sensitive antibody for Sjogren, while anti-La is the most specific antibody for Sjogren's. So how do you diagnose this Sjogren syndrome? They usually tend to take the lip biopsy. So from the lip, they'll take the biopsy. So lips contains this minor salivary glands. So in the minor salivary glands, we can see multiple lymphocyte aggregates along with destruction of the gland and fibrosis. So moving on to the next autoimmune disease, which is the systemic sclerosis. Systemic sclerosis, anywhere you see sclerosis, it means something related to collagen. Fibrosis is going to be there. nodular sclerosis in Hodgkin's lymphoma. So there again, there is going to be collagen bands. So sclerosis means there is going to be fibrosis. So here, another hallmark coming again. So hallmark of systemic sclerosis is microvascular injury. So when the vessels are being damaged repeatedly, it is going to result in ischemia, then damage, and then inflammation and fibrosis. Okay. So systemic sclerosis is again divided into two things: limited form and a diffuse form. Limited, as the name suggests, it is going to usually involve only the skin. So skin is going to be quite fibrous and thickened. So here the antibody associated with limited systemic sclerosis is anti-centromere antibody. And limited, there is also a syndrome associated with it called as CREST syndrome. It is an acronym. So CREST stands for calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Okay, so all of these features are features seen in limited systemic sclerosis. Under diffuse, you get to see involvement of skin and early visceral involvement. Multiple organs will be involved. The patient will have a very hard time. So everything will be fibrous. The lungs cannot expand. They cannot eat food. The esophagus will have strictures. So quite pathetic. So here the antibody associated with diffuse systemic sclerosis is anti-topoisomerase antibody. So if they ask the most specific antibody, it is the anti-topoisomerase antibody. But again, most sensitive antibody here is the anti-nuclear antibody. So ANAs were most sensitive for both SLE and systemic sclerosis. Most specific for SLE was anti-Smith, but more specific for systemic sclerosis is going to be anti-topoisomerase antibody, while anti-centromere antibody is for limited form of systemic sclerosis. Then coming to inflammatory myopathies, we have three major classes of inflammatory myopathies. First one will be the dermatomyositis, polymyositis, and inclusion body myositis. So as the name suggests, dermatomyositis. Dermo means skin. Myositis means muscle. So inflammation of both the skin and muscle is going to be there in dermatomyositis. And here, three classical features will be seen. That is heliotrope rash, that is a lilac color. Lilac is somewhat a purplish violet color. Okay. So lilac colored rash will be seen around the eyes, especially here. Okay. So heliotrope rash, then Gottron's papule and mechanic's hand. Gottron's papules is on the knuckles, they'll have some damage. So that is Gottron's papule. Mechanic's hands is they'll have rough skin like a mechanic's hand. So that is mechanic's hands. These three are features of dermatomyositis. And in dermatomyositis, you get to see perifascicular atrophy and inflammation. So in the muscle, if this is the muscle fiber, so around the fascicle, you will have inflammation. So this entire muscle fiber is there. So the inflammation is going to be around the muscle fiber. So perifascicular atrophy and inflammation is a feature of dermatomyositis, which has heliotrope rash, Gottron's papules, and mechanic hands. And both polymyositis and dermatomyositis are proximal muscle weakness. So the patient will have weakness in the proximal muscles, while the inclusion body myositis is usually the distal muscle weakness. So they'll not be able to do fine finger hand movements. Okay. And the antibodies associated with dermatomyositis are anti-Jo1 antibody, anti-Mi2 antibody, anti-P155 antibody, and anti-P140 antibody. No other go. At least you must be able to recognize the answer if they ask in MCQs. Just you remember it. Okay. Anti-Jo1, anti-Mi2, anti-P155, and anti-P140 antibodies are associated with dermatomyositis. While polymyositis, as the name suggests, it is only muscle, but multiple muscles are going to be inflamed here. And here the important point is there is going to be an endomysial inflammation. That is inside the muscle fiber itself, there is going to be inflammation, not the perifascicular one. So endomysial inflammation is for polymyositis. Here again, there is going to be proximal muscle weakness. There is no skin involvement. So inclusion body myositis, as the name suggests, there is going to be some kind of inclusion seen in the muscles. That much you understood, right? So this inclusion body myositis is the myositis which we see in elderly people. So here they have distal muscle weakness, and then the antibody associated will be anti-5-nucleotidase. This one you don't need to remember. So they usually have rimmed vacuoles, which are inclusions. The rimmed vacuoles will appear as inclusions in the muscle biopsy, right? So these are again important questions. Then IgG4 related disease, only one thing you need to remember because it is a triad. In IgG4 related diseases, there is going to be elevated amounts of serum IgG4 along with tissue infiltrates of plasma cells which produce this IgG4. Then we have obliterative phlebitis, Phlebitis means vessel. So vessel is inflamed and is going to obliterate the lumen of the vessel. So obliterative phlebitis. Then storiform fibrosis. Storiform means it is going to look like a wheel. So the fibrosis is going to have the appearance of the wheel. So this is the classical triad of IgG4 related diseases: obliterative fibrosis, obliterative phlebitis, storiform fibrosis, and elevated IgG4 levels with tissue infiltrates of plasma cells which produce the IgG4. Okay. Then coming to immunodeficiencies, I'll just tell the important ones alone. So in primary immunodeficiencies, we have DGOT syndrome. So DGOT syndrome is chromosome 22 Q11 deletion. Okay. So where else did we see this chromosome 22? It was in vertical trisomy 22. Remember, multiple vertical colobomas are present. And also chromosome 22 is the gene for neurofibromatosis, both 17q and 22q. Okay. So chromosome 22q11 is for DGOT syndrome. Here, what happens is that the gene which is responsible is the TBX1 gene. It is responsible for the formation of the brachial arches, second and third. So thymus, the great vessels, parathyroids will not be formed when it is defective. So when thymus is not formed, obviously the T cells will not be formed. So when T cells are not formed, the immunity will go down. Without T cell help, the B cells cannot function properly. They cannot produce the class switching and isotype switching and affinity maturation, right? So B cells will also be affected. And apart from that, when parathyroids are not being developed, so calcium will not be produced. So that will result in tetany. And then great vessels, the aorta, all of this goes here, right? The arch of the aorta. So the great vessels anomalies will also be present. So congenital heart disease can also be present. So this is the triad for DGOT syndrome. They also give the mnemonic of catch-22 for this. Okay. Then isolated IgA deficiency. This is the most common primary immunodeficiency as such. And IgA is related with the mucosal immunity. So respiratory infections and GIT infections are quite common in this. Coming to Bruton's A gamma globulinemia, you have to read it in parallel with QID, which is common variable immunodeficiency. So Bruton's A gamma globulinemia, if you remember, it was an example of X-linked recessive disorder. So X-linked recessive is going to only affect the male because females are only the carriers. So here B for B, Bruton's for B, and it is a B cell defect. So here as such, from the precursors, the mature B cell is not being formed. Okay, this is the first step. From the precursors, mature B cell is not going to be formed in Bruton's. So B cell defect affecting the boys, and A gamma globulinemia, as the name suggests, there is not going to be any immunoglobulin production. So the child usually presents within 1 year of age. Usually after 6 months of age, the child will present, and the defect here is going to be of the BTK, which is Bruton tyrosine kinase defect. That is the one which is responsible for the maturation of the B cells. So that is going to be defective. So more than 6 months of the age, the child will present with n number of infections, starting from respiratory, GI, every infection. Okay. Coming to QID, if you see, in QID, it is the B cells will not mature onto plasma cells. Okay, the first step was B cell precursors to mature cells, then mature cells to plasma cells. So the first step was defective in Bruton's A gamma globulinemia. The second step was defective in the QID. Okay, so plasma cells will not be formed in QID. So in QID, the usual history which will be given will be Giardia infections. Okay, Giardia is a intestinal parasite which is going to affect. So Giardia infections are common with QID. And here it is both sex will be affected. There Bruton's was for boys only, X-linked recessive, but here both sexes are affected, and the onset is slightly elder than that of the Bruton's. Okay, childhood onset, not within a year. Then coming to ataxia telangiectasia. Ataxia telangiectasia, it is actually a DNA repair defect here. So ATM gene is going to be defective. ATM gene is located on chromosome 11. So here there is going to be multiple recurrent infections happening. Apart from that, they are at a high risk for developing multiple cancers and lymphomas, skin cancers also, neurological defects, and then lymphomas and cancers. Then Wiskott-Aldrich syndrome. So Wiskott-Aldrich syndrome, the gene is going to be VASP. Okay, Wiskott-Aldrich syndrome. So VASP gene defect, here again it is an X-linked recessive defect. So here it is a triad of this thrombocytopenia, eczema, and recurrent infections. Okay, platelets will be less and also small. So thrombocytopenia, eczema, and then recurrent infections are the classical triad of Wiskott-Aldrich syndrome. Here again, they are at an increased risk of developing lymphomas. Moving on to secondary immunodeficiencies, obviously HIV is the one which comes to our mind, caused by AIDS, which is caused by HIV virus. So here I'm not going into the details again. Certain points alone I'll highlight. So the normal CD4 count is the T cells, right? CD4 count is going to be 500 to 1000 microliter. When it goes less than 300 microliter itself, the patient will start having opportunistic infections. So multiple infections will take over, and that is the one which actually kills the person, not the HIV as such. Okay, HIV is not a killer disease; it's the opportunistic infections and other comorbidities which kill the person. So less than 300 microliter, it is opportunistic infections. Less than 200, we label it as AIDS syndrome. Less than 100, they are at a risk of developing cryptococcal infections. Less than 50, they are at a risk of developing CMV and also CNS lymphomas. So normal CD4 to CD8 ratio I told was 2:1, right? Here it will be reversed because CD4 cells are the ones which are being affected by the HIV virus. So they'll be dying. So CD4 count goes down. So automatically CD8 will appear that it is high. Okay, so CD8 will be increased. Reversal of CD4 CD8 ratio will be C. So in opportunistic infections, we have the most common one being tuberculosis. In our country, definitely it is tuberculosis, which is the most common. And most common fungal infection, if they are specifically, it is Candida. Most common ocular infection, it is CMV retinitis. I'll give break after I complete this chapter, okay? So most common ocular infection was CMV retinitis. And other than that, we have multiple infections which are happening. Then there is certain neoplasms which are specific for HIV. Not that it is specific for HIV. These are the only ones which are labeled as AIDS defining neoplasms. Even though they are prone for many cancers, only these three can be taken under AIDS defining neoplasms. So what are the AIDS defining neoplasms? First is the Kaposi sarcoma. So initially Kaposi sarcoma was the most common sarcoma related. Now it has changed to lymphoma. So lymphoma is the most common lymphoma, that too DLBCL type, diffuse large B-cell lymphoma. That is the most common neoplasm associated with AIDS. Second will be the Kaposi sarcoma. Third one will be the cervical cancer. So cervical cancer, we all know it is associated with human papilloma virus. So it is also a sexually transmitted disease. HIV is also sexually transmitted. So when both of them come together, it is going to be a very bad combo. Okay. Then again, some other most common. So the most common space occupying lesion in a HIV patient in the CNS is going to be toxoplasmosis. Okay. They just ask it is a space occupying lesion. It is an infective causes should come before any neoplastic condition. Remember, okay. Just space occupying lesion, it is toxoplasmosis. If they are specifically space occupying CNS tumor, then you will have to answer it as NHL, which is the DLBCL type. Okay. Most common hematological manifestation will be the autoimmune hemolytic anemia, IHA. Most common dermatological will be seborrheic dermatitis. Most common neurological symptoms will be AIDS dementia complex. Most common renal is going to be HIVAN, which presents as HIV-associated nephropathy, which presents as the focal segmental glomerulosclerosis, FSGS. Okay, so at least you must remember these three things, right? So how do you confirm HIV? You do ELISA as a screening test, but confirmation will be done with the help of Western blot. But there is a time called as window period wherein the infective organism will not be detected in blood. It can be detected only with the help of RT-PCR test. Then coming to the most important topic in immunity, which is amyloidosis. So, so amyloidosis, amyloid is basically a fibrillary protein, which is going to be extracellular. So extracellular protein, which doesn't have any form. So it is called as an amorphous extracellular. It is never ever intracellular. Okay. Amyloid is always extracellular and it is amorphous pink material, fibrillary protein. So it is aggregation of some misfolded proteins only. So the structure of an amyloid protein is a fibrillary protein. And if they ask, this is the most important asked question here. So electron microscopically, amyloid will appear as continuous non-branching fibrils of infinite length. Okay, length is going to be infinite, continuous, non-branching, like a straight wire. It is going like this, and the diameter of the wire is going to be 7.5 to 10 nanometer. Length is infinite, only the diameter is 7.5 to 10 nanometer. Remember. So these are just fibrils like this. And only on X-ray crystallography or infrared spectroscopy, you see it as a beta pleated sheet. So don't answer it ulta like this. So on electron microscopy, it is going to appear as fibrils. Only on X-ray crystallography or spectroscopy, it is going to appear as beta pleated sheet. And this beta pleated sheet is the one which is responsible for the most characteristic appearance of this amyloid on Congo red stain. Remember? So Congo red stain is the special stain used to highlight amyloid. And on Congo red, if they plainly ask, it is just going to give a pink color. But if they put it under polarized microscopy, only then you see this apple green birefringence. Okay, so apple green birefringence, this appearance is actually because of the beta pleated sheet of this amyloid. Okay, so never ever forget Congo red stain, apple green birefringence, beta pleated sheet, then continuous fibrils. So these are the most important questions under amyloid. So examples of amyloid, again, they are important. So the most common form, which is the primary form of amyloidosis, is the AL form. A stands for amyloid, and L stands for whatever protein is forming the amyloid. Okay, so L stands for the light chain. So amyloid light chain AL is going to be seen in multiple myelomas. The most common amyloid is going to be the AL. Okay, and we have various other amyloids. So we have AA, which is amyloid associated, which is derived from the protein SAA, serum amyloid associated. Okay, SAA is the protein which is forming this AA. So it is associated with any chronic inflammation. So any chronic inflammatory diseases can usually present with this amyloid. So AA is there. Then we have A beta 2 microglobulin. So A beta 2 M is for A beta 2 microglobulin, which is seen in chronic renal failure. So in patients undergoing dialysis for chronic renal failure, they tend to develop this A beta 2 microglobulin. Then again, we have familial amyloidotic polyneuropathy, which has ATTR, which is amyloid mutant transthyretin. So transthyretin has two forms, which is the wild type and the mutant type. Wild is the normal one. Okay. So the wild type is the wild type of transthyretin is going to be accumulated in systemic senile amyloidosis, while this mutant type of transthyretin is going to be associated with familial amyloidotic polyneuropathy. So as the name suggests, here the nerves are going to be affected, while in systemic senile amyloidosis, it is the heart which is going to be affected by the amyloid. So localized amyloid, again, the amyloid which is seen in the Alzheimer's disease brain, A beta plaques. So those are again amyloid only. And that beta, if you remember, I mentioned while we were discussing Down syndrome also. It was derived from the amyloid precursor protein APP. Okay, A beta. Then other amyloids are ACAL. Cal stands for calcitonin. So ACAL, the only cancer which is associated with amyloid is medullary carcinoma of thyroid. So very, very important. Medullary carcinoma of thyroid associated with amyloid, and that is amyloid calcitonin. Okay, so because there is going to be elevated production of this calcitonin, which is forming this ACAL. Okay. So organs affected in amyloid, most commonly it is going to be the kidney, but in elderly, if they are specifically, it is the senile systemic amyloidosis, which is wild type transthyretin. So it is going to affect the heart. And in heart, restrictive cardiomyopathy. In fact, the most common cause for restrictive cardiomyopathy is amyloidosis. Then in kidney, it can accumulate at any of the place extracellularly. In liver, it is going to accumulate in the space of disease, while in the spleen, two important things again. We have Sago spleen and Lardaceous spleen. Sago spleen, Sago means Javarisci, okay? Sago is that small white color round eatable we have. So the spleen is going to appear like a sago. So multiple sagos are there. It is the sagos are actually representing the white pulp of the spleen, the follicles, okay, lymphoid follicles. So that is going to have this amyloid deposition. So that we call it as sago spleen affecting the white pulp. But when the amyloid is deposited in the red pulp, which is the sinusoids, so the red pulp is affected, it is going to give a map like geographic appearance, because white pulp is like this, in between whatever this area is going to appear like map only. So if that amyloid is depositing in those areas, obviously it is going to appear in a geographic map like appearance, which is termed as Lardaceous spleen. So remember, Lardaceous, you can pronounce it as Lardaceous, okay, RD. So that is for red pulp. Lardaceous for red pulp. So coming to diagnosis of amyloidosis, not going into details again, the special stains, only congruent stain you need to remember, apple green birefringence on polarized light. And biopsy is the actual standard method for diagnosing. So biopsy, you can, initially it was rectal mucosa. Abhi, they had changed it into abdominal pad of fat. So the abdominal pad of fat biopsy will be taken, and if you put congruent stain and see it under polarized light, you can see the apple green birefringence. So in transplant and graft pathology, transplant rejections are important. We have three types of transplant rejections, which is hyperacute, acute, and chronic. Only three questions I will tell in this. Hyperacute form is the immediate type, as the name suggests. So within 48 hours, the rejection will happen. And it is because, obviously, if it is happening so suddenly, so quickly, it means that something has been already kept in stock. So it is due to preformed antibodies against the graft antigens. Okay. So preformed antibodies is the one responsible for hyperacute rejection. Then coming to acute rejection, it is both acute cellular and humoral. That is T cell mediated also, and also B cell mediated. Humoral is B cell antibody mediated, right? So for the marker of this acute humoral rejection is going to be C4D, complement 4D. So complement 4D is the one which gets deposited on the vessels, and it is a marker of acute humoral rejection. Chronic rejection, anything chronic, I told, it is associated with tissue injury and fibrosis. So any fibrosis, graft arterial sclerosis, graft itself will get fibrosed as such. So that is chronic rejection. And the most common cancer in a patient who has undergone a transplant, you will expect it to be something else, but it is actually a skin cancer. So mostly the patient is prone for when they undergo transplant, they undergo chemotherapy and not chemotherapy, immunosuppression therapy, right? So when they have immunosuppression therapy, obviously they are prone for multiple cancers, and the most common cancer is skin cancer more than non-Hodgkin's lymphoma. GVHD, actually previously they were graft versus host disease. Previously they were dividing it into acute and chronic based on the number of days. Acute was called as less than 100 days, and chronic was called as more than 100 days. But that criteria has been currently removed, and it is only the manifestations which determine whether it is an acute or a chronic GVHD. So we have finished till immunity. Let's take a break for 5 minutes. I'll be back by 8:05. Okay. Shall we start? Next, we'll start with neoplasia. So neoplasia, it as such means it is a new growth. It's crab. Okay, that is what cancer. The word actually means it is crab. Okay. So under neoplasia, again, we'll discuss the important points alone. So the hallmark of malignancy. So till now we had seen many hallmarks. So include this also in the list. So hallmark of malignancy is anaplasia. So anaplasia means that there is lack of differentiation. Okay, so differentiation is nothing but how far the cell resembles its parent organ. Okay, suppose we take a hepatocellular carcinoma, we call it as a well-differentiated carcinoma if it resembles more like the normal hepatocytes, and a poorly differentiated carcinoma if it is a if it is very anaplastic, okay, that it doesn't resemble the parent organ. So anaplasia is the hallmark of malignancy. And here, do not confuse this with dysplasia and metaplasia. Metaplasia was the reversible cellular adaptation which we saw. It is just changing of one differentiated cell type to another. While dysplasia is going to be disordered growth, D for D, disordered growth. So the cell will become the nucleus cytoplasmic ratio will increase, the cell will be pleomorphic, and then there is going to be loss of polarity with mitosis. So all of these changes are pre-neoplastic changes. So there, when dysplasia is there, it is pre-neoplastic, meaning the basement membrane is not breached, it is still intact. But in anaplasia, it has already become malignant, meaning the basement membrane had already breached. So the same features of dysplasia will be there, the disordered growth will be there, but as such, the base membrane is going to be breached in anaplasia. Then local invasion, it is the second most reliable feature of malignancy after anaplasia. Then metastasis. So metastasis, we usually know it is spread of spread of a tumor to distant sites, which is not in connection with the parent organ. But all cancers can metastasize, except that basal cell carcinoma. So basal cell carcinoma, it is also given the name of rodent ulcer, right? Why? Because it buries into the skin, it goes deeper and deeper. Surrounding tissues are being eaten up. So that is basal cell carcinoma. It actually has it just burrows into the tissue. That is why it's called as a rodent ulcer. It usually doesn't metastasize. Then gliomas. So gliomas are brain tumors, as glial cells tumors. So these gliomas also don't metastasize usually. Okay. So in general, the rule is carcinomas have a lymphatic spread while sarcomas have a hematogenous spread. Okay, but there are always exceptions to this. So the exceptions alone I'm going to mention. So the exceptions for carcinomas which are having a hematogenous spread are hepatocellular carcinoma, renal cell carcinoma, choriocarcinoma, follicular carcinoma of the thyroid. In fact, follicular carcinoma thyroid has this bone metastasis which causes pulsatile bone metastasis, right? So follicular carcinoma of thyroid, HCC, RCC, choriocarcinoma, they are usually invading the vessels, blood vessels, basically. Hematogenous spread, sarcomas usually have hematogenous spread, except for certain sarcomas. Important ones are synovial sarcomas, angiosarcomas, clear cell sarcomas, epithelioid, and rhabdomyosarcoma. So previously, the mnemonic used for this was MARSES. M for malignant fibrous histiocytoma. You don't have to go into the details, okay? A for angiosarcoma, R for rhabdomyosarcoma, C for clear cell sarcoma, E for epithelioid sarcoma, and then S for synovial sarcoma. Then this one is important. So usually bone metastasis, it happens with certain cancers only, okay? Main thing, if it's a female, you'll have to first think about a breast, and if it's a male, you have to first think about prostate. Especially when they complain of low backache in the male, you'll have to rule out prostate cancer first, okay? And prostate is usually an osteoblastic metastatic cancer, okay? Blastic means it is growing, so bone is growing, so osteoblastic metastasis. While kidney, intestine, and thyroid, KIT, okay? So KIT is going to be osteolytic bone metastasis, while breast, lung, and liver are going to be both. Then moving on to the hallmarks of cancer. So hallmarks, we all have studied those 8 points, which was in Robbins long back, right? So apart from that, they have added 2 other features, which are called as cancer enabling characteristics. So these are cancer promoting inflammation and genomic instability, which has been newly added in Robbins. So not going into the everything again and again. So first hallmark, which is the self-sufficiency of growth signals, it deals with the oncogenes and proto-oncogenes. So oncogenes are of 5 classes: growth factors, growth factor receptors, nuclear transcription factors, cell cycle regulators, and also signal transduction proteins. So these 5 are there. So specific examples alone you need to remember. So EGFR, at least you must know whether it is a proto-oncogene or a tumor suppressor gene. Okay, then you will have to remember some of the important genes which is associated with certain cancers. For example, this EGFR, which is also called as ERB1, is associated with lung cancer. It is quite important because nowadays we have targeted therapy for this EGFR. We can give gefitinib and erlotinib. And HER2 is ERB2, which is associated with breast cancer. Then RET is associated with medullary cancer of carcinoma of thyroid. Then CD117 or KIT mutations are associated with GIST and seminoma. Then coming to the next category of oncogenes, the signal transduction proteins, and the most common, this is an important question, most common oncogene mutated in tumors. If they just ask most common gene mutated in tumors, it is going to be TP53, which is as such a tumor suppressor gene. But they specifically ask for most common oncogene mutated in tumors, then you will have to answer RAS. Even in that, the KRAS is the most common one. These examples you don't have to remember. ABL is again an oncogene. So ABL, where do you read? BCR-ABL gene. Remember, BCR-ABL gene is the fusion protein which we see in chronic myeloid leukemia. The characteristic feature, the defining features of a feature of CML itself is the fusion of translocation 922. So translocation 922 will result in the fusion of the protein BCR-ABL, and this ABL is as such a proto-oncogene. Okay. So what happens in CML is that this fusion protein which is being formed is going to increase the tyrosine kinase activity. So that is what is going to result in the proliferation of the myeloid cells, resulting in leukemia. So if we as such target this tyrosine kinase which is being activated, then we can control CML. So that is when the breakthrough of CML treatment happened. So the TK inhibitors, imatinib was started. So imatinib, and then the subsequent nilotinib, everything had come now. So imatinib was the first drug which was started for CML, which is targeting this BCR-ABL transcription fusion protein, okay, which is increasing the tyrosine kinase activity. Then BRAF. BRAF is a very important oncogene. It is mutated in many cancers. Most important ones are melanomas, Langerhans cell histiocytomas, and hairy cell leukemia. In fact, in hairy cell leukemia, it is 100%. So 100% BRAF mutation will be there in hairy cell leukemia. Then MYC. So MYC is MYC. So nuclear regulatory proteins is again a proto-oncogene. So here we have CMYC, LMYC, and NMYC, one of the worst genes possible. So this CMYC, if it gets mutated, it is seen in Burkitt's lymphoma. So Burkitt's lymphoma is an important question in MCQs. So Burkitt's lymphoma, it is a very highly proliferative lymphoma, non-Hodgkin's lymphoma, in which CMYC expression is going to be amplified. So in Burkitt's lymphoma, every translocation will be related to 8, okay, 8th chromosome. So chromosome 8, 14, 2, 8, everything will be there. So 8 is the number in which this CMYC is going to be present. Okay, so CMYC amplification is the one which results in Burkitt's lymphoma. Then we have LMYC and NMYC. N for N, so NMYC for neuroblastoma, LMYC for L, so lung, small cell lung cancer. Okay. Then coming to cell cycle regulators. Don't get scared by seeing this diagram. It is the simplified version actually. So cell cycle, we all know, it progresses from the G0 phase to G1 phase. Then it goes to the synthetic phase. Then it goes to G2 phase and then comes to the mitotic phase. And after that, the cell exits. So there is checkpoints in each 2 of these levels. One is the G1S phase and the other one is the G2M phase. So the G1S phase is going to be controlled by the checkpoint, which is RB gene, which is a tumor suppressor, retinoblastoma gene, which is a tumor suppressor. G2M is going to be controlled by the next tumor suppressor, which is the TP53 gene. Out of this, if they ask where radiation can affect, in which phase the radiation can cause cell cycle mutation, it is in the G to M. So G to M phase is quite radio sensitive. Okay, as such, you just need to remember this table. So we have various cyclins and cyclin dependent kinases which help in the progression of the cell cycle. So basically cyclins and cyclin dependent kinases are proto-oncogenes. They help in progressing the cell cycle, proliferation basically. But RB and P53 were trying to break, they were trying to proofread whatever is happening. So they were tumor suppressor genes, right? So in the cyclins, we have 4 cyclins: cyclin D, cyclin E, cyclin A, cyclin B. Remember in this order only, D, E, A, B, D, okay? Cyclins D, E, A, B. Apart from that, we have cyclin dependent kinases. As the name suggests, these kinases are dependent on the cyclins. So cyclin dependent kinases, we have 4, 6, cyclin dependent kinase 2 and 1. So this is the way in which you write and remember it, okay? Cyclin dependent kinase 4 and 6 are associated with cyclin D. Cyclin dependent kinase 2 is associated with cyclin E. Then cyclin dependent kinase 2 and 1 are associated with cyclin A, while cyclin dependent kinase 1 is associated with cyclin B. Okay. Out of this cyclin D, E along with the cyclin dependent kinases 4, 6, and 2 is involved in the G1S phase. While in the synthetic phase alone, it is the cyclin A along with the CDK 2 and 1. While in the G to M phase, it is only the cyclin B along with the cyclin dependent kinase 1. Okay, so this is important. At least you must remember these two. Okay, cyclin dependent cyclin D along with cyclin dependent kinase 4 and 6, which is present in the cyclin G1S phase of the cycle. So when there is something positive, obviously there is something which is regulating it. So there is something called a cyclin dependent kinase inhibitors. Okay. So these cyclin dependent kinase 4, 6, 2, 1, 1, all these things were there, right? So these are going to be inhibited by the cyclin dependent kinase inhibitors. So in inhibitors, we have 2 families, which is CYP family and the INK4-ARC family. So in the CYP family, we have 3 members, P21, P27, and P57. Okay, so these P21, 27, and P57 are going to inhibit all the cyclin dependent kinases 4, 6, 2, and 1. Invariably, they are going to inhibit. While the INK4-R family is going to be having 5 members, P14, 15, 16, 18, and 19. Leaving P17 from 14 to 19, all the P's are going to be there. Out of this INK4 family is going to inhibit only the first 2 cyclin dependent kinases, which was involved the cyclin D, which is cyclin dependent kinase 4 and 6. Okay, CDK 4 and 6 associated with cyclin D is going to be inhibited by this INK4-R family, right? So any of this can be mutated and it can result in cancers. Not going into so much of a detail. So next will be the insensitivity to growth signals, the second hallmark of cancer. So insensitivity to growth inhibitory signals. So obviously growth inhibitory signals will be given by the tumor suppressor genes. So they are going to, the cancer is going to oppose the tumor suppressor and grow. Okay, so that is what is insensitivity to growth inhibitory signals. So here again, specific examples you need to remember. Tumor suppressor genes are NF1, NF2. So NF1 is also called as neurofibromin gene present on chromosome 17q. So NF2 is also called as Merlin gene, which is present on chromosome 22q. So in this, we have NF1 is associated with neurofibromas and then neuroblastomas, while NF2 is associated with schwannomas and meningiomas. So these examples are again important. Okay. Then we have P10. P10, as the name suggests, 10 is there, so it is present on chromosome 10. And here we have multiple cancers. We remember it as BET. Okay, breast, endometrium, and thyroid cancer, BET. Then APC, it is the chromosome 5q. It is also called as the gatekeeper of the colonic neoplasia, because APC gene, it is responsible for another syndrome called as the familial adenomatous polyposis syndrome, which is an autosomal dominant disorder. So those syndromes, they are prone for developing colonic cancers. So this APC gene is the gatekeeper of the colonic neoplasia. Even if it is not a familial cases, sporadic case as well, APC gene is the first gene which is going to be mutated in the colonic neoplasia pathway, right? So that is why it is called as a gateway of colonic neoplasia. Then about retinoblastoma gene, very important. So retinoblastoma gene, it is going to be present on chromosome 13q, okay? And then as the name suggests, it is going to be associated with retinoblastoma. Apart from that, there are other tumors also related with retinoblastoma gene, which is osteosarcoma and breast cancers. Okay, osteosarcoma has a very high chance if the retinoblastoma gene is mutated. So this is also called as the governor of the genome. So rest all name goes to the T53. Okay, governor alone has been given to retinoblastoma, while policeman, gatekeeper, everything else has been given for T53. Governor is RB. So Knudsen's two-hit hypothesis is for retinoblastoma. Okay, not going into the details again. Just remember Knudsen's two-hit hypothesis is for retinoblastoma. So we have certain things called as rosettes. So we have two types of rosette, at least true rosette and pseudo rosette. So one such example is in this retinoblastoma, we get both kind of rosettes, which is true rosette and a pseudo rosette. So an example of a true rosette will be a Flexner-Wintersteiner rosette. Here, if you see, this is forming a flower kind of an appearance, right? And the center lumen is present. It is empty lumen. So this is a Flexner-Wintersteiner rosette. But if you see a Homer-Wright rosette, it is multiple, these roses are being formed, flowers are seen, but in the center there is some pinkish material which is filled with this neuropil. Okay, so that is the Homer-Wright rosette. So when the lumen is empty, it is a true rosette, and if there is some material inside the lumen, it is a pseudo rosette. The example of a true rosette is a Flexner-Wintersteiner rosette, while an example of a pseudo rosette is a Homer-Wright rosette. Both true and pseudo rosettes are present in retinoblastoma cancer. Okay. Then gene STK11 is associated with Peutz-Jeghers syndrome. So Peutz-Jeghers syndrome, we'll be reading it in GI tract also. Just remember the gene STK11. Then we have BRCA1 and 2, which are associated with breast cancers. We all know breast cancers, ovarian and prostate cancers, right? So these are associated, these are again tumor suppressor genes. Then we have this mismatch repair genes. So mismatch repair genes are, you don't have to remember the names, you just remember these are all MMR genes, okay? Mismatch repair genes. So these MMR genes are mutated in colonic cancer, endometrial cancers especially. And it is associated with Lynch syndrome. Lynch syndrome, okay? It is again an autosomal dominant disease. Then coming to TP53, it is present on chromosome 17p, which is again a tumor suppressor gene. So if already I told, most common gene mutated in tumors is TP53, most common oncogene mutated in tumors is going to be KRAS, okay, RAS. So then rest of the names, the guardian of the genome, molecular policeman, gatekeeper, all of this has been given the titles, these titles were given to TP53. Only the governor title was given to RB. Okay, this one. So we all know human papilloma virus, right? This human papilloma virus is such a culprit that it is going to attack both the major tumor suppressors. Like one is controlling the G1S phase, the other is controlling the G2M phase. So both the phases are being controlled by these are controlled by RB and P53. The HPV is actually inactivating both P53 and RB with the help of its protein, which is E6 and E7. So E6 is going to inactivate P53, E7 is going to inactivate RB. So with both the main tumor suppressors gone, guardian gone, governor gone, what happens? It is going to result in cervical cancer. Not just cervical cancer, it results in other cancers as well, which we'll be seeing later. I remember it this way. 53 has 3. 3 is a multiple of 6. 6 is a multiple of 3, right? So E6 is for P53 and E7 is for RB. This again has been a question. Then this Warburg effect. So what is Warburg effect? Just remember it is aerobic glycolysis. Usually when oxygen is present, the cell will undergo oxidative phosphorylation to produce energy with, that is ATP. But in tumors, what happens is this normal cell, even if oxygen is present, aerobic glycolysis. So even as oxygen is present, it is going to undergo glycolysis. So glycolysis, what happens is the end products will actually enter into cycles which are needed as intermediates. So basically the tumor cell wants to build up intermediates for growing in size. So it doesn't need energy. It just needs intermediates for the constituent. It is proliferating rapidly, right? So for each of the cell, it needs the constituents to be made. So for that, it needs intermediates. So for intermediates to be made, it doesn't need ATP. It just needs the intermediates. So that is why aerobic glycolysis happens. So Warburg effect is nothing but aerobic glycolysis. It is for producing intermediates. This is again a new concept which was introduced in Robbins, oncometabolism. So certain enzymes which are seen in Krebs cycle. So those enzymes are going to undergo mutations, and that those mutations are being taken up by certain tumors for growing. Okay. One such example is the IDH. IDH is an enzyme which is isocitrate dehydrogenase, which we see in the Krebs cycle. So this IDH, normally it is converting this alpha ketoglutarate, but in the mutated form, it is going to convert this alpha ketoglutarate into 2-hydroxyglutarate. So this 2-hydroxyglutarate is the oncometabolite which is formed. So rather than the normal pathway of Krebs cycle, this 2-hydroxyglutarate is going to cause some epigenetic changes and result in cancer. Okay, just remember IDH, because IDH mutations are quite specific. The examples of IDH specific mutations are gliomas. Remember gliomas at least. Okay. Then evasion of apoptosis. The tumor suppressor gene, which is BCL2, anti-apoptotic. Remember, BCL2 is an anti-apoptotic factor. So when this overexpression of BCL2 happens, meaning the cell is escaping from apoptosis, escaping from cell death. So tumor cells actually, they take up this overexpression of BCL2 and they escape from apoptosis. So overexpression of BCL2, this is being seen in a lymphoma called as follicular lymphoma. And the characteristic translocation seen in follicular lymphoma is going to be translocation 14-18. Okay. This immortality gene I already spoke when we were discussing cellular aging. Remember telomerase. This will be covered. Then coming to genomic instability, which is one of the cancer enabling factors, characteristics. Newly added, I told you that one. So usually DNA repair happens whenever there is some damage. It will try to repair. So repair genes are there. But when this repair genes itself are being mutated, obviously it is going to lead to a catastrophe, right? So then the genome will become unstable because of that. That is what is called as genomic instability. So DNA repair defects results in genomic instability. So we have a few kinds of repairs. First one will be the nucleotide excision repair. Just remember, nucleotide excision repair, it happens because of UV damage. So UV radiation will as such cause cross-link and damage the DNA and cause cross-linking of the pyrimidine dimers. Formation of pyrimidine dimers will be seen with the UV damage. And this pyrimidine dimers are usually corrected by this nucleotide excision repair. But when this is getting mutated, this mechanism, nucleotide excision repair itself is getting mutated, it is going to result in a condition called as xeroderma pigmentosa. So xeroderma pigmentosa has multiple risk factors for skin cancer. Okay. Then the second mechanism of DNA repair is homologous recombination. So homologous recombination, again, UV radiation can not only cause pyrimidine dimers, it can also cause double-stranded DNA breaks and DNA crosslinks. So these double-stranded DNA breaks and DNA crosslinks will be corrected by homologous recombination. And homologous recombination, if it is defective, it can result in 3 syndromes: Bloom syndrome, Fanconi anemia, and then ataxia telangiectasia. Remember, ataxia telangiectasia, ATM gene chromosome 11, we learned it in immunodeficiency, right? So Bloom syndrome, Fanconi anemia, and ataxia telangiectasia are defects in the homologous recombination. Then comes the DNA mismatch repair, the most important one. This was the genes I was speaking about just now in tumor suppressors as well. Remember the MLH1 genes. So these DNA MMR genes, DNA mismatch genes, are corrected by the mismatches as such. We know that adenine pairs with thymine and then cytosine pairs with guanine, but sometimes it is the other way, that thymine is going to pair with guanine, okay, T with G. So that a kind of thing is not allowed, right? So in this MMR genes will be proofreading the genome. So when they see this kind of a mismatch, they'll try to repair. So that is why they are called as MMR genes, mismatch repair genes, or they're also called as proofreaders of the genome or spell checkers of the genome. So these are defective. It is going to result in the Lynch syndrome. It is also given the other name of hereditary non-polyposis colonic cancer. Okay, HNPCC syndrome is hereditary non-polyposis colonic cancer syndrome. So this Lynch syndrome is autosomal dominant. MMR genes are defective. Already we saw it is going to be resulting in endometrial cancers, colonic cancers, and ovarian cancers, CEO. Okay. Next, moving on to the etiology of carcinogenesis. So chemical carcinogens, here again, this table is important. Okay. So the which is the carcinogen and what type of cancer it is going to result in, you need to remember. So I'll specify certain things. Aromatic amines like benzidine result in bladder cancer. Asbestos, it is going to cause both lung adenocarcinoma and mesothelioma. Then benzene is going to cause acute myeloid leukemia. So remember, benzidine is for bladder cancer, benzene is for AML. Okay. Then DES, which is diethyl silvosterol, which is going to result in clear cell carcinoma of the female genital tract in a child. So in utero exposure of the mother to this DES is going to result in the clear cell carcinoma in the child. Okay. And alcohol, tobacco, you can write every other cancer is related to that. And angiosarcoma of liver is important. We have three causes, which is arsenic, thorotrast, and vinyl chloride. VAT. Okay. Arsenic, vinyl chloride, arsenic, and thorotrast. So these three are important for angiosarcoma of the liver. Then we have polycyclic aromatic hydrocarbons like benzopyrene. So these aromatic hydrocarbons are resulting in lung and bladder cancer. So at least this much you must know. Then coming to radiation carcinogenesis, UV rays, usually it is the UV rays, B for bad, okay? B for bad. So B rays are the ones which are known for causing cancers. So UV rays usually cause skin cancer, and the most common one of which is the BCC. Don't write SCC. Most common skin cancer itself is BCC, okay? Infrared rays, okay? Infrared rays are going to be most commonly, they are going to result in blood cancers like acute myeloid leukemia. UV for skin cancers, IR for acute myeloid leukemia. Especially in thyroid, if they ask what is the cancer which is sensitive for radiation, it is papillary carcinoma of the thyroid. Okay, it is X-rays. All of this unwanted X-rays to the chest region can predispose the individual for developing papillary carcinoma of the thyroid. It's a risk factor. Then coming to microbial carcinogenesis, certain microbes have been implicated in the development of certain cancers. So H. pylori, you all know, stomach. So it is going to cause stomach adenocarcinoma, not just that, but also stomach maltoma. Okay, both stomach adenocarcinoma and maltoma. Then we have HTLV1 human. This HTLV1 virus is going to be there. This is going to be parentally transmitted only. So this is a T cell leukemia. It is going to result in T cell, adult T cell leukemia, ATCL. Then HCV, which is hepatitis C virus, it is going to result in hepatocellular carcinoma. Then HBV also for HCC. Then HHV8, herpes virus, human herpes virus is going to cause Kaposi sarcoma. Then HPV virus. So this is what I was telling. HPV, human papilloma virus, E6 and E7 proteins we were discussing, right? So we have to various strains of HPV. So based on their risk, we are classifying it into low risk and high risk. So low risk, the main strains you need to remember is 6 and 11, while high risk 16 and 18. Okay, 6 and 11 strains are going to cause giant condyloma acuminatum, warty lesions basically. Okay, warts. So warts are condyloma acuminatum, while high risk lesions 16 and 18 are usually prone for developing cervical cancer, but not just that. So cancer cervix, along with that, any perineal cancer, anal cancer, vaginal cancer, penile cancer, vulval cancer. Then also oropharyngeal cancers, oropharyngeal and laryngeal cancers are associated with HPV. Okay. And most important question again, repeatedly asked, EBV associated cancers. So Epstein-Barr virus is associated with Burkitt's lymphoma, we all know. Then Hodgkin's lymphoma, certain types of Hodgkin's lymphoma basically. Then we have post-transplant lymphoma and also nasopharyngeal carcinoma. So nasopharyngeal carcinoma, usually in the Southeast Asian countries, they are prone for developing this nasopharyngeal carcinoma in correspondence to this EBV. Okay. So Burkitt's, Hodgkin's, and nasopharyngeal at least you need to remember. Then fungus which causes cancer, which is Aspergillus flavus. So this Aspergillus flavus will produce a aflatoxin. So aflatoxin is responsible for causing HCC. Then for parasites, this one is important. Schistosoma hematobium, this parasite is going to cause SCC of the urinary bladder, squamous cell carcinoma. Usually, urinary bladder cancers, it is transitional cell cancers, transitional cell carcinoma. But specifically, Schistosoma hematobium is going to cause squamous cell carcinoma, S for S. Okay. Then we have two other parasites, which is liver fluke, which is Clonorchis sinensis, and Opisthochus sinensis, which is causing cholangiocarcinoma. Okay. So these are direct one-liners which can be asked. Next, moving on to paraneoplastic syndromes. Paraneoplastic syndromes are nothing but they are going to be associated with neoplasms, but they are as such not due to the neoplasm spread. Okay. Most common paraneoplastic syndrome is going to be hypercalcemia, and the most common cause of this hypercalcemia as a paraneoplastic syndrome is the breast cancer. So this is there, and this table is a very important table in Robbins. So they might ask paraneoplastic syndrome, then give one of the things, and they'll ask which cancer it is related to. Okay, you need to remember this table. So Cushing syndrome is because of ACTH, mainly because of small cell lung cancer. Small cell lung cancer, both Cushing syndrome and SIADH. So both ACTH and ADH production will be there by the tumor. It's going to result in Cushing syndrome and syndrome of inappropriate ADH secretion. So both of it is related with small cell lung cancers. Then polycythemia. So it is because of erythropoietin production, renal tumors, okay, renal cells and hepatocellular carcinoma. Then this one is new. So this hypoglycemia is because of insulin production in fibrosarcomas. Okay. Then acanthosis nigricans. So acanthosis nigricans is this velvety blackish appearance of the neck here and also in the axilla and groin. So it is related with the gastric cancer. Apart from that, there is something called as lesser prolactin. So lesser prolactin is nothing but multiple seborrheic keratosis is going to develop in the skin. It indicates that there is a possibility of an internal malignancy in the patient. Usually it turns out to be a gastric malignancy. Then myasthenia gravis. So myasthenia gravis and also pure red cell aplasia, it is related with thymoma. This question was in fact asked in the previous PG. So myasthenia gravis and pure red cell aplasia are paraneoplastic syndromes associated with thymoma. Okay. Then Lambert-Eaton syndrome, it is associated with lung cancer. Then this Trossi syndrome. Trossi sign is nothing but migratory thrombophlebitis. So venous thrombosis is going to be there. So this Trossi sign is associated with two cancers mainly, which are mucin producing, pancreatic and lung adenocarcinoma. Okay, mucin producing pancreatic lung adenocarcinoma. At least pancreas you must remember. Trossi sign and lesser Trellat sign. We had seen two signs in this. So at least the highlighted ones you need to remember in this table. Then coming to the diagnosis of cancer, we'll see about pap smear and FNAC. Okay. So one thing about FNAC, we all know, surgery postings they had asked a number of times. FNAC cannot differentiate between follicular thyroid carcinoma and a follicular adenoma. So a benign and malignant cannot be differentiated with an FNAC. Okay. Only for this follicular papillary thyroid carcinoma, you can identify. But follicular carcinoma and follicular adenoma, you cannot diagnose it on FNAC. Then we have pap smear. So pap smears are nothing but screening test which we use for cervical cancer. So it is an exfoliative cytology technique only. So there we see the squamous cells and their morphology, and we give a diagnosis of whether the patient is having some pre-neoplastic condition or a neoplastic condition. Okay. So pap smear. The important question here will be the fixative for pap smear. So pap smear fixative here will be 95% ethanol. Screening test for cervical cancer. 95% of ethanol is the fixative for this pap smear. Okay. Next, moving on to the normal fixatives. So if you get a histological specimen, in which fixative do you send the specimen? So it is usually 10% neutral buffer formalin. So 10% neutral buffer formalin is the normal fixative. If you are wanting to do an electron microscopy, suppose they are sending a kidney biopsy, they want to do an electron microscopy. In that case, the specimen has to be sent in 2.5% glutaraldehyde. Okay, electron microscopy, 2.5% glutaraldehyde. Then immunohistochemistry. So nowadays, for proving the origin of a tumor, suppose you don't know the origin of the tumor and you want to check what is the origin of the tumor, you can use certain specialized techniques like immunohistochemistry. So based on the certain expression of certain factors by the tumors, we can identify the origin of the tumor. So we employ antibodies against the antigens which are expressed in the tumor cells. Okay. So for example, any carcinoma is going to express the intermediate filament CK, which is cytokeratin. Okay. Sarcoma, the IHC molecule factor will be vimentin. Lymphoma, it is the common leukocyte antigen, which is LCA or CD45. Then Hodgkin's lymphoma, it is CD15 and CD30. And then LCH, we have just Langerhans cell histiocytosis, it is CD1A and Langerhans. CD1A is very important. Then we have seminoma. Seminoma or dysgenoma. Seminoma is the dysgenoma is the female counterpart of seminoma. Okay, so testicular and ovarian tumors. So seminoma is going to express PLAP. Okay, PLAP, OCT34 and NANOC. Yolk sac tumor, again in ovarian or testicular tumor, it is going to express alpha fetoprotein. Then granulosa cell tumor, it is going to be expressing inhibin. It is a sex-cord stromal tumor, inhibin. And neuroendocrine tumors express synaptophysin and chromogranin. So these much at least you must remember. These are the specific IHC markers for tumors. Then coming to tumor markers, again very important MCQs. Tumor markers. So tumor markers, they are usually biomarkers which we test for identifying the tumor cells. So it is usually not for diagnosis, they usually use it for follow-up. So prior to surgery, they measure this tumor marker. Then post-surgery and post-treatment, they'll be consecutively evaluating this tumor marker. The level should fall down. Suppose the level is rising again, then it means that the patient has already metastasized or they are having a recurrence. So for follow-up and to assess the tumor recurrence, we have to measure this tumor marker. This tumor marker table again is quite important. Calcitonin, we have already seen. It is going to be expressed by the medullary carcinoma of thyroid. So this was also ACAL, remember, amyloid calcitonin. Then beta HCG for choriocarcinoma. Then vanillyl mandelic acid for pheochromocytoma. Also 5-hydroxyindolestic acid was also for pheochromocytoma. Then alpha fetoprotein is for 3 things. Okay, 2 things related to liver, which is HCC, hepatocellular carcinoma and hepatoblastoma. Apart from that, yolk sac tumor, YST. Okay. Then carcinoma embryogenic antigen is for colon, pancreas, lung, basically. Then PSA is for prostate specific antigen. So name itself suggests it is for prostate. Then non-specific enolase, it is for neuroendocrine tumors. Then immunoglobulin, as such we know, multiple myeloma, plasma cell dysplasia is the one which produces immunoglobulin. Then we have CA125 for ovarian cancers, CA199 for pancreatic cancer, CA153 for breast cancers. Okay, these 3 at least you must know. Then recently added one in the Robbins is this serum cell-free DNA. Okay, so cell-free DNA, as the name suggests, it is the DNA is not going to be present inside the cell; it is going to be roaming in the circulation, and we capture that one, and you do molecular techniques on that and identify the mutations as such. So the targeted therapy can be given directly. Okay, so they in a lung cancer, if we find this EGFR mutants in the serum, already I told erlotinib and gefitinib can be given. So EGFR for lung cancer. In urine, if they check for TP53, they can diagnose bladder cancer. Same for sputum and serum, if they identify TP53 and RAS mutation, it is for lung cancer, right? So I had given a final recap of the various chromosome numbers and the syndromes, diseases associated with it. So just give it a quick revision. At least remember whatever is possible, okay? Now neoplasia is done. Let's move on to the systemic pathology. So first we'll start with CVS, cardiovascular system. Any doubts so far? Can I proceed? Someone please reply.
Page number of CVS, ma'am.
Sorry?
Page number, ma'am.
Actually, I have put it as a separate folder. It's
Here is a PDF, ma'am.
Ninth one.
Okay.
Okay, let's start with cardiovascular system. So in cardiovascular system, again, I will be telling only the important points. So You must have heard of heart failure cells. So what are heart failure cells? They can ask. These are nothing but hemosiderin-laden macrophages which are seen in lungs. Okay, heart failure cells are not seen in heart. It's seen in lungs as a result of heart failure. Okay, as a result of heart failure. So heart failure cells are hemosiderin-laden macrophages in pulmonary edema seen in left heart failure. Can you move it, please? Someone had kept on their speaker. I think it is okay. So this hemosiderin-laden macrophages, already I have told hemosiderin is the one which contains iron. So iron, anyway, you can highlight with Prussian blue stain, right? So Prussian blue stain can be used. So this, if they see heart failure cells in the lung, it is a telltale sign of left heart failure. Okay. Then we have something called as nutmeg liver. Nutmeg is jadikai. Okay, in Tamil we call it as jadikai. So nutmeg liver, if you cut the surface of this nutmeg, you can see some darker areas and some lighter areas. So that is the classical appearance of a liver in a condition which is chronic venous congestion. So in chronic venous congestion, the liver will appear like a nutmeg. And in this, if you see the darker red color areas are the necrotic areas as such. Okay, the darker areas are the centrilobular hemorrhagic necrotic areas. So around the central vein, the area is going to be necrosed, while the portal areas at the periphery of the portal tract, right? So that area is going to be viable, and that area is going to appear light in color. So red is the necrotic area, while the lighter color is the viable area. So this nutmeg liver is seen in chronic venous congestion, which is as such a result of right heart failure. Heart failure cells for left heart failure, and nutmeg liver is for right heart failure. So the same chronic venous congestion can go back and can affect the spleen as well. So in this chronic venous congestion of the spleen, you can see something called as Gamna-Gandhi bodies. It's not gamma, it is Gamna. Gamna-Gandhi bodies, which is composed of three things: hemosiderin, calcium, and fibrosis. So hemosiderin can be stained with Prussian blue, calcium can be stained with von Cosa. Okay, so these are the MCQs related with this. Next, moving on to cardiomyopathy. So cardiomyopathy, we have three basic types, which is dilated cardiomyopathy, hypertrophic cardiomyopathy, and then restrictive cardiomyopathy. Again, important points to be highlighted. Dilated cardiomyopathy, it can be of various types, but the most common mutation is the titin mutation, which is an autosomal dominant. And in fact, it is the largest protein found in the body, titin. So X-linked can be there. In X-linked only, it is a dystrophin mutation. Remember in dystrophin, I was Duchenne's muscular dystrophy. When we were discussing X-linked recessive, I was mentioning. So Duchenne's and Becker's muscular dystrophy, both of it has this dystrophin mutation only, which can result in cardiomyopathy as well. So the most common cause of this DCM is going to be alcohol. Okay, alcohol. And hemochromatosis can result in dilated cardiomyopathy. In general, if you see any kind of deposition or fibrosis will result in restrictive cardiomyopathy. But hemochromatosis, I told, it is an iron overload. But hemochromatosis is associated more with DCM than restrictive cardiomyopathy. Okay. So in DCM, what will happen? Dilated, as the name suggests, all the heart chambers are going to be massively dilated. The heart is going to be dilated. So as it goes dilated, obviously the walls will get thinned up, right? So the chambers will all become flappy. The walls will become flappy and thinned up. So the heart is not able to contract. It has dilated so much that it has become flappy and it is not able to contract. So it is a systolic dysfunction. And the finding which you see in a DCM heart is the ninja star nuclei. So when myocytes which are undergone hypertrophy, they'll have some irregular, bizarre pleomorphic nuclei like a ninja star. So you must have seen in cartoon some star kind of an image like this, right? A blade kind of thing. So that is a ninja star. So that kind of a nucleus is seen in DCM. Then hypertrophic cardiomyopathy, here it is only autosomal dominant. Like we have only genetic cause for hypertrophic cardiomyopathy. Unlike DCM and RCM, there is no other cause for hypertrophic cardiomyopathy. It is 100% genetic. And usually the mutation is of the beta myosin heavy chain mutation. Okay. And classically, the history will be that of a young athlete who's playing on a basketball ground or something, and he collapses just like that on the ground itself while playing. So that usually is the result of a hypertrophic cardiomyopathy. Then here the heart, as the name suggests, hypertrophy. So the wall is going to be thickened, especially the interventricular septum. Okay, so there is going to be thickening of this interventricular septum. So this is the septum as such. This big the septum has become. Okay, so this interventricular septum has become asymmetrically thickened, and because of the thickening, it is going to compress the left ventricle into a banana shape. Okay, banana shape configuration of the left ventricle. The asymmetric IV hypertrophy, IV septum hypertrophy, along with banana configuration of the left ventricle is classical for HCM. And here again, the outflow is being obstructed. The left ventricle is being compressed, right? So when the outflow is obstructed, there is going to be a systolic ejection murmur in this patient. Aorta is going to be compressed. So this microscopically, one important feature, helter-skelter disarray. Basically, the myocytes are not arranged parallelly like this. They are going to be arranged crisscross like this. Can you see? So this is called as helter-skelter disarray, which is a feature of hypertrophic cardiomyopathy. Ninja star for DCM, helter-skelter disarray for HCM. For RCM, which is already I told, the most common cause is amyloidosis. So anything which is depositing. So amyloid is also an external kind of a deposition, right? So amyloidosis is the most common cause of RCM. Apart from that, anything which can induce fibrosis or some deposition like metastatic tumors, radiation-induced fibrosis. So all of these can, even accumulation of metabolites in inborn errors of metabolism, all of these can result in restricted cardiomyopathy. So nowadays the questions are being focused on Takotsubo cardiomyopathy. I don't know about MRB, but in NEET at least they ask this. So Takotsubo cardiomyopathy, it is a variant of dilated cardiomyopathy only. It is given a special name called as catecholamine-induced cardiomyopathy or broken heart syndrome. Okay, so it is because of some supraphysiological stress. You must have seen in movies that sometimes the heroine or the heroine's mom will hear some death news and then she'll also collapse. So that is usually because of Takotsubo cardiomyopathy. Some supraphysiological stress is going to cause a massive release of catecholamines immediately. So that will go and stun the myocardium. So the heart will just stop without contracting. Okay. So this stunning of the myocardium will result in the myocardial contraction band necrosis. This is the microscopic feature of this Takotsubo cardiomyopathy, myocardial contraction band necrosis. So as such, if you see, there will be no ECG changes in this patient. Right? Why is it given this name Takotsubo? It is actually the second picture here, right? So this is a pot kind of thing which they use for capturing octopus in Japan. So it resembles, the heart resembles that shape of that pot, and that is why it is given that name. Then another type of cardiomyopathy is arrhythmogenic right ventricular cardiomyopathy, which is again a variant of DCM only. So as the name suggests, here there is going to be right heart failure. So arrhythmogenic, arrhythmia is going to be there. So one thing here is the Naxos syndrome. Naxos syndrome is nothing but this arrhythmogenic right ventricular cardiomyopathy, along with that hyperkeratosis of the palms and soles. So very much thicker on white colored soles and palms will be there, and they'll have some woolly kind of hair, like what do you call that? Wool only, wool bundle. So it will look like that. So that is due to placoglobin mutation. So this is a triad acid. So that is why I specified here. Then coming to pericarditis, here two things I'll again tell, three things. So serofibrinous pericarditis is also given the name of bread and butter pericarditis, which is seen in rheumatic heart disease. Okay, serofibrinous pericarditis seen in rheumatic heart disease called as bread and butter pericarditis. Then caseous pericarditis and hemorrhagic pericarditis, the causes can be tuberculosis. But if they ask hemorrhagic pericarditis specifically, the most common cause is going to be a tumor, especially lung, which is near to the heart. Okay, so hemorrhagic pericarditis, most common cause is the lung cancer, but TB is here as well, and in the caseous pericarditis as well. And there is something called as milk spot, soldier's plague, or epicardial plague. They might just give this and ask, what is this? Don't confuse, it is just pericardial fibrosis. Okay, chronic constrictive pericarditis. It is just given the specific name. So this fibrosis is going to form a plaque-like thing on the surface of the heart, and it is going to look like a soldier's plaque. Okay, milk spot and epicardial plaques are other names given for this. Then myocarditis. So myocarditis, it is the myocardium which is going to be inflamed, and usually it is infectious causes. Most common cause in general, if they ask, it is going to be viral infection, and that too herpes. Do not answer Coxsackie. Coxsackie is the second most common. Okay, herpes infection is the most common cause of myocarditis. If they ask specifically for a parasite which causes myocarditis, then you answer it as Trichinella spiralis. So Trichinella usually enters into the muscle, right? So Trichinella spiralis is the one which causes this myocarditis. Then coming to endocarditis. So endocarditis is usually in the endocardium, the valves. The valves are going to be affected. There's going to be some formation of vegetations. Okay, so these vegetations are also called as verrucae. So based on the type of vegetations and the surface in which they are involved, we have classifications of endocarditis. So let's start with rheumatic heart disease. So rheumatic heart disease usually affects in 5 to 15 years of kids, and usually it is due to molecular mimicry. The child would have developed a streptococcal infection of the throat. So post group A beta hemolytic streptococcal infection of the throat, it is going to result in the molecular mimicry, and the host will think that it is mounting the response against the bacteria, but it is also matching with that of the antigens present in our heart and joint. So our tissues, host tissues also be affected. Okay, so the most common tissue which is affected will be the mitral valve. Most common valve is mitral valve which is affected, and pulmonary valve is the least commonly affected valve. So mechanism is the molecular mimicry. So the features of rheumatic heart disease: ash of bodies, Anish-Koff cells. Okay, ash of bodies are nothing but it is a granuloma type of thing only, but it is composed of this fibrinoid necrosis along with this Anish-Koff cells and lymphocytes. And this ash of bodies can be seen throughout all three layers, not just endocardium, myocardium, pericardium can also be seen, but most commonly in the myocardium. So ash of bodies is the characteristic feature of rheumatic heart disease. And this Anish-Koff cells present in the ash of bodies are nothing but macrophages only, which have a nucleus which appears like that of a caterpillar. Okay, if you see in this image, this is an Anish-Koff cell. Here the nucleus is looking somewhat like this, right? So all of the cells which are seen here actually looks like this. So these are nothing but the Anish-Koff cells. So ash of bodies and Anish-Koff cells are seen in RHD. Then coming to Macallum plaques. So in chronic RHD, so when there is this mitral valve is being affected, the jet of the blood is going to go back and hit the left atrium and cause a plaque-like thing on the left atrial posterior wall. So that is called as Macallum plaques, again seen in rheumatic heart disease. You also get to see the mitral valve which is getting stenosed. So very much stenosed. Any chronic disease is going to cause fibrosis, right? So stenosis is going to happen. So it will look as if it is the mouth of a fish or a buttonhole. So fish mouth or buttonhole stenosis, Macallum plaques, ash of bodies, Anish-Koff cells are all features of rheumatic heart disease. I'll be telling about the verrucae when I'm discussing all the other conditions as well. Okay. So this again we all know. I'm not going into the details of RHD because you'll be reading about this again in medicine. So just remember, revised Jones criteria is the criteria which is used for RHD. And like SLE, here again, the arthritis is going to be non-erosive, painless. Coming to infective endocarditis. Infective endocarditis, as the name suggests, the valves are going to be infected with some microorganism. So whenever it is going to be an infection, it is going to cause a very bad kind of a necrosis. So the vegetation which it forms itself will be very much friable and it damages the valve so badly. Okay. So if it is an acute infective endocarditis, it usually affects the normal valve. Priorly, the valve would have been normal, and it usually because of staphylococcal aureus infection. While if it's a subacute infective endocarditis, it usually affects a damaged wall, prior damaged wall because of some other comorbid condition. So on that damaged wall, a streptococcus viridans infection can cause a subacute infective endocarditis. While prosthetic valves, so some other valve has been get prosthesis can be here. In that case, it is staphylococcal epidermidis, which is the most common infection. Suppose the IV drug abusers are there. So in that case, the right heart is usually the left heart which is affected in infective endocarditis, but in IV drug abusers, it is the right heart which is commonly infected. And if it's the right heart which is infected, it is the staph aureus, and if it's the left heart which is infected, it is the enterococcal infection. Okay. And the classical features of this infective endocarditis, at least for MCQ point of view, It is rod spots, Janeway lesion, splinter hemorrhages, and osler nodes. So all of these are seen in infective endocarditis. So rod spots are seen in retina, R for R retina, which are flame-shaped hemorrhagic lesions. Okay. Then Janeway lesions and splinter hemorrhages. These are again hemorrhagic lesions only. And this Janeway lesions are usually seen in the palms and the soles. So these Janeway lesions are painless, while Osler's nodes are again seen in the fingers only, but some nodule kind of thing. Okay. So they are as such painful. So how do you remember it? Osler, O for ouch. So someone pricks tend to shout ouch, right? So Osler is ouch, which is painful, while Janeway lesions are painless. So for RHD, it was Jones criteria. For infective endocarditis, it is Duke's criteria. Okay, now coming to the differentiating features between the various forms of infective endocarditis. Various forms of endocarditis. So in rheumatic heart disease, the verrucae will be usually small and firm. Okay, small, firm, and warty, and these are usually present at the closure of the valve. If the valve has three cusps like this, so at the closure of the valves, the verrucae will be present. In infective endocarditis, I told it is an infection, so it will be very bad. So they are going to be very large, friable, and damaged as much as possible. They are the only non-sterile vegetations. Okay, and usually they are present on the upper surface of the cusp. While it is non-bacterial thrombotic endocarditis. So thrombotic, as the name suggests, it is thrombus is going to be there. So same like RHD, this is also going to be present at the lines of closure of the valves only, small like RHD, but it is sterile and it can embolize. It is not as small as the RHD. If you see the picture also, you can compare. It's not as small because it tends to form thrombus. It can also embolize, and that is the issue with this. It can embolize and go and settle in some other organ and cause disease over there as well. Then last one is the Libman-Sachs endocarditis. Where else did we see this? Yes, it was SLE, LSE for SLE. So in systemic lupus erythematosus, the endocarditis which happens is called as the Libman-Sachs endocarditis. Here, it is usually both the upper surface and the lower surface of the cusp which are being involved, but more in the lower surface. Okay, so LSE, LS, so lower surface has lots of vegetations. So just recap, along the lines of closure, we have two things, RHD and NBTE. But NBTE tends to embolize, as the name suggests. Then infective endocarditis, the worst one, large, friable, and it is the non-sterile one seen on the upper surface. While LSE is going to be both on upper surface and lower surface, but more on the lower surface, right? Then coming to myocardial infarction, here again, important MCQs are there. So when is there irreversible cell injury in MI? So it is 20 to 40 minutes. We usually tell no, within half an hour, if the person reaches the hospital, they can still be thrombolized. So in that case, the irreversible cell injury will happen within 20 to 40 minutes. But the ATP depletion will start within seconds. As soon as there is an infarction, the ATP depletion will start. The next one is this earliest enzyme. There will be various markers we check in a myocardial infarction, right? So the earliest thing to elevate will be a myoglobin. As such, it was myoglobin, but nowadays they had changed it into this heart-related fatty acid binding protein, HFADP. Okay. I don't think they'll ask this in option. Myoglobin might be asked. Okay. So earliest to elevate will be this myoglobin or HFABP. Then the most sensitive and the specific, the best thing will be the troponin I. Okay, myself, I am good. Okay, so troponin I is the best. Next to troponin, next will be the troponin T. Marker of reinfarction is also troponin I. So if troponin I is raising again after 7 to 10 days, then it means that the patient is going for a reinfarct. Again, he's having an attack. Then there is something called as flipping of LDH ratio. So usually it is LDH2 which is elevated, while LDH1 is not that much. Okay, LDH2 is more than LDH1. But in myocardial infarction, LDH1 gets elevated because LDH1 is present in the heart. So LDH1 will elevate more than LDH2. This is called as flipping of LDH ratio. So do not confuse. It is 1 more than 2 is flipping. Okay. Then coming to the autopsy findings, I'll highlight the more important things alone. So the first autopsy finding will be the electron microscopic finding only. Okay. So within half an hour, that is before irreversible cell injury had happened, if you take the autopsy and see, it is going to be only an electron microscopically you are going to see any changes. Grossly or light microscopically, you will not find any changes. On electron microscopically, what will you see? The mitochondria will be swollen up. Remember, in reversible cell injury, we saw the first morphological change was cellular swelling, and the first organelle was affected was mitochondria. So that is why mitochondrial swelling will happen as the first change in electron microscopy in a myocardial infarction within half an hour. But within after 30 minutes to 4 hours, which is kind of still a golden period. So in that time, irreversible injury had already happened, but there you can you can see the first light microscopic change. So light microscopic change, the first change will be the waviness of fibers. The fibers will start becoming wavy. And grossly, you can use this TTC stain. So this TTC stain, normal myocardium should look red in color. But if there is an infarct, if you pour this stain, it will appear pale white in color. Okay. So because the LDH which is present in the cardiac myocardium, it has been lost to the surroundings. So when LDH is lost, it becomes pale with the stain. Okay. So TTC stain is a gross finding in which pale thing highlights the infarct. So at least this much you must remember. Granulation tissue, here again, it is a pronounced granulation tissue comes at 10 to 14 days. You are there in wound healing. If you remember, we read maximum granulation tissue was at day 5. Here, the granulation tissue starts at around 7 to 10 days and maximum it reaches by 2 weeks. So 1 to 2 weeks, the granulation tissue is happening. Then coming to the cardiac tumors, the most common cardiac tumor, if they ask, it is going to be metastasis. So anywhere if they ask in the body, most common thing will be metastasis. So the most common cause of metastasis, heart is very much near to the lung. So lung is the most common cause of metastasis. And if it's the primary benign tumor they're asking, in an adult it is going to be a myxoma, in a child it is going to be a rhabdomyoma. Okay. Then in the malignant tumor, adult it is an angiosarcoma, in a child it is going to be a rhabdomyosarcoma. These things are just for mugging up. And we have something called as mitral valve prolapse. It's important because it's given another name called as Barlow syndrome. So Barlow syndrome is nothing but mitral valve collapse. It is a degenerative condition. So the heart valve, mitral valve becomes somewhat myxomatous and degenerative. And it gives a characteristic mid-systolic click. Then we start with blood vessels. Okay, so blood vessels, vasculitis is the one which is important. Again, here we'll try to read it in groups. We have large vessel vasculitis, we have medium vessel vasculitis, and then we have small vessel vasculitis. In the large vessel vasculitis, we have two things, which is giant cell arteritis and Takayasu arteritis. So both of them are essentially the same, except that the vessels which they involve are different and the age group they involve are different. As is microscopically, it is going to be the same finding. So in giant cell arteritis, it is going to affect more than 50 years of age group, while Takayasu, it is going to affect less than 50 years of age group. Giant cell arteritis, it is also called as temporal arteritis, meaning it is going to affect the temporal arteries here. So the temporal arteries will become much more prominent over here, and they'll have a very high pain here, so that they can also result in blindness of the eye. Ophthalmic artery can be involved and they can undergo blindness and also jaw claudication. So these are all features of giant cell arteritis. While Takayasu arteritis here, it is going to affect the subclavian artery. So it is also called as the pulseless disease. So the subclavian artery is going to be affected over here. So you cannot feel any pulse in the upper limb, but lower limb pulse will be seen. Okay, subclavian artery is the most common artery affected in Takayasu, while superficial temporal artery is the most common vasculitis affecting the adults, and it usually affects the superficial temporal artery in giant cell arteritis, right? And both this large vessel vasculitis are granulomatous inflammation. You don't have to go into that much of details. Okay. Then we'll see about medium vessel vasculitis. So under medium vessel vasculitis, we have many things. First, we start with polyarteritis nodosa. Whenever you are reading polyarteritis nodosa, you compare it with the microscopic polyangiitis and disease. Okay, microscopic polyangiitis is a small vessel disease, but the points are more or less like a opposite of each other kind of. Okay. So in polyarteritis nodosa, P is not for P. Okay. So for PAN, it does not involve pulmonary vessels. So it involves all the medium vessels except pulmonary vessels. So this is again another confusion I get to see. People think P for P. P is not for P in PAN. Okay. Polyarteritis nodosa doesn't involve the pulmonary vessels. Here, it usually involves the kidney. Even then, it doesn't cause any glomerulonephritis. And it is associated with hepatitis B. Also, this much. Then I'll come back to PAN again when we are seeing microscopic polyangiitis. Okay. Next, we'll see about the next medium vessel disease, which is Kawasaki disease. So Kawasaki disease, it is the most common vasculitis affecting children. Okay, most common, and it is also the most common cause of myocardial infarction in children. So most common, the most common kind vasculitis in children is Henoch-Schönlein. So the most common cause of myocardial infarction in children is going to be Kawasaki. Most common vasculitis in adult is going to be the giant cell arteritis. Okay. So this Kawasaki disease is important because it is going to affect the coronary arteries. So that is why when the coronary arteries are damaged, it is going to cause myocardial infarction in the child. Okay. Here again, this much you remember, it is in a child, most common cause of myocardial infarction in child. Then coming to Buerger's disease. So this is BUER. Okay. So Buerger's disease is also called as TAO, thromboangiitis obliterans. If you remember in surgery postings, we all must have presented cases of this. So it is common in young males who have a history of smoking. So less than 35 years old, they are coming with some pain in the leg with claudication kind of a history. Then later on, they'll develop pain at rest. So this is the classical history we'll elicit, right? So that is because of thromboangiitis obliterans, which is a medium vessel vasculitis, also given the other name as Buerger's disease. Don't confuse it is Buerger's disease, which will be discussing it in kidney chapter. Okay. Buerger is BERGER. This is BUERGER. Okay. So the most common vessels affected will be the peripheries, the tibial artery and the radial artery, which are being affected. So initially the arteries and veins will be affected. Later on, it will engage the nerves also. So when the nerves are affected, only then they develop pain at rest. But remember, lymphatics will not be involved in this. Then coming to the small vessel vasculitis. So this was the one I was saying. This is the most common vasculitis in children, Henoch-Schönlein purpura. So Henoch-Schönlein purpura, you'll read it both in kidney chapter and vasculitis chapter. So it was a type 3 hypersensitivity reaction, and it is going to be mediated by IgA. Okay. It is IgA mediated, but if you see purpura is there. So purpura is nothing but like petechiae. These are somewhat smaller hemorrhages. Petechiae is pinpoint hemorrhages. Slightly more than that is going to be purpura. So purpura usually happens as a result of thrombocytopenia, decrease in the platelet count. But in this condition, Henoch-Schönlein purpura, don't think there is decrease in the platelet count as such. There is thrombocytosis, increase in the platelet count in this condition. It is just that the purpura is palpable. That is, you can touch and feel the purpura. So palpable purpura, which is happening as a result of the small vessel vasculitis and not because of platelet count issue. So platelet count is actually elevated in these patients. So the classical history of this patients will be, it is going to involve multiple things. So in the skin, we told it is going to have this purpura. In kidney, it is going to cause hematuria. It is a glomerulonephritis. So IG related glomerulonephritis will come. So it is presenting with hematuria. And in abdomen, they are going to have pain. And in the bone joints, they are going to have joint pain. So this classical triad of this abdominal pain, glomerulonephritis, joint pain, along with this palpable purpura is characteristic history for a Henoch-Schönlein purpura, right? Next, coming to Behçet's disease. Behçet's disease, we already, I told it when we were discussing HLA, remember? HLA B51. So it is also associated with B5. HLA B5 and B51 are associated with Behçet's disease. This is a small vessel vasculitis. Here, they are going to have multiple oral and genital ulcers. Along with that, they are going to have uveitis. So this is the triad of Behçet's disease. Then coming to microscopic polyangiitis. So this was the one I was telling. It is kind of opposite to that of a PAN. So this, all of this I was speaking about some immune complex related or antibody related, but this microscopic polyangiitis and the other two entities which we are going to discuss are all quasi-immune. Quasi-immune meaning there is not going to be any immunoglobulin immunocomplex related. Okay. So quasi-immune causes are microscopic polyangiitis, Wegener's granulomatosis, and Churg-Strauss syndrome, all three. Okay. So in microscopic polyangiitis, it is also called as leukocytoclastic vasculitis. So as the name suggests, leuco means WBC, cytoclastic means cell lysis. Okay, something is being broken in the cell. So that is going to cause vasculitis. As such, if you see, neutrophils will be broken down, and that will actually result in the inflammation of the vessel. So that is why it is given this name of leukocytoclastic vasculitis. But here, if you see, pulmonary capillaritis. So here it is going to involve the pulmonary. PAN was not involving pulmonary. Microscopic polyangiitis involves the pulmonary. While kidney involvement is seen in both, there is no glomerulonephritis in PAN, but necrotizing glomerulonephritis is seen in microscopic polyangiitis. While hepatitis B association was seen in PAN, it is not seen in microscopic polyangiitis. And here, if you see, I told it is quasi-immune, right? But we have certain other things, which is called as ANCA, which is anti-neutrophil cytoplasmic antibodies. Okay, so certain antibodies are formed against the neutrophil cytoplasm, contents of the neutrophilic cytoplasm. So against this ANCA can be of two types, either a P ANCA or a C ANCA. P ANCA is perinuclear ANCA, and C ANCA is cytoplasmic ANCA. So the contents around the nucleus, perinuclear, which is basically the MPO, myeloperoxidase enzyme. Remember, it was a primary azurophilic granule seen in neutrophils. So P ANCA is produced against the MPO, and it is seen in this microscopic polyangiitis, right? Then coming to Wegener's granulomatosis. Previously, it was called as Wegener's granulomatosis. Now the name has been changed to granulomatosis with polyangiitis. You might not get the name Wegener's granulomatosis. The new name will be given. It is granulomatosis with polyangiitis. Here it is again a triad. So the triad is going to be it is usually a necrotizing kind of granulomatous inflammation. As the name suggests, there is going to be granulomatous inflammation and necrosis is going to be present. So what all is going to be affected? Lung, kidney, and also there is going to be this upper respiratory tract which is going to be affected. So small vessels are going to be affected, that is for sure. And this is a quasi-immune type. So necrotizing granulomatous inflammation involving the small vessels, kidney. In the kidney, it is going to present as RPGN, rapidly progressive glomerulonephritis type 3. RPGN type 3 is associated with this quasi-immune kind of vasculitis. Okay, so whatever we are reading here, three things will come again in the RPGN type 3. Okay, I'll not repeat it there. So necrotizing crescent-free glomerulonephritis, crescents are a feature of RPGN. So that is a thing. And in the lung, in the airways, basically, in the upper respiratory tract also, and also in the lung, you are going to have multiple necrotizing granulomas. In Wegener's granulomatosis, you usually tend to have both C ANCA and P ANCA, but C ANCA is more than that of P ANCA, cytoplasmic ANCA. Okay, so C ANCA is usually directed against proteinase 3, while P ANCA was directed against myeloperoxidase. So both C ANCA and P ANCA, but C more than P in Wegener's granulomatosis. Then Churg-Strauss syndrome, again, this has been given a new name, which is now called as allergic granulomatosis with angiitis. So allergic is written, so obviously it is to be associated with some kind of eosinophil, right? So there is going to be increase in the eosinophils along with granulomatosis. So there is going to be granulomatous inflammation, then angiitis. So it is a small vessel vasculitis. So allergic granulomatosis with angiitis. So here there is going to be eosinophilia, and it is associated with P ANCA. Okay. Both microscopic polyangiitis and Churg-Strauss has P ANCA, while Wegener's alone has both C ANCA and P ANCA. C ANCA is more than P ANCA, right? So done with CVS. Next, we'll move on to respiratory system. So respiratory system, first we'll start with the COPD. So COPD is obstructive lung disease, which is a combination of both chronic bronchitis and emphysema. So chronic bronchitis, not going into the details, just remember read index is going to be increased. Normal read index is going to be 0.4. So what is read index? It is just the thickness of the mucus gland layer of the bronchus to the entire wall thickness, only the mucus layer and the entire thickness. Okay. In this chronic bronchitis, there will be excess production of this mucus, that is, it is going to increase so much. Okay. So this read index is eventually going to increase in chronic bronchitis. And these patients are called as blue bloaters, while pink puffers are emphysema patients, blue bloaters are chronic bronchitis patients. Both of it, cigarette smoking is a very classical history. In emphysema, if you see, there is going to be association with alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin deficiency will be seen in both lung and liver. So this alpha-1 antitrypsin is actually a serine protease, which is going to inhibit the elastase enzyme produced by the neutrophils. If you remember, elastase was one of the neutrophil primary azurophilic granules. It was a neutral protease. So that elastase is going to actually destroy the tissue. So with lots of inflammation happening because of cigarette smoking or something, so the elastase is going to eat up the tissue. So normally this alpha-1 antitrypsin would have gone and suppressed that. It was asked it to stop. But when there is alpha-1 antitrypsin deficiency, this inhibition is not going to be there, and the elastase is continuously going to eat up this surrounding host tissue and cause damage, resulting in the destruction of the alveolar wall. Okay, so that is what happens in emphysema. So we have various types of emphysema. In that, remember, the most common type is going to be the this one, irregular type. Okay. But if they ask most common type associated with smoking, then it is centri-acinar. While most common type associated with alpha-1 antitrypsin, it is the pan-acinar type, right? So pink puffers are emphysema patients. Then bronchial asthma. So bronchial asthma, we all know it is of two types, atopic type and non-atopic type. Atopic type is the one which has this allergic history and running in the families. So in this, there is going to be a type 1 hypersensitivity, wherein there will be elevated amounts of IgE and eosinophils. While non-atopic type are just induced by certain other factors like cold, exercise, stress. So these things will trigger the asthma. So there is going to be some reversible bronchospasm because the smooth muscles are going to become hyper-reactive. Along with that, there is going to be lots of mucus production, which is again going to obstruct the airway. So this is same that of the atopic type is going to be the same that of the type 1 hypersensitivity reaction, right? So the early phase was mediated by the mast cell, late phase is going to be mediated by the eosinophil. So three things we see in this asthma patient. First is the Crayola body, second is the Kirschmann spirals, third is the Charcot-Leyden crystals, all three C's. Crayola bodies are nothing but the bronchial epithelial cells. They just form a 3D ball kind of structure called as Crayola bodies, which is seen on cytology. Same Kirschmann spirals is just mucus plugs, which takes up the shape of the bronchus. Okay, so it has a spiral kind of appearance. So Kirschmann spirals, Crayola bodies, and then Charcot-Leyden crystals. So galactin, it is just needle-like crystal composed of this galactin 10. So galactin 10 is actually produced by the eosinophils. So during atopy, the eosinophils produces galactin 10 and they tend to crystallize. So these form this Charcot-Leyden crystals. So three C's are associated with asthma. Then coming to bronchiectasis, one of the causes of our bronchiectasis is going to be the cartaginous syndrome. So cartaginous syndrome, ferret MCQ, it's a triad actually. So triad of bronchiectasis, along with that, they are going to have recurrent sinusitis and situs inversus. That is, situs inversus, all the organs which are supposed to be on the left are going to be on the right. That's it. So direction, or sorry, side of the organs are going to change. So that is situs inversus. So bronchiectasis, sinusitis, and situs inversus is a triad of cartaginous syndrome. So one of the causes of bronchiectasis is cartaginous syndrome. Moving on to restrictive lung diseases, these four which we saw were obstructive lung diseases. In restrictive lung diseases, we have first one, pneumoconiosis. So pneumoconiosis is nothing but occupational diseases, which particles, if we inhale, which is of 1 to 5 micron size. Okay, the size is important. 1 to 5 micron size particles, if you inhale, it will reach up to the end of the alveoli and cause disease over there. So the most common pneumoconiosis is going to be the silicosis. Apart from that, we have coal workers pneumoconiosis, asbestosis as well, and many others. So silicosis, it is going to most of it is going to involve the upper lobe of the lung, except asbestosis, which is going to involve the lower lobe of the lung. So in asbestosis, we all know asbestos is an important risk factor for both mesothelioma and lung adenocarcinoma. Lung adenocarcinoma is much more common. So increased risk of lung adenocarcinoma, and mesothelioma is the most specific cancer though. Okay. And we get to see something called as asbestos body or ferruginous body in asbestosis. So these are nothing but there will be this asbestos fiber in the center, and surrounding which a coating of iron particles would have formed. So it characteristically has a dumbbell kind of an appearance, a beautiful one. So that is called as the ferruginous body. Ferru means iron. So iron coating over this asbestos fiber is called as ferruginous body or asbestos body. Since it contains iron, it can be stained with the Pearl-Prussian blue reaction. So what is Kaplan syndrome? So it is nothing but rheumatoid arthritis along with pneumoconiosis, which usually tends out to be co-workers pneumoconiosis. Okay, rheumatoid arthritis with pneumoconiosis is called as Kaplan syndrome. These again are SPM related MCQs. You can read it. Rest all, at least with the name, you can think. Just remember, byssinosis is for cotton dust, and then bagosis is for sugarcane dust. Then moving on to the granulomatous diseases. First is sarcoidosis. Sarcoidosis, we read about it when we were discussing granulomatous diseases. Remember? So I told it was a autoimmune, unknown etiology condition, disease of unknown etiology, which is going to have non-caseating granulomas, and they are called as naked granulomas because lymphocyte collar was absent. So characteristically, it will affect multiple systems, but the first one to be affected will be the hilar lymph nodes and the lungs, chest. Okay. It is going to be associated with various syndromes like Lofgren syndrome and Hereford-Waldenstrom syndrome. Another thing is these granulomas I told, no, these were actually, they can produce vitamin D. So these are called as vitamin D producing granulomas. Okay, vitamin D producing granulomas are a feature of sarcoidosis, right? Then microscopically, if you see here again, you can get giant cells, and in the giant cells, you can have some star-shaped bodies called as asteroid bodies, or some laminated calcification like Samoma bodies, which are called as Schaumann bodies. So asteroid bodies and Schaumann bodies are seen in sarcoidosis. Okay. Tuberculosis, not going into the detail, you'll be reading again in microbiology as well. Just remember Robert Koch. Robert Koch is the scientist who discovered this tuberculous bacillus. He gave the Koch's postulates as well. Then coming to pneumonia, we have typical and atypical pneumonia. Typical pneumonia is bacterial pneumonias usually, while atypical pneumonias are other viral infections or parasitic infections. These all can tend to cause atypical pneumonia. In typical pneumonia, usually we'll have exudates, infiltrates of neutrophils which are present inside the alveoli. While in atypical pneumonia, it is just outside the alveoli in the interstitial space. Okay, and usually it is of a chronic inflammatory type, lymphocytes. And then typical pneumonia is the one which is classified into lobar pneumonia and bronchopneumonia. So based on the distribution of the patches. So stages of pneumonia, we have the stage of congestion, red hepatization, gray hepatization, and resolution. So hepatization, as the name suggests, the lung tissue, which is actually spongy, is going to become like a liver. Liver is solid. So it will become like that. That is what we call it as consolidation, right? Solid. So red hepatization, as the name suggests, something red has to be present, right? So red is for RBCs. So RBCs will enter into the alveoli, and there will be fibrin production also. When with gray hepatization, these RBCs will get lysed up, and then along with the fibrin, it is going to be present. So that is why it is going to appear gray in color. So after some days, whether in 10 days, basically, it tends to resolve. So the most common causes of these pneumonia are important. So most common cause of pneumonia in burns patient is Pseudomonas. If you had attended internship, you will be knowing this for sure. So Pseudomonas is the most common infection in a burns patient. While in alcoholics, most common cause will be the Klebsiella, and then most common cause of community-acquired pneumonia will be Streptococcus pneumonia. And in ICU patients, just because they are kept in ventilators, Legionella infections are common. So with AC also, we tend to get Legionella infections. So long time, if you are not used humidifiers, ACs, from there you can get Legionella infections. So ICU patients, because of the ventilators, they tend to get Legionella infections. So hex pneumonia, I've already told. Measles, right? Measles is a virus. So measles is an atypical pneumonia, and here we tend to see Warden single D giant cells. Then coming to lung tumors. So lung tumors, we have three categories: squamous cell carcinoma, adenocarcinoma, and small cell carcinoma. Now, the most common lung cancer is adenocarcinoma. Okay, not SEC. It is lung cancer. Adenocarcinoma is the most common one, and as smoking related cancers are both the S for S. Okay, so squamous cell carcinoma and small cell carcinoma are going to be associated with smoking, while non-smokers, especially in females, adenocarcinoma are more common. Okay. And if you see, both the S again, smoking related ones are going to have a central location in the bronchus, while the adenocarcinoma is much more peripheral in location towards the pleura. Right. Then IHC for these things are again important. P63 and P40 are anywhere, not just for lung, anywhere squamous differentiation can be proved by P60 or P40 expression. These are squamous cell differentiation markers. And then TTF1 and then napsin A are specific markers which we use for lung adenocarcinomas. Then we have this synaptophysin and chromogranin. Anywhere synaptophysin and chromogranin comes, it is of neuroendocrine origin. Okay, so neuroendocrine origin, you can use synaptophysin and chromogranin bombesin. These are general things. Okay. We also have something called as lipidic adenocarcinoma. So previously, which was called as bronchoalveolar carcinoma. So it has a tendency to travel along the edges or along the walls of the alveoli. So it will not infiltrate into the interstitium. It just travels along the walls of the alveoli. So thus it has a very good prognosis. So now they had termed it into a lipidic adenocarcinoma. The way it travels, it is compared with the presence of butterfly on a fence. So they usually call this term. So butterfly on a fence appearance is usually seen in a lung adenocarcinoma. And something that is called as Azzopardi effect. So Azzopardi effect is seen in small cell lung carcinomas. These neuroendocrine tumors, they are usually very much aggressive, and especially the small cell lung carcinoma is very, very aggressive. So what happens is that the tumor is very, it divides rapidly, and with the division, the nucleus also gets broken up. So the nuclear material, the basophilic nuclear material, it tends to go on stain on the vessel wall. So the vessel wall will appear coated with this basophilic nuclear material. That is what we call as Azzopardi effect seen in small cell lung carcinoma. Okay. Coming to carcinoid tumors, these are again neuroendocrine tumors, but these are well differentiated ones. So carcinoid tumor, atypical carcinoid tumor, then comes the neuroendocrine carcinomas, which is the small cell lung carcinoma. So carcinoid tumor was a kind of a benign entity. Okay. So carcinoid tumors, the origin of this carcinoid tumor anywhere in the body is going to be Apud cell or Koncpt cell or ECL cells. So in intestine, we call it as ECL cells, this enterochromaffin-like cells. Koncpt cells, the other name for it, and then Apud, I think it is amine precursor, some uptake something. Okay, I don't remember it. So Apud cell is Apud cell, Koncpt cell, and ECL cells are the origin of this carcinoid tumor. So most commonly, if they ask, GI carcinoids are much more common than the bronchial carcinoids. Okay, and in GI also, it is more common in the ileum. This carcinoid tumors, they tend to secrete some substances like serotonin, 5-hydroxytryptamine, these things. Okay, so this serotonin, these are vasoactive amines as such, and they can cause carcinoid syndrome. So the substance responsible for carcinoid syndrome is serotonin, and this is going to result in vasodilatation kind of thing. So vasodilatation, flushing, and because of vasodilatation, BP will fall down, hypotension, diarrhea, these things can happen. Okay. In urine of these patients, if we see the metabolite of this serotonin is going to be 5-hydroxyindolestic acid, which I told in the tumor markers table as well. So that is going to be elevated in any neuroendocrine tumor. RS is done. Let's move on to GI pathology. So in GI, we have already seen about Barrett's esophagus while we were discussing metaplasia. So Barrett's esophagus is intestinal metaplasia in which there is going to be presence of goblet cells, which is the hallmark of Barrett's esophagus. And it is a penioplastic condition. It's seen in the lower 1/3 of the esophagus, which has a high risk of developing into adenocarcinoma. Then we'll see something about maltomas. So if they ask, what is the most common site of malt? Malt is mucosa associated lymphoid tissue. Okay, just malt, it is going to be ileum. Pairs, patches are there, no? So that is malt tissue. So most common site of malt will be ileum. But if they ask most common site of maltoma, then it is going to be stomach. Okay. The tumor is in stomach, but the patches are much more seen in ileum. But in general, if they ask most common extranodal site of the lymphoma itself, which is again stomach. Okay. And the most common site of extranodal lymphoma in AIDS will be PNS. Remember, DLBCL I told. So extranodal in general is going to be stomach only. Most common site of maltoma is also going to be stomach. Okay. This one I told, H. pylori is associated with both gastric adenocarcinomas and also with lymphomas, maltoma, right? So gastric cancer, here again, I'll highlight the important risk factors. Firstly, nitrosamines. So nitrosamine, which we have with this barbecues and all those things. So burnt food we take, right? So those are high, rich in nitrosamines, and they are very much prone for causing stomach and colonic cancers, okay? So salted and smoked foods, nitrosamines, pernicious anemia. So what is pernicious anemia? Pernicious anemia is again an autoimmune condition only. Here we have autoantibodies produced against the intrinsic factor. So intrinsic factor is one thing which is produced by the parietal cells of the stomach. This intrinsic factor is needed for absorption of B12. Okay. So without intrinsic factor, B12 deficiency will occur, and that will result in an anemia, which is specifically called as pernicious anemia. So this pernicious anemia is as such a preneoplastic condition for gastric adenocarcinoma. Then we have Menetrius disease. Menetrius disease, I'll tell it at the last as well. So it is nothing but there is going to be lots of the gastric rugae are going to be quite humongous, huge enough, and they will appear like brain folds. So they'll appear cerebriform. So cerebriform rugae are seen in it is Menetrius disease. Okay. Linitis plastica. So what is linitis plastica? So linitis plastica is nothing but the diffuse type of gastric cancer, which we see. So in gastric cancer, we have two types, which is intestinal type and the diffuse type. So gastric stomach tissue, which is going to have intestinal kind of tissue, cancer developing like an intestine, is called as intestinal tissue. The diffuse type is the one in which the cells are going to be singly infiltrated. So rather than a pattern, it is going to singly infiltrate like a signet ring, it will have a pattern. So cells will appear like signet ring, and they'll have a single cell infiltration pattern. And since they are infiltrating along the wall, they don't go and create a mass. They just thicken the wall of the stomach. So wall of the stomach will be quite thick that it appears as if it is a leather bottle. So leather bottle appearance is also called as linitis plastica. It is nothing but the diffuse type of gastric adenocarcinoma, right? Then GIST, gastrointestinal stromal tumor. So gastrointestinal stromal tumor is the most common GI mesenchymal tumor. So if they ask for mesenchymal only, it is GIST, not the general one. Okay. And it is associated with this Carney's triad. Carney's triad, I don't think they'll ask you. So the origin of this GIST is going to be interstitial cells of the Kajal. So interstitial cells of the Kajal is going to be present in the muscularis propria layer of the GIT. Okay. So between the inner circular and the outer longitudinal layer, this it is going to be present. So interstitial cells of the Kajal, this is the origin of this GIST. So we have multiple mutations of the with the most important, the most common one is going to be the CD117 or c-KIT. c-KIT mutations or the CD117. So where else did I mention the c-KIT? By reading this neoplasia table, I mentioned c-KIT mutations are seen in both in seminomas and also in GIST. Okay. both these places you need to remember. c-kit is also called as CD117. So that becomes the IHC marker for it. CD117 positive tumor is this myeloid leukemias are also CD117 positive, as well as GIST is also CD117 positive. If they ask most sensitive marker, it is going to be CD117. If they ask more specific, it is going to be DOG1. Then coming to the ulcerative lesions of the intestine, we have three major ulcerative lesions: the tuberculous, typhoid, and then amoebic. So this one we have been asked a number of times in MBBS as well. How do you differentiate grossly? So tubercular ulcer is going to be a transverse ulcer. Typhoid is going to be a longitudinal ulcer, but amoebius is going to be a flask-shaped ulcer. This one you need to remember. So I remember it like tie is going to be quite long, right? The necktie they wear, it is going to be quite long. So tie for long. So tie long, I remember. So rest all amoebiasis is flask-shaped ulcer. Tuberculosis is transverse. Okay. Erythrophagocytosis. So erythrophagocytosis is nothing but the phagocytes, the macrophages, they are going to take up the RBCs as well. So the RBCs will be present inside the cytoplasm of the macrophages. That is what we call it as erythrophagocytosis, which is a feature of the amoebiasis. Okay. Then we have something called as pseudomembranous colitis. So pseudomembranous colitis, it is usually a complication of a repeated antibiotic usage. So long-term antibiotics. So after that, what will happen? The patient will have some very bad diarrhea. So that is because of this Clostridium difficile infection. So if you check the gross or microscopy of the patient, in the gross, they will be having a pseudomembranous appearance. A membrane will be formed on the intestine. So this yellow thing which we see here, right? So all this is the pseudomembrane. So pseudomembranes are nothing but exudative necrotic material only, which forms a membrane kind of thing. So pseudomembrane is seen in Clostridium difficile infections. And this pseudomembrane will have a volcano-like eruption kind of a appearance on microscopy. So this is the normal level, surface level, but this is the pseudomembrane which has been formed, which looks like some mushroom or a volcano, right? So that appearance is seen in a pseudomembranous colitis. Then moving on to malabsorption syndrome. Here again, we'll be highlighting the higher important points. So Whipple's disease. So Whipple's disease is caused by a actinomycete, which is called as Trophorema whippleyi. Trophorema whippleyi causes Whipple's disease. Why is it important? Because it is going to mimic tuberculosis. Okay. So basically, in the lamina propria, if you see, they are going to be filled up with this foamy macrophages. So everything is foamy macrophages, and inside this foamy macrophages, it is actually the organism which is present. Okay. So that Trophorema whippleyi, which causes this malabsorption, is seen. Then comes celiac disease. So celiac, very favorite question for everyone. So celiac disease, what are the foods which can trigger celiac disease? It is also called as gluten sensitive enteropathy. So gluten containing foods which are called as bro foods: barley, rye, oats, and wheat. So bro foods can trigger celiac disease. It is actually a type 4 hypersensitivity reaction. So this gluten, it gets broken down into gliadin. So against this gliadin, there is going to be a reaction, and then it is going to cause enterocyte apoptosis finally. So enterocytes will die, the intestine. The antibodies associated with this celiac disease is anti-transglutaminase, anti-gliadin antibodies, anti-endomycin antibodies. They ask what is the most sensitive. It is anti-transglutaminase. Most specific, it is going to be anti-endomycin. You will think that gliadin is the one which is present in the food, so that will be more specific, but no. Okay, anti-endomycin is the most specific, while anti-transglutaminase is the most sensitive. And it is also associated with the skin condition called as dermatitis herpetiformis. So if in skin, if you read this dermatitis herpetiformis is the one which has this micro abscess at the tips of the papillary dermis. So there is going to be abscesses of this papillary micro abscess in this dermatitis herpetiformis. Okay, and it is IgA related, mucosal immunity, right? And since it is related with celiac disease, it is also going to have this IgA related thing. So on immunofluorescence with IgA, this papillary microabscess can be highlighted on indirect immunofluorescence. So as such, celiac disease is a preneoplastic condition which can trigger adenocarcinoma or a T-cell lymphoma, okay, enteropathy associated T-cell lymphoma, EATL. So it is a preneoplastic condition. And one other important thing about celiac disease is that there is going to be shedding of the enterocytes. The apoptosis of the enterocytes is going to be there. So the villus will be atrophied. So villus are nothing but finger-like projections like this, right? So the villus will be atrophied and flattened. But what will happen is that the crypt, which is the part here, it is going to undergo hyperplasia. So the height as such here should have been more, but this one had come down, but the pits are increasing in size. So what happens is that the height of the villi remains the same. So the mucosal thickness will remain the same. Even though there is villus atrophy, there is going to be cryptic hyperplasia, resulting in the thickness of the mucosa remaining the same. This is an important question. Then coming to our favorite, which is inflammatory bowel disease. So we have all read this in a comparative manner, Crohn's disease and ulcerative colitis. So again, we'll highlight only the important points. So most common site of Crohn's disease is going to be terminal ileum. It will start in terminal ileum, while ulcerative colitis will always start from the rectum. So from the distal end, it is going to start and go up proximally. Okay. So the most important thing is the extra intestinal manifestations. So in that, ulcerative colitis is associated with primary sclerosing cholangitis. So PSC is again an autoimmune condition. We'll be reading it now. So the PSC is going to be associated with this ulcerative colitis. Both of Crohn's and ulcerative colitis has an increased risk of developing into colonic adenocarcinoma, but the maximum risk is with that of the ulcerative colitis. Skip lesions, fissures, strictures, and fistula. All of these are features of Crohn's disease. Okay, skip lesions means the disease is not a continuous disease. So here there will be normal mucosa, then there will be disease mucosa. It will be like that, alternating. So this is called as skip lesions, and because of the skip lesions, the diseased part and the normal part is going to give the appearance of a cobblestone. So cobblestone appearance, skip lesions. Apart from that, strictures, fistula, fissures, all these are features of Crohn's only. Okay. While the ulcerative colitis is going to have continuous lesion. So from the rectum, it is going to go back continuously, and it is going to reach up to the small intestine also. So it can go and involve the entire colon. So it is called as pancolitis. So continuous lesion, pancolitis can happen. So sometimes can even attack the ileum, causing backwash ileitis. So pseudopolyps, toxic megacolon are all features of ulcerative colitis. So with this involvement, the continuous involvement, the entire intestine is going to appear smooth without any hostrations, and it is going to appear like a lead pipe. So usually we draw the colon like this, right? So that is called as hostrations. So without that, it is going to appear smooth like this, like a lead pipe. So lead pipe appearance is called as the ulcerative colitis, in ulcerative colitis. And microscopically, if you see, both of it can have ulcers and everything, but non-caseating granulomas are seen in Crohn's disease, okay, fully evolved ones. And cryptitis and crypt abscess are seen in ulcerative colitis. So if they ask for fistula, fissures, strictures, and all these things, granulomas, these are none of it is going to be present in ulcerative colitis. Ulcerative colitis is the one usually, because there is going to be ulcer, and it's usually present with bloody mucoid diarrhea. Okay, nocturnal diarrhea. Then coming to polyps of the intestine. So only the major polyps we'll discuss. The first polyp is the Peutz-Jeghers polyp. So it is a non-neoplastic polyp. It is associated with STK11 or LKB1 gene. So while reading neoplasia also, I told STK11 gene, remember? So it is associated with the PJ polyp. So it is an autosomal dominant condition affecting young adults. So the classical triad will be that of they'll have multiple pigmented or perioral hyperpigmentation, perineal and also perioral hyperpigmentation will be present. Apart from that, multiple hamartomatous polyps will be present. Okay. Multiple hamartomatous. And the polyp as such it is called as an arborizing polyp. Arborizing means a branching like a tree. Okay, arborizing polyp, and the branches of the tree are formed by smooth muscle fibers. So none of the polyps as such has this appearance. It is a very beautiful and a characteristic image of a PJ polyp, arborizing polyp with the core of which is formed by the smooth muscle branching fibers. Okay. There is going to be increased risk of n number of cancers. But as such, that polyp is not going to turn into a malignancy. That is why it is a hematomatous non-neoplastic polyp. Okay. Then in neoplastic polyps, we'll discuss about tubular polyps, tubular villus polyps, villus adenomas. These are all adenomatous precursors, okay, to colonic cancer. Apart from that, we'll have two things: familial adenomatous polyposis and Lynch syndrome. Okay, FAP is going to be autosomal dominant. Again, the gene was APC present on chromosome 5q. So what was APC? It was the gatekeeper of the colonic neoplasia. I told, right? So in this patients, it is also an autosomal dominant disorder. So in these patients, they'll have more than at least 100 polyps should be present in the intestine. So remember, at least 100, just imagine. So at least 100 polyps should be there for diagnosing FAP. And these polyps are prone for developing into cancer. So they have to undergo a prophylactic colectomy and remove the intestine. Okay. Because by the age of 30, they are prone for developing colonic cancer. So other variants of this FAP syndrome are Turcot syndrome and Gardner syndrome. So Turcot syndrome is usually related with brain tumors, medulloblastoma usually, and Gardner syndrome is usually associated with fibromas and osteomas. Okay, bone-related things will be seen with Gardner syndrome. Sorry. Then comes colonic cancer. So colonic cancer, I told FAP is a important risk factor. Other than that, I told HNPCC. So HNPCC was a Lynch syndrome, MMR defect, which is a mismatch repair defect. So HNPCC's name is hereditary non-polyposis colonic cancer, meaning there is no polyps here. Okay, and I told CEO, it has colon, endometrium, and ovarian cancer risk. So when I told APC, I told it is the colonic gateway of colonic neoplasia, right? And I told it is the first gene to be mutated in colonic cancer. So this thing we'll study in surgery as well. So colonic cancer on barium study will have a apple core appearance. So you'll be reading about achalasia cardia, esophageal cancer, then apple core appearance, all these things. So all of them have rat tail appearance, bird beak appearance. So you need to remember these things. So I told Menetrius disease was a precursor lesion to gastric adenocarcinoma, remember? So I told it is going to have giant rugae, which is going to appear like the folds of the brain. So cerebriform rugae are seen in Menetrius disease, which is a preneoplastic condition for gastric adenocarcinoma. GIT is done. Next, we'll see liver pathology. We'll have a break of 10 minutes, okay? We'll commence at 10:10.
चिकन रखा दिखाई जाए चला जाए वरना दाया चिकन वरना नीचे फोन फोन कर चला दाया सब नूती बोला भाई याना तुम्हारा क्या बोल रही है जो अब कॉल कर रही है क्या करते दाने देखिए खत्म होगी नहीं कहीं जा पाएगी अरे चिकन डाल रही है
AFP levels. So the AFP levels are going to be normal in HC, fibrolamellar variant. So already I told AFP is alpha fetoprotein, which is elevated in HCC, hepatoblastoma, and yolk sac tumors. But AFP is going to be normal in this fibrolamellar variant of HCC. So the marker of this fibrolamellar variant is going to be neurotensin, while it is elevated AFP is going to be seen in the HCC. So this thing you need to remember, it has the good prognosis, and usually HCC has, even though it's a carcinoma, it was an exception. It usually tends to metastasize via hematogenous spread, but fibrolamellar variant has a lymphatic spread. Okay, so we are done with liver. Next, we'll move on to renal pathology. So renal system, the most important thing here will be the glomerular diseases. So glomerular diseases, we all know it is divided into nephritic and nephrotic syndrome based on the presentation of the kid. So presentation of the patient. So nephrotic syndrome is the one in which there is going to be massive proteinuria. So the proteinuria range is more than 3.5 gram per day. Okay, more than 3.5 gram per day. And once the proteins are being lost, the patient is going to have severe edema. Okay, severe edema is there. Apart from that, the patient will also have hyperlipidemia. By nephrotic syndrome, the case presentation will be that of a, there will be proteinuria here also, but the range will be less than 3.5 only. There will be hematuria, hypertension, oliguria, along with that RBC casts. So hematuria, hypertension, and oliguria are features of nephritic syndrome. So this nephritic and nephrotic syndromes are just presentation. So various patterns of renal disease comes under that. So we have PSGN pattern, FSGS pattern. These patterns are there. So many diseases can present with these patterns. So that is what I want to imply here. So starting with nephritic syndrome, we have PSGN. So PSGN is post streptococcal glomerulonephritis. As the name suggests, it is going to be post a streptococcal infection, usually a pharyngitis or a skin impetigo. Again, the same bacteria only, group A beta hemolytic streptococci. So we read about the same bacteria in RHD as well, right? Molecular mimicry was there. So same bacteria, but here it is going to cause glomerulonephritis. And the classical history will be cola colored urine. The urine is going to have a red, brownish red appearance because of the hematuria. Okay. So microscopically, if you see the other name for PSGN is actually acute proliferative glomerulonephritis. So what is proliferating? So everything inside the glomerulus is going to proliferate. So the inflammatory cells, the mesangial cells, the endothelial cells, everything is going to proliferate, and the glomerulus is going to look very huge and hypercellular. Okay. And apart from that, there is immunofluorescence. If you see the immune complex, it is an immune complex disease. So the immune complexes which are depositing in this PSGN is going to give a characteristic starry sky appearance. So where else do you see starry sky appearance in pathology? it is seen in Burkitt's lymphoma. So Burkitt's lymphoma, there is going to be lymphocytes along with the tingible body macrophages, which look like stars in a sky. Okay, so starry sky appearance is seen in PSGN and also Burkitt's lymphoma. And electron microscopically, it is called as subepithelial humps. It is so huge, the complexes are deposited so huge, and the location is going to be subepithelial. That is given the name of subepithelial humps, lumpy, bumpy appearance. Okay. The next one is rapidly progressive glomerulonephritis pattern. So RPGN is basically represents the severity of a disease. So any nephritic or a nephrotic syndrome, at its end stage, it can progress on to RPGN. And the classical feature of an RPGN is going to be the formation of crescents. So crescents are nothing but, remember it by the mnemonic flip. Okay. So F for fibrin, then L for leukocytes. The monocytes and macrophages are basically leukocytes, right? And then P for parietal epithelial cells. So crescents are formed by this flip components only. And the severity of the disease is based on the number of the crescents as well. Okay, so RPGN, we have three types, type 1, type 2, and type 3. The type 1 is the one which is classical of Goodpasture syndrome. So here there is going to be presence of anti-basement membrane antibody. So here the non-collagenous 1 domain, so NC1 domain of the alpha 3 chain of type 4 collagen. So type 4 collagen is the collagen which is present in any basement membrane. So in that, the chain which is involved is the alpha 3 chain. So this alpha 3 chain is going to be affected by this anti-glomerular basement membrane antibody. So in Goodpasture syndrome, the basement membrane of both the kidney and the lung alveolus is going to be affected. So the patient will present with both hematuria and hemoptysis. Okay. The classical history of hemoptysis and hematuria, they'll ask what type of RPGN or what disease it is. It is Goodpasture syndrome, which is type 1 RPGN because of anti-basement membrane antibody against alpha 3 chain. Then comes type 2, which is basically the immune complex mediated. So whatever immune complex glomerulonephritis we are studying, in its severity, the severe disease, it can progress on to RPGN. So always immune complex is, whenever immune complex disease is there, it is going to result in a granular immunofluorescence pattern. So remember, immune complex will always have granular immunofluorescence pattern. Since Goodpasture syndrome was against the base membrane. So base membrane is a linear structure. So antibody against that will also be sticking onto that base membrane. So it will give a linear kind of immunofluorescence. So linear immunofluorescence in type 1 RPGN Goodpasture syndrome, while granular immunofluorescence is seen in type 2 RPGN, is related with immunocomplex mediated diseases. Then type 3 was the posse-immune mediated. Remember the ANCA-associated vasculitis we were speaking about, microscopic polyangiitis, Wegener's granulomatosis, and Churg-Strauss. So all of these three things are posse-immune, meaning there will be no immune deposits on immunofluorescence, just that it will be ANCA-associated. Then coming to, now we are seeing nephritic, and move on to nephrotic syndrome. So nephrotic syndrome, first disease will be the minimal change disease, which is the most common nephrotic syndrome in child. So all of us would have presented a pediatric case during our MBBS time. So minimal change disease is usually affecting children more than adults, but the severity will be more in adults. Okay, so it has selective proteinuria. So selective proteinuria is seen only in this minimal change disease, that is only albumin will be excreted here. So as the name suggests, minimal change, meaning on light microscopy or immunofluorescence, there is not going to be any change at all. Only thing is it has lipoid nephrosis. So in the proximal convoluted tubules, there will be cells which are laden with this lipoproteins. Since hyperlipidemia is a feature of nephrotic syndrome, I told, right? So this hyperlipidemia, this lipids will tend to get excreted in the urine. So during that time, reabsorption from the in the PCT will happen, which results in this lipoid nephrosis. So lipoid nephrosis is nothing but minimal change disease. Then is membranous nephropathy. So in membranous nephropathy, this is the most common nephrotic syndrome in elderly. So here again, we have many types, primary and secondary, not going into the detail there. So here the most important thing is spike and dome pattern. So spike and dome pattern is going to be seen in membranous nephropathy. So it is actually because of the subepithelial deposits which are epimembranous. Okay, subepithelial PSGN, it was subepithelial humps. Okay, but here it is epimembranous or subepithelial deposits. Then comes MPGN, which is membranoproliferative glomerulonephritis. This is a combination of both nephritic and nephrotic syndrome, and eventually it can progress on to RPGN as well. So here again we have type 1, 2, and 3. And the important one here will be the type 2, which has been a new entity. The MPGN type 2 is also called as the dense deposit disease. Okay, dense deposit disease. So the immunofluorescence, if you see here, it is against the membrane basically. Okay, so it is going to form a ribbon like intramembranous deposits. The deposits will be present on the membrane, so it will have a ribbon like pattern, like a linear pattern. It will be present. Otherwise the MPGN is of a subendothelial deposit. So subepithelial deposit we have seen, subendothelial deposit we have seen, membranous deposits we had seen. And another important thing here will be the double contour or the tram track appearance. So the double contour or the tram track appearance is basically because of a duplication and splitting of the base membrane. It will appear as if it is duplicated and split like this. So that is going to appear like a tram track. So tram track or the double contour appearance is seen in MPGN, while silver spike and dome pattern is going to be seen in membranous nephropathy. Next will be focal segmental glomerulosclerosis. So this is the most common nephrotic syndrome in adults and also overall. So in general, if they just ask most common nephrotic syndrome, it is FSGS. Most common nephrotic syndrome in adults, FSGS. Most common nephrotic syndrome in children, minimal change disease. Most common nephrotic syndrome in elderly, it is going to be membranous nephropathy, right? So FSGS is associated with certain specific causes. At least you must remember HIV and then sickle cell disease. Okay, sickle cell disease and HIV are associated with FSGS. So we have this diseases, the gene, it can also, FSGS can also be inherited. So the genes are NPHS1, which is encoding nephrin, NPHS2 encoding podosin, alpha actinin 4, and TRPC6. So all of this can present with a nephrotic kind of syndrome. Okay. The collapsing variant of this FSGS is the one which is associated with worse prognosis, and it is also the one which is associated with HIV. So HIV associated nephropathy, HIVAN, I told, right? So HIVAN is a form of collapsing variant of FSGS. Then coming to IgA nephropathy. If they don't ask whether it is a nephritic syndrome or a nephrotic syndrome, just they are asking glomerulopathy. Okay, glomerulonephritis seen in a worldwide, most common glomerulonephritis worldwide, that is IgA nephropathy, and this is the Buerger's disease. Buerger's disease was TAO, which we saw in thromboangiitis obliterans, like vasculitis, remember? But in Buerger's disease is IgA nephropathy. This is the most common glomerulonephritis worldwide, and it is the most common cause of recurrent hematuria as well. So back-to-back hematuria is going to be there in these patients. And this IgA nephropathy is the one which is associated with mesangial deposits. Okay. Till now we saw subepithelial, subendothelial, membranous, and mesangial is the one which is associated with this IgA nephropathy. Okay. Then Alport syndrome. Alport syndrome, we read it as an example in X-linked dominant. But that itself, I mentioned, it can have all types of inheritance, but the most common was X-linked dominant. So here, the antibodies are actually formed against all the three chains, alpha 3, alpha 4, and alpha 5 chains of the collagen, type 4 collagen. Okay. Alpha 3 alone, I mentioned for Goodpasture syndrome, while alpha 3, 4, 5 for Alport syndrome. These two at least you need to remember. And Alport syndrome is actually a very beautiful triad. It is a triad of hematuria, sensory neural hearing loss, and then anterior lenticonus. So eyes, then ears, and then renal. Okay, anterior lenticonus, sensory neural hearing loss, and hematuria. It's a syndrome, classical triad of Alport syndrome. Here, Alport syndrome, it is a hereditary nephritis since it's having all these kind of X-linked dominant, autosomal recessive, autosomal dominant, whatever. And here again, the patient is going to present with repeated hematuria only, like IgA nephropathy. But one thing important about this one is the basket weave appearance. So basket weave appearance on electron microscopy is the feature of Alport syndrome. It is because of there is this splitting and then there will be multilayering, that is lamination. So lamination and splitting of this lamina densa of the basal membrane is going to happen, which will appear like a basket weave pattern. Okay, so basket weave pattern, we see it in Alport syndrome. Then spike and dome pattern, we see it in membranous nephropathy. Then we saw about double contour or tram track appearance in MPGN, right? Then moving on to lupus nephritis. Lupus nephritis, I already told. Type 4, which is the diffuse proliferative nephritis, lupus nephritis is the most common one. And in that, it is the most commonly one associated with the wire loop lesions as well. So here the deposits will be subendothelial in location, and the subendothelial, it is an immune complex disease, right? It is a type 3 hypersensitivity. So the deposits will be composed of everything, IgM, IgG, IgC, C3, everything will be there, IgA. So since every immunoglobulin complement deposit is present in SLE, it is also called as full house effect. Okay. Then moving on to systemic disorders affecting kidney, we have hyaline arteriosclerosis and hyperplastic arteriolosclerosis. So hyaline arteriolosclerosis is when there is some pinkish amorphous material seen surrounding the vessel wall and narrowing the vessel wall. So this is a feature of benign hypertension and also diabetic mellitus. As such, this hyperplastic arteriolosclerosis is when there is multiple layering of the smooth muscle of the vessel. Okay, so it is going to increase in thickness and cause the lumen decrease in size. So this multiple layering of the smooth muscle of the vessel is going to appear like a onion skin. Okay, so multi-layering like a lamination is going to appear. So onion skinning or hyperplastic arteriolosclerosis is seen in malignant hypertension. Then coming to diabetes mellitus, this one is an important question. So what is the most important predictor of nephropathy? Whether the patient will develop nephropathy or not, diabetic patient will develop nephropathy or not, it will depend on the duration of the disease. So how long the patient has been having the disease. So the earliest lab finding for this patient will be elevated GFR, while earliest histological finding will be just basement membrane thickening. So capillary basement membrane will be thickened. Then most common histological finding, if they ask, is going to be diffuse glomulosclerosis. Okay, like SLE, here also it is diffuse glomulosclerosis. But most specific, if they ask, it is going to be Kimmelstein-Wilson lesion or the nodular glomulosclerosis. KWB lesion is a very important one. Kimmelstein lesions are seen in diabetic nephropathy, right? So most common will be the diffuse glomulosclerosis. Most specific will be KW lesion or the nodular glomulosclerosis. Earliest will be the capillary basement membrane thickening. Apart from that, I also spoke about the Armani-Epstein lesion when we are discussing intracellular accumulation glycogen. Remember? Then thyroidization of the tubules. Basically, the renal tubules will be enlarged and the central material is going to appear somewhat pinkish in color, and it is going to give the appearance of a thyroid colloid. Okay, so that kind of an appearance, which is called as a thyroidization of the tubules, is seen in chronic pyelonephritis, which is basically infection of the kidney. Usually it is ascending infection with the E. coli infection. Okay. Then renal tumors, Wilms tumor. Wilms tumor is the most common primary renal tumor seen in the childhood, which is less than 5 years of age group. And we all know it is a triphasic tumor composed of a blastemal component, which is an undifferentiated cell type. Then we have the stromal component, which is the interstitium. And then we have an epithelial component, which is formed by the abortive tubule. So it is a triphasic tumor. It is the most common primary renal tumor of the child. It is the Wilms tumor. Genes affected will be Wilms tumor WT 1 and 2. Gene will be chromosome 11. And moving on to RCC. The RCC, there are various syndromes associated with RCC. Just important ones we'll see. VHL syndrome is associated with clear cell RCC. Then hereditary papillary RCC syndrome, as the name suggests, it is associated with papillary RCC. Same for HLRCC, it is associated with papillary RCC. Then sickle cell anemia is associated with medullary RCC. There is a type of RCC called as medullary RCC, which will originate from the medulla of the kidney. So sickle cell anemia patients are prone for developing medullary RCC. While patients who have some cystic kidney disease or the patients undergoing some dialysis kind of thing, so both the cystic kidney disease and dialysis are associated with papillary RCC. Okay. But as such, if they ask most common RCC, it is going to be clear cell RCC associated with chromosome 3p deletion, which was the VHL syndrome gene. Okay. Then coming to the urine microscopy, we can see about the urine microscope, urine crystal shape. Okay. So if they give a dumbbell shaped crystal, so in dumbbell shaped crystals are nothing but calcium oxalate crystals. So calcium oxalate can be either a monohydrate form or a dihydrate form. So monohydrate form are the ones which appear like the dumbbell shape, while dihydrate form appears like the envelope shape. Okay. Dumbbell, then envelope. Then uric acid crystals are rhomboid in shape, while triphosphate crystals are coffin lid shaped. At least these things you know. Then bladder tumors, already I have highlighted. The most important risk factors, most common carcinoma in bladder is going to be transitional cell carcinoma, except when there is schistosoma hematobium, which is going to be a risk factor for squamous cell carcinoma. Apart from that, aryl amines are going to be like benzidine are going to be important risk factors for developing bladder cancers. So don't forget to go through that risk factor carcinogenesis table in the neoplasia chapter. So there is something called as malakoplakia. It is infectious condition only, but here it classically produces something called as Michaelis-Guttman bodies. These are nothing but lamellated calcium only present inside the cells. So because of protease or E. coli infection, there is going to be this deposition of calcium laminations called as Michaelis-Guttman bodies. Michaelis-Guttman bodies are seen in malakoplakia. Next, in breast cancer, we all know BRCA1 and BRCA2 are associated with breast cancers, right? These were tumor suppressor genes. Then the most common breast cancer is going to be invasive breast cancer, invasive ductal carcinoma. So IDC we call it as. So invasive ductal carcinoma is the most common breast cancer. So based on gene expression profiling, breast cancers are classified into luminal A, luminal B, HER2 enriched, basal type, which is triple negative, and Claudin law. So luminal A is when there is going to be positivity for both ER. Luminal subtype itself is when ER/PR, estrogen receptor and progesterone receptor positivity is there. When HER2 new is also positive, it becomes luminal B, and HER2 new is negative, it becomes luminal A. So both the luminal categories are associated with BRCA2. Okay. So BRCA2 is the one which is associated mainly with male breast cancer. Male breast cancer is associated with BRCA2 more than BRCA1. And the luminal subtype, whenever there is ER/PR positive, we can give hormonal therapy. So the patient is going to have a very good prognosis. Even for HER2 new, we have hormonal therapy trastuzumab, but still it is not as good as that of a luminal A kind of subtype. Okay. Then Indian file pattern. So Indian file pattern is nothing but the cells are arranged like a file, Indian file. So back to back in a line, one after another, it is going to be arranged. So it's called as Indian file pattern. It is going to be seen in lobular carcinoma of the breast. Basically, the cells are going to be discohesive, singly lined cells, but they will be arranged one back to back like that in a line. Okay. So that is called as Indian file pattern seen in lobular carcinoma. And the single cells is again going to have a pattern, appearance of signet ring. So like Linitas plastica, gastric carcinoma, I told, right? So there again, the mutation is going to be that of E-cadherin. So whenever E-cadherin is lost, the cell addition will not be present and the cells will be singly scattered. And they usually tend to have a signet ring kind of morphology. So both lobular carcinoma and Linitas plastica will have E-cadherin mutation, in which we are going to have the signet ring cells, right? Under CNS pathology, we'll see about meningitis first. So meningitis can be is going to be caused by infective causes mainly. So under that, if they give a history of a cobweb kind of a coagulum in the CSF, what do you suspect? You have to think of tuberculosis. So cobweb coagulum is for tuberculosis. Apart from that, cloudy, if CSF is quite cloudy and turbid, then you have to think about a bacterial cause. Then coming to other infections, CMV, I already told owl eye appearance when we were discussing Reed-Sternberg cells of Hodgkin's lymphoma, remember? So owl eye appearance are seen both in CMV infection and also in Reed-Sternberg cells. Negri bodies are seen in rabies virus. So rabies viral infection, encephalitis, there is going to be presence of this Negri bodies in the neurons. These are nothing but intracytoplasmic inclusions only. The most characteristic lesion in a HIV encephalitis is going to be the presence of microglial nodules. So microglial nodules, characteristic lesion seen in HIV encephalitis. If they specifically ask for the most common cause of fungal meningitis, then it is Cryptococcus. And Cryptococcus, the beautiful picture is of a soap bubble cyst. So the cryptococcal fungal organism itself has a thick capsule, which is going to be stained by mucicarbon. So this thick capsule is going to be there. It's going to form multiple cysts, which makes the lesion appear as if it is a soap bubble abscess. Okay, so soap bubble cysts are seen in cryptococcal meningitis. Stain of the capsule will be stained by mucicarbon stain. Mucor and aspergillus, we all must have seen cases of COVID. So during that time, because of immunosuppressed individuals, they were having a high risk of this mucor and aspergillus fungal infections. As such, they are very bad because they cause vascular infection in invasion and form thrombus also. So they can go anywhere, affect anywhere in the face and reach the CNS as well. And the usual fungal stain is periodic acid chip PA stain. Apart from that, the specific stain we can use is that of a Gomorrhe's methenamine silver. So how do you differentiate between mucor and aspergillus is that mucor is going to be aseptate. That is, there is not going to be any septate. So it is a very broad kind of a fungus, aseptate, and then it is going to have 90-degree perpendicular angle. Okay, it is going to be like this. While aspergillus is going to be thin one and it has septate and it has a acute angle of branching. Okay. This is the picture of aspergillus. Then coming to demyelinating diseases, you just remember that oligoclonal bands in CSF are characteristic of multiple sclerosis. Okay, it is a demyelinating disease, and there will be excess of immunoglobulin seen in the CSF, and when you put electrophoresis on that, you can see oligoclonal bands of this immunoglobulin. Then Alzheimer's, when we are discussing Down syndrome also, I told these patients are prone for developing this Alzheimer's disease at an earlier age because of the presence of APP gene, amyloid precursor protein gene, which is also present on chromosome 21. And as such, Alzheimer's disease, the amyloid which is associated with Alzheimer's is going to be A beta. So A beta is going to form the A beta plaques. So that will form the neuritic plaques and neurofibrillary tangles, which are classical for a Alzheimer's disease. Then there are many inclusions in CNS. So I'm just telling, Negri bodies, we saw it in rabies, while Lewy bodies are going to be seen in Parkinson's disease. So Parkinson's disease is that mask faces we read in physiology. So that is because of the deficiency of the dopaminergic neuron seen in the basal ganglia. So there we are going to see Lewy bodies in Parkinson's disease. Then Huntington's disease, when we are discussing trinucleotide repeat, I had mentioned that the repeat will be of CAG. Okay. So in Fragile X syndrome, the repeat was CGG, and I told the full mutation will be when the repeats are more than or equal to 200. Okay. While for Huntington's, the number of repeats is more than 35. Okay. More than 35, the repeats will result in Huntington's disease. And anticipation is a feature of any trinucleotide repeat disease. Next, coming to Prions diseases. So Prions disease is a rapidly progressive dementia disease. Usually, most common cause of this disease is going to be iatrogenic. That is, during neurosurgery or some corneal transplant, the infection can enter. And prions are usually misfolded proteins only, but these are transmittable and they are rapidly fatal also. Okay. Then examples of Prions disease will be And the characteristic microscopic finding of a prions disease is the spongiform neurons. So the neurons will appear like a sponge, forming a grape-like vacuoles. Because of the grape-like values, it appears like a sponge. Okay. Moving on to the CNS tumors, if they ask the most common brain tumor, it is metastasis. Always look at the question carefully. If they don't mention primary and in general they're asking, it is always metastasis. Any organ, it is usually metastasis, which is the most common tumor. If they ask specifically primary CNS tumor, then you look for whether they are asking for a benign tumor or a malignant tumor. Then you'll see for whether it is a child or an adult they are asking. Okay. So in a child, if they ask the most common primary tumor, okay, benign tumor will be a pilocytic astrocytoma, while a malignant tumor will be the in a child most common will be medulloblastoma. The same thing if they ask most common primary benign tumor in an adult, it will be a meningioma, while if they ask the most common primary malignant tumor in an adult, it will be glioblastoma. Okay, so based on the question, your answer will change. So butterfly tumor is also glioblastoma because this tumor tends to cross the midline and affect the other frontal lobe as well. So it gives appearance of a butterfly. So butterfly lesion is seen in glioblastoma, and the most a big question is the serpentine necrosis. Serpentine necrosis or pseudopalliciding necrosis is a feature of glioblastoma. So the necrosis in this is going to have this snake kind of pattern, and surrounding which the tumor cells are going to be seen. So this gives an appearance of pseudopallisading. That is why it is called a serpentine necrosis or pseudopallisading necrosis. Same thing, they ask for fried egg appearance. In general, fried egg appearance, two things we have to remember in pathology. First, fried egg appearance in CNS tumor, it is seen in oligodendroglioma because the cell appears to be sitting in a perinuclear halo. Okay, so that is why it is called as fried egg appearance, oligodendroglioma. Apart from that, even in hairy cell leukemia, on microscopy, you tend to have this fried egg appearance. Okay. Then schwannoma. Schwannoma is usually the common site will be the cerebellopontine angle, which is the CP angle, and usually it affects the inferior vestibular branch of the 8th cranial nerve. Okay, so auditory nerve is going to be affected, inferior vestibular branch. And schwannoma and meningioma, both of it will be associated with neurofibromatosis type 2. So my classical microscopy of schwannoma is get to see Verroque bodies, Antony areas, and Antony B areas. So cells are going to be hypercellular in the Antony areas, A areas, and they will be arranged, the nuclei will be arranged parallel to each other. So true palisading is going to be seen. So that is what is called as a Verroque body. And then they alternating with that, there is going to be loose hypercellular areas. So it is a very beautiful picture of a schwannoma. So Antony A and Antony B areas will be seen along with Verroque bodies in schwannoma. In genital system, very few things only we'll see. So most common germ cell tumor in male, if they ask, is going to be seminoma. Okay. So the counterpart of seminoma in female was dysgerminum. So if they ask germ cell tumor, it is seminoma, right? And it is a very chemosensitive and a radiosensitive tumor. Okay. So it has a very good prognosis. IHC, I already told, PLAB, OCT3/4, and NANOG. These are positive IHCs for seminoma. Then yolk sac tumor, where did we see this yolk sac tumor? Alpha fetoprotein. So alpha fetoprotein is seen in hepatocellular carcinoma, hepatoblastoma, and yolk sac tumor. So alpha fetoprotein and alpha-1 antitrypsin are both positive in yolk sac tumors. And as such, this is the most common germ cell tumor in infants less than 3 years. So if they ask in general germ cell tumor, it is seminoma. Less than 3 years, it is going to be yolk sac tumor. So Schiller-Duval bodies, which are also called as glomeruloid bodies, are seen in yolk sac tumors. Okay. Schiller-Duval bodies, do not confuse it with Kohl-Exner bodies, which are seen in granulosa cell tumor. Okay. Schiller-Duval is for yolk sac, Kohl-Exner is for granulosa cell tumor. Then teratoma. So teratoma, we all know it is a germ cell tumor which is going to arise from more than 2 germ cell layers. At least 2 germ cell layers should be present. So from the ectoderm and endoderm and the mesoderm, all 3 germ layers also we can sometimes get a teratoma. And usually it is cystic and benign, and it is termed as a dermoid cyst, but it can become malignant and or an immature teratoma also. So all 3 layers in that case, you get to grossly also you can get to see bone, teeth, hair. All these things can be seen on a gross specimen of a teratoma also. The marker of choriocarcinoma is going to be elevated beta HCG levels. So beta HCG levels will be elevated in pregnancy also, but massive increase in the beta HCG is seen in choriocarcinoma. And it is a tumor composed of a combination of both the trophoblastic cells, that is the cytotrophoblast and syncytial trophoblast. Okay. Then Rinke's crystalloids. Rinke's crystalloids are seen in Leydig cell tumor. Okay, so Rinke's crystalloids are seen in Leydig cell tumor, which also produces testosterone. This is the sex-cord stromal tumor, which produces testosterone. So they are going to be hormonally active. So their patients usually present with gynecomastia, or if it's a kid, it is going to present with precocious puberty, all those things. Okay, microscopically, if you see, this classical feature will be that of a Rinke's crystalloid. Then when we're discussing cellular adaptation hyperplasia, I mentioned BPH, remember? But I told it was not a pre-neoplastic condition, and it is going to arise from the transitional zone. And as such, the cause for BPH is going to be dihydrotestosterone. Don't answer it as testosterone. The cause for BPH is going to be dihydrotestosterone. So testosterone gets converted into dihydrotestosterone with the help of a 5-alpha reductase enzyme. So in order to prevent BPH and to cure patients with urinary complaints in BPH, they give 5-alpha reductase inhibitors like finasteride, right? Then Gleason scoring system is used for prostate cancer, and prostate cancer arises from the peripheral region. BPH arises from the transitional region, while prostate cancer arises from the peripheral region. The most common tumor in female, if they ask, it is going to be in a female genital system, at least it is going to be leiomyoma. So leiomyoma is nothing but a benign smooth muscle tumor. So origin is from the smooth muscle. The most common tumor is going to be the leiomyoma. Okay. So coffee bean nucleus, or at least grooving of the nucleus, you see in certain specific conditions in pathology. So let's give a recap for that. First thing will be a Brenner's tumor. So Brenner's tumor is going to be a surface epithelial tumor wherein there is going to be grooving of the nuclei, which gives a coffee bean appearance. First thing. Then we have granulosa cell tumor, which is a sex-cord stromal tumor. Okay, granulosa cell tumor also has coffee bean nuclei. Then we have papillary carcinoma of the thyroid. So nuclear grooving is one of the major features for diagnosing papillary carcinoma of thyroid. Third one is over. Then fourth one is going to be the LCH, which is Langerhans cell histiocytosis. Okay, LCH, papillary carcinoma of thyroid, Brenner tumor, and then granulosa cell tumor. All of this will have coffee bean nuclei or a nuclear grooving. Okay. So granulosa cell tumor, the one important thing I told was it is having Kohl-Exner bodies. So Kohl-Exner bodies are seen in granulosa cell tumor, while we get to see Schiller-Duval bodies in yolk sac tumor. So nuclear grooving is again a feature of granulosa cell tumor. Then one important question, Krukenberg's tumor, this was asked prior in MRB exam as well. So Krukenberg's tumor is nothing but metastatic tumor to the ovary, which usually occurs bilaterally. It is via transcoelomic spread. So via the peritoneal fluid, it is going to reach up to the ovary and deposit. So what is the primary for this Krukenberg's tumor? Usually it is from the stomach or the GI tract, colon also, or the breast lobular carcinoma. So as such, the morphology of the Krukenberg tumor cells are signet ring cells again. So remember, signet ring cells, two things I told already. One was lobular carcinoma of the breast. The other one was diffuse gastric carcinoma. Both of it had E cadherin mutation, right? So from those primaries, the signet ring cells can pass on through a transcelomic spread and reach up to the ovaries and cause a metastatic tumor there. Okay, so that is what we call as Krukenberg's tumor. So the question was, what was the primary? So most likely primary was asked the question. Okay. Next, just 2-3 things about papillary carcinoma, thyroid alone I'll tell. So papillary carcinoma of the thyroid is going to be the most common thyroid malignancy. Younger age group, already I mentioned it is quite associated with the risk factors, radiation exposure. So any repeated chest X-rays can result in this radiation exposure and can cause papillary carcinoma thyroid in predisposed individuals. So the mutation associated is BRAF mutation here again. Other than that, we have red PTC rearrangements. So the diffuse sclerosing variant and the tall cell variant of this PTC is having worse prognosis. There is presence of samoma bodies and then this orphan Annie eye appearance. So orphan Annie eye appearance was again asked as a MRB question previously. So orphan Annie appearance is nothing but the nucleus of the PTC cells are going to appear empty. Okay, just like a hollow, it is going to appear, and that is actually an artifact. During tissue processing, the nuclear material gets wiped off, and only the chromatin at the surrounding of the nuclear membrane is going to be present, giving an empty-looking appearance of the nucleus, called as orphan Annie eye appearance. So orphan Annie eye appearance is seen in papillary carcinoma of the thyroid, along with that nuclear grooving, which we saw now, coffee bean nucleus, right? Nuclear grooving is also a feature. Then any papillary carcinomas, I told, samoma bodies will be present. Then regarding follicular carcinoma of thyroid, I told FNAC cannot distinguish between follicular thyroid carcinoma and adenoma because we cannot find vascular or capsular invasion based on FNAC. So for that we need histology. Okay, so only on histomorphology we can define follicular adenoma and a carcinoma. Then coming to medullary carcinoma of thyroid, again, the origin of this cell, medullary carcinoma of thyroid, is not follicular cells, it is parafollicular C cells. So any C cell hyperplasia can predispose to medullary thyroid carcinoma. It is as such associated with MEN2 syndrome. So we know MEN2A and 2B syndrome, both MEN2A and 2B are associated with medullary carcinoma thyroid. And there is going to be elevated levels of serum calcitonin, and this serum elevated calcitonin can form ACAL, amyloid cal. Okay, so amyloid will be present in the stroma. So the only cancer which has amyloid in the stroma is the medullary carcinoma of thyroid. So amyloid can be stained with Congo red stain, giving an apple green birefringence on polarized microscopy. So MEN syndrome, we have MEN1, MEN2, and MEN2A and MEN2B syndrome. This needs to be just marked up. So MEN1 syndrome is also called as Wermer syndrome. And here we have all 3 P's which are involved: parathyroid, pancreas, and pituitary tumors. So parathyroid, pancreas, starting from here, pituitary, parathyroid, and pancreas tumors. Then MEN2A is going to be called as Sippel syndrome. And here it is going to be parathyroid, pheochromocytoma. Only one P is going to be retained. Only the parathyroid is common for these two. So parathyroid adenomas are going to be there, pheochromocytoma and medullary carcinoma of thyroid. In MEN2B syndrome, it is going to be pheochromocytoma and medullary carcinoma of thyroid of MEN2A is going to be retained. They just removed parathyroid adenoma, but they added mucosal neuromas and marphonoid habitus. Okay. So the gene for each of this will be MEN1 is going to be MEN1 gene, then MEN2A is red gene, while MEN2B is also red gene. Okay. So this red gene is the same thing which is associated with medullary carcinoma, sporadic tumors. So we have tried to cover the maximum MCQs. We were not able to cover hematology. If there hematology, that's it. They have not asked much questions except for certain areas of anemias and Hodgkin's lymphomas. Burkitt lymphoma was asked. So just go through that. hemophilia. So these kind of major questions were asked. So I'll send the highlighted points like this, just like the now I underline, no. So same thing I'll do for hematology, and I'll send it in the group by tomorrow. So if there is any other questions, you can ask now. Any questions?
Thank you, ma'am.
Sorry, I had to rush up because there was no time.
It's okay, ma'am. It's crisp and clear, ma'am.
Thank you. So if we are done with the session, we can close it. Thank you, everyone. And all the best for your exams. You'll all do it well. They'll ask basic questions only. At least seeing the options, you'll be able to answer. Don't worry.
Thank you, ma'am.